समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Thank you. Good morning and happy to welcome you all on behalf of ACS 2025 Organizing Committee and APM, and happy to welcome our teachers and all speakers and our friends, chairperson, experts and all delegates and those who are watching us online. I'm sure that there is going to be the good interaction and we'll have a carry home message. Thank you very much once again. I'd like to invite Dr. Tarun Madan for his first talk, and for that I'd like to invite Dr. Rajesh Hyderabadi to chair this session. Thank you. Dr. Nirav, yes, please join us as expert. And I think meanwhile Dr. George Joseph will join us. Good morning everyone. Today's topic is new modalities for acute DVT management, pharmacomechanical lysis. DVT is a very important subset in today's medical context. It's very important to treat this disease very early, else we can get a complication in the form of a deadly disease called pulmonary embolism. And the late complications of DVT are venous hypertension. Slide is not moving. So late complications are venous hypertensions, which can lead to secondary varicosities. If we treat it early, the symptoms are resolved very dramatically. And some people use temporary cable filter along with the lytic and pharmacomechanical therapy. So lysis can be pharmacological or it can be mechanical, or both can be combined together. So there's an excellent system available in the country nowadays, which is called AngioJet. It's a thrombectomy system designed to effectively remove the thrombus, aspirate it, pulverize it, and decrease the complication. What are the benefits of this system? There's a quick restoration of flow, which improves the vessel patency, target lesion visualization. There is very less distal embolization, and you can treat the thrombus of various ages with this machine. This is a console on the left-hand side, and this is a catheter, which is called Zelante. It's a 8 to 9 French compatible catheter, which works on the principle of Bernoulli. As the velocity increases, the pressure decreases, and you can pulverize the clot and aspirate the clot. So this machine has a propeller which rotates inside with very high speed, and saline jets are coming out of the nozzle, and then which breaks the clot into small particles. And then there is an aspiration port just behind the saline port, which aspirates the clot. The catheter is selected on the basis of location of the clot, whether it is in the femoral, whether it is in the iliac or in the IVC or in the pulmonary artery. And then volume of the thrombus decides whether we can give a pulse therapy or a lytic therapy. In the power pulse therapy, physicians infuse a fluid inside the thrombosed vessel, which is inside the thrombus. You infuse a tissue plasminogen activator or whatever lytic agent is available with you. Normally we use Actilyze. We can use tenecteplase and urokinase if there is a cost constraint. And in the thrombectomy part, high velocity saline jets are creating a low pressure zone at the catheter tip, which is as per the Bernoulli's principle, which allows the aspiration breakup and removal of the clot. So these are the different catheters available: Zelante, Solvent and Solvent Omni, but in the DVT we use Zelante catheter. This is a patient who had right leg DVT, so patient is made to lie in the prone position, so this is the right leg, and we take popliteal venous access under the ultrasound guidance, and then we do an angiogram which shows the superficial femoral vein is full of clot, and the iliac vein is again external iliac vein, common iliac vein is totally occluded and full of clots, and these are the collaterals from where the blood is going up to the heart. This is how the patient is made to lie in the cath lab. Patient is in a prone position, and in the left popliteal fossa we have done a puncture. This is a 8 French sheath through which the O35 wire goes inside, and then you do angiograms angiogram shows the presence of clot in the superficial femoral vein. You can see above the popliteal vein there is no flow, it is totally occluded. And then you aspirate the clots. These are the clots which are aspirated, and then this is an infusion catheter sometimes you use, which has multiple side ports to infuse the drug. This is how the popliteal venous access looks, and when you leave the catheter in place, you just make it a coil and then tie the catheter. So this was the you can see external iliac vein, common iliac vein, the wire is going up into the IVC. IVC is also occluded, and there are big collaterals from the lumbar vessels. And this is after few passes. You can see now the common iliac vein and the external iliac vein is totally visualized, and there is a good flow to the inferior vena cava. And then the next day, after the complete course of lytic therapy, the patient was made to lie in the supine position. So what we were seeing on the left side now comes on the right side, because now the patient is supine. So this is common femoral vein, this is external iliac vein, and this is the common iliac vein. Absolute clearance of the clot, and you can see the venous valves which are patent. So there is a prompt symptom resolution, very less chances of late venous valve failure or incompetency. So this is a catheter which is 8 French compatible. You can give contrast injection through the side port of this catheter, and you can exchange it over a multiple wire. So this is a over the wire system. Again, this is a 53-year-old male who had massive DVT in the left upper limb after some strenuous exercise, which is called muscle bridge related subclavian venous injury. And you can see the left axillary vein, subclavian vein was totally occluded, and multiple collaterals can be seen going through the axillary area. And then this angiojet was deployed from the brachial venous access, and lytic therapy was given, followed by subclavian angioplasty because there was some stenosis in through the proximal part of subclavian. This is a angiojet which can be rotated 360 degree, and in the different areas aspirations were carried out. And once the whole clot was removed, we did a balloon angioplasty into the proximal part of subclavian vein, and then in the last part we can see the good flow was established from the innominate into the subclavian vein. And this patient had received a stent in the common iliac to right external iliac vein for May-Thurner syndrome, which is a syndrome in which the artery compresses the vein. And this patient had a stent failure because the stent was totally occluded. Now you can see when you inject from the common femoral vein, we did a angiojet. This is a 2 ports of angiojet. From this one radio opaque marker, you can rotate, and then you do balloon, multiple aspiration cycles, and then lytic therapy. And once everything was done, the flow was established. So because this is a low flow circulation, the failure rates are higher, but there is no other option. So this patient received stent, and then after the stent failure, this patient received a angiojet therapy, and after the balloon angioplasty, good flow was established in the iliac vein. So this is the last shoot, which shows a good brisk flow, antegrade. So similarly, pharmacomechanical thrombolysis can be performed for the pulmonary embolism. Blood flow is established immediately. There is a thrombus burden which is reduced, and hemodynamics are improved in the form of normalization of pulmonary artery pressure and increased and improved oxygen saturation level. So this is a left pulmonary artery in which we can see there are multiple clots. Angiojet was deployed, thrombectomy was performed, and then the last cine we can see good resolution of the clot into the left pulmonary artery. Again, another patient with left pulmonary artery thrombus. Final pulmonary angiography reveals good recanalization and hemodynamics improved. So small clots can embolize distally, but they can be managed with the help of lytic therapy. There is a very small risk of cardiac arrhythmias because there is a fluid imbalance in the patient. We have to use systemic heparin along with, because we are using intravascular hardwares. Because this is acting on a pressure-based system, so there is a transient hemolysis because of the breakdown of RBCs, and the patient can have black urine or hemoglobinuria, which should be monitored with proper hydration, and if required, blood transfusion should be given. Thank you so much.
Thank you very much. And
questions. And then
Thank you, Tarun bhai, for an excellent presentation. What percentage of these cases would you be putting an IVC filter prophylactically, or is it rarely indicated?
if there is a free floating clot in the common iliac vein or the inferior vena cava infrarenal part below the renal veins and up to the renal veins also, then we should put a filter either in the suprarenal part or the infrarenal part.
For pure iliofemoral DVT, you would not be using a filter routinely?
There is mixed review across the world, sir. Some people they use in every case, but some people they do not use because then removal of filter is very, very important. Like you can't let the patient go with the filter. So if you have a good follow-up, you should put a filter and then call the patient back for removal of filter also.
Second thing is if you find a May-Turner syndrome as the cause of DVT on the left side, would you be stenting at the time of pharmacomechanical thrombolysis, or you would like to wait for a few weeks?
Generally, sir, we allow the venous compliance to get better after 2 to 3 weeks and then call the patient back again and then do a repeat Doppler or CT venography. And if availability of peripheral IVUS catheter is there, we do a peripheral IVUS catheter to look for any web inside the vein or any area of constriction, and then we do a stenting. And these venous stents are dedicated stents, like we should not use commonly available large diameter stents. Only dedicated self-expanding venous stent should be used, like Vinovo or sinus stents.
How much is the failure rate after you do this intervention, venous stent?
15 to 20% failure rates, because it is a low flow circulation. So anticoagulation has to be very aggressive. Usually we give rivaroxaban to all these patients, 20 milligram once a day. And if there is a high prothrombotic burden, we combine it with aspirin also, because we have put a stent.
How long do you give rivaroxaban?
Rivaroxaban, if there is a stent, it has to be given lifelong. And if it is a first episode of DVT, maybe 6 months to 1 year. So normally any DVT as per the guidelines up to 15 days we can use, because the thrombus after the 15 to 20 days becomes more organized and it is not amenable to lytic therapy. But for mechanical lysis we can do up to 1 month also, 1.5 months.
And dose of the actylates?
Sir, actylize we use generally 1 milligram per hour, sir. 1 milligram
Locally or?
to be infused inside the vein, inside the thrombus per hour. So we use up to sometimes 60 milligram, that means more than 2 days, sometimes 100 milligram, maybe 3 to 4 days sometimes.
With heparin or?
Along with heparin, because the lytic will lyse the clot. It will not prevent the further development of clot. So anticoagulation has to be given to prevent the development of clot.
Excellent lecture, Tarun bhai. For pulmonary embolism and large thrombus in the proximal pulmonary arteries, now penumbra is also available. So
Yes, sir.
what do you recommend? I mean, do you angiojet or penumbra, or which are any data?
Better than penumbra, there is another system which is available from Inari pharmaceutical, means Inari company. There's a clot reaver.
Yeah, so
So
those kind of device is
clot
better
reaver
or-
is better than angiojet, sir. Yes, sir. It is used in arterial thrombi also, because the other two catheters which were small, Omni and the second one, they are used in arterial system also.
So among the penumbra and this system, when you will choose a penumbra?
Sir, penumbra is a purely a aspiration catheter. You cannot give any lytic therapy through that. It is just a wide bore tube which helps you to suck the clot. So I do not have any personal experience of penumbra as of now. So I have used only angiojet or the simple guiding catheter to aspirate the clot,
And
if the patient is not affording
And
for
risk of
angiojet.
hemolysis in practice, how many cases you have seen?
Maybe, sir, in around 30 to 40% cases, hemolysis happens.
So
You have to be very careful in the hydration part. Otherwise, the patient can develop acute renal failure.
thank you, excellent. Yeah.
Sir, angiojet is costing around 2 lakh rupees. And the actylize is costing around 50,000 rupees, 50 milligram. So the overall therapy for one case of DVT would be somewhere around 3 to 3.5 lakhs.
Thank you very much, Dr. Tarun, and I
Thank you.
request Dr. Hyderabadi to felicitate Dr. Tarun.
So for the next talk, I would request to chair the session Dr. Jagdish Hiremat sir, Dr. Tarun Dave to chair the session. Experts for the same session are Dr. Sharad Jain, Dr. Shaurin Shah, Dr. Dinesh Joshi, Dr. Pratik Rawal. Please come on the dais. Would request Dr. Ajay Swami to please present his talk, Navigating Coronary Circulation, the Role of Physiological Revascularization in 2025. Thank you, sir.
First of all, I must thank Jayesh and the whole team of ACS for giving me this privilege of speaking to all of you. Second, my salutations to my teachers, some of whom are in the audience and some of whom are not. For the next 30 minutes, I have the daunting task of trying to summarize what physiology in the cath lab is today and what it's likely to be tomorrow. So this is a talk that will go from the basics to where the rest of the world is right now. These are my disclosures. So the angio is not playing. It doesn't matter. This is basically a multi-vessel disease, and the whole point, it says cannot play media. So it was playing there, but it isn't playing. It doesn't matter. What it shows is a multi-vessel disease. It shows disease in all the three vessels. And we needed to decide which one to actually pick, which one needed to be intervened in this patient with angina. Location of disease in a patient with angina can either be in the epicardial vessels, which we assess by our FFR. It could be in the microvasculature, which we're supposed to look at IMR, and the total picture is given by CFR. The problem is that the other two are not available to us, and it's not always easy to infer what problem the patient has and what has brought him to us. Now, the history of coronary physiology actually parallels the history of coronary intervention. And it begins in 1974 when canine studies showed that if you occluded the circumflex completely, the perfusion in the circumflex territory was preserved at rest. But when we increased or caused hyperemia, at that time we would get ischemia in that particular territory. And vasodilator stress testing then began and started to be researched. And when Grunzig and friends realized that yes, an obstruction can be relieved, he battled this problem for a while. How do we know which obstruction is significant and which is not? And at that time, they only had resting pressure and resting flow. And even then, he recognized that the resting gradient is far from enough. But unfortunately, it is all that we have with us today. In the 90s, the relative CFR, which was known as FFR in patients with a significant epicardial stenosis, this concept came to light. It was realized that this was less impacted by physiological factors. The Doppler wire was introduced in 87. What was normal wasn't very clear, but in 91, the pressure wire came. And after that, coronary physiology has progressed a great deal. Pills, Nicopiles, and Bernard de Bruin worked and looked at the diagnostic accuracy of FFR against exercise testing, thallium scintigraphy, and stress echo, and came up with this ratios that we had. That means the ratio of resting flow to hyperemic flow, and a surrogate marker of that as the pressure difference at resting and at hyperemia. This is what the underlying principle is. Essentially, flow is pressure divided by resistance, and flow can thus be changed either by changing pressure or by changing resistance. And if one can fix the resistance or take away the resistance, the difference in pressure will then be reflected by the difference in flow, right? They are basically the same. Thus the FFR is the maximum achievable blood flow in a stenotic artery divided by blood flow in the same artery without stenosis, and this is how we do it with a pressure wire. These are all questions that have been answered, but we'll quickly go through them, whether it assesses stenosis completely, whether FFR-guided intervention compares, whether it predicts the natural history of coronary artery disease, can it be used as an endpoint, and what is our current treatment strategy. Now you look at angiogram, and this is a patient who's got long moderate stenosis in the proximal and mid LAD and something that looks like a subtotal occlusion of the right coronary artery. But when you do the FFR, you see that the RCA FFR is 0.86 and the LAD, which looks borderline, is actually 0.69. So one would have looked at this RCA and stented this and then forgotten about the LAD, and the patient would, his angina would not have got relieved. It also accounts for the size of perfusion area. The same severity of stenosis in a large perfusion area gives us an FFR which looks like 60%, gives an FFR of 0.6. The same stenosis severity in a small perfusion area, which looks like 60%, is an FFR of 8.5. So this accounts for the difference in perfusion areas, not just what we see as stenosis. And also in case there are collaterals in the same territory. So this accounts for stenosis severity, biocardial territory and viability, and collateral perfusion. It guides the diagnostic and the procedure itself. Now we know that angiography underestimates or overestimates the severity, and this is drawn from FFR studies which looked at what happened when the stenosis was, say, 91 to 99%. 4% of these were still non-obstructive. When it was 71 to 90%, 20% were non-obstructive. And even more interesting, when it was 50 to 70%, actually 35% of these were obstructive. That means even in patients in whom we label 60% stenosis, nearly 1/3 of these are actually stenotic and causing ischemia. So this leads to reclassification. So this was tested in a study, 4 studies, in which they did routine FFRs in all vessels that had more than 40% stenosis. And they found that there was a percentage change in the strategy nearly 40% of the time, 26 to 40% of the time. It also showed, R3F showed, that it was safe to pursue a revascularization strategy that was different from what the angiogram showed. If we based it on physiology, it was safe and it was effective. And there was a significant proportion of ACS patients as well in this subset. So even in ACS, if we use physiology to guide our procedures, we are going to end up with a better result. What about the natural history of CAD? You will hear lots of people saying, but still some of them are going to develop a problem. Yes, that's true. But astrology is better at predicting. However, FFR does have a role. Now this was FAME 2. They looked at FFR in all the target lesions and then randomized them into 2 arms. One arm in which medical therapy, if you look at down below, I don't know if there is there's a marker here. They looked at medical therapy and they looked at PCI plus medical therapy. Another arm, when the FFR was more than 0.8, even these patients were followed up. That means they were non-obstructive, but they were followed up. And they were followed up for 5 years. And models were made as to what happened. So this is a revealing chart. I'm going to show it in a graphical way as well. But if you see, once the FFR drops below 0.8, the event rate goes up to 30%. And as it drops lower, 0.1 to 0.55, the event rate goes to nearly 60%. But when the FFR is more than 0.8, the event rates are less than 10%. They are not zero. There are significant event rates even in patients who have non-obstructive lesions over the next 5 years. This is the difference between ischemia burden and atheroma burden. The long-term natural history of atheroma burden is worse the greater the burden of atheroma. The present diagnosis of ischemia is best given by physiology. How much ischemia does the patient have? Now, if a patient has ischemia as well as atheroma in a particular territory, that lesion is most likely to break down. And this is not a statistical model. This is an actual observation. And this is something that we all need to carry with us. This is the same thing shown in a graphical model, that as you see the FFR go below 0.8, the event rate for that individual lesion goes up. It's just that there are so many lesions which have a negative FFR, but the number of these outnumbers the obstructive lesions by nearly 5 to 8:1 in various studies. So the total number of non-obstructive lesions, their natural history is determined by the atheroma burden. The ischemia burden statistically is more likely to break down and cause a problem. I hope I was able to make that concept clear. Now, does FFR guided PCI lead to a better outcome? This also was shown by FAME, and yes, unequivocally so. And FFR guided PCI is far better than medical management alone. in the short term, intermediate term, and long term. This has also been shown in Syntax 2 that was published in 22 and then further evaluated thoroughly. They compared a historical group of patients who underwent CABG and then performed angioplasty in multivessels in Syntax 2, and physiology was used to guide this PCI. Compared with controls, they were followed up for 5 years, and what did they find? There was no difference in MACE in the Syntax 2 PCI and the matched risk CABG patients. This was a pre-specified analysis. That means if you matched the risk of CABG and similarly matched risk of multivessel PCI and did them, there was no difference out to 5 years. This was very, very different from the Syntax 1, obviously. And at 5 years, the MACE was similar between the PCI and the Syntax 1 CABG groups. This had improved and durable clinical results when compared to predefined patients. But there was a significant difference when we compared, and this mirrors the difference in Syntax 1 between what the CABG group and the PCI group was. That means if you look at 10 years apart, our multivessel PCI results, even when done without whatever is available to us today, if they were guided by physiology, you're able to match the surgeons out to 5 years. What about FAME3? This was a trial which everybody said was negative. But remember, at 1 year it showed non-inferiority. But when you look at 3 years, there's no difference in the composite of death, MI, and stroke between the FFR-guided PCI versus CABG. And in this trial, post-PCI physiology was measured, and they found a mean of 0.89 post-PCI, which was grossly inadequate as far as proper or completeness of revascularization was concerned. So even when you had residual ischemia, I'm going to show you some examples for that, this was still much better, or it didn't show any difference out to 3 years. This is what is the same thing in a different slide. Thus, the concept of FFR-guided revasc is based on well-structured and consistent RCT data. Ideally, all coronograms, angiograms for chronic stable angina should be done. Intermediate lesion in single vessel disease with unclear symptoms, you're not sure does he have symptom or not, FFR is an excellent objective way to decide whether the patient has ischemia or not. Almost every single multivessel patient who presents with angina must be interrogated. ACS patients in non-culprit vessels, I have not discussed this in detail because that is an entire chapter in itself. But suffice it to say, the current the mass of evidence suggests that if done at the appropriate time, even non-culprit vessel physiology-guided revasc is as good, if not better, than angiogram at a cost of a fewer number of stents being implanted after PCI to predict outcome. And this is the elephant in the room, that if you use post-PCI physiology, you'll actually be able to predict, in my opinion, probably slightly better than imaging itself. Now, when should we not use ischemia? When should not use FFR? If you have typical angina and ischemia or non-invasive testing in a patient who's got a 90% stenosis, you don't need FFR pre in that, but you should do it post. Culprit vessel of a STEMI, it's very, very difficult to get microvascular dilatation in patients who have got STEMIs for multiple reasons. And if FFR is not going to change the treatment plan for whatever reason, he's going to go for, he's not a candidate who's going to survive for very long, etc. Now, there are certain limitations that we must remember, and physiologically, this is the single most important limitation. An FFR of 0.77. Remember, in FAME1, actually 7.5 was the cutoff for when defects would begin to appear in patients who had ischemia. But 0.8 was chosen as a safety for FAME2 because in FAME1 we were using right atrial pressure as well as aortic pressure to decide that it was ischemic or not. FAME2, all the other pressure measurements were done away with. Now, when you have an FFR of 0.77 and you have got normal microvascular function, and the coronary flow reserve is high, that means there is a great difference between the resting flow and the hyperemic flow. In that case, 0.77 means almost no ischemia. It can be left alone. But in somebody whose coronary flow reserve is very low, that means he is unable to raise his hyperemic flow for whatever reason, in that case, this becomes highly important, extremely important, and it's difficult to interpret the ischemia burden in these patients using FFR alone. What are these subsets? Those who have diffuse distal disease, those who have got severe microvascular disease, somebody who's got severe LV dysfunction with raised LV EDP, somebody who has gross LVH, somebody who has aortic stenosis, because the intramural pressure is so high that the coronary flow reserve itself drops. So one is not able to get a proper hyperemia. It's important to recognize these limitations in our daily life. What about tandem lesions? Yes, left main is another special subset, and left main is not one subset. If these angiograms will pay, you can see you can have left main with only shaft disease, you can have left main, distal left main with single vessel disease, you can have multi-vessel disease, or you can have bifurcation disease with downstream stenosis in both. How can physiology help us in this? Now, this is difficult to estimate angiographically because there isn't a normal segment to compare it with. And it's extremely difficult to decide how significant the left main disease is when you have downstream disease as well. But can we bring some, common sense into this and some physiology into this? Remember, Excel and Noble, the two largest left main trials, just used angiography. They didn't use physiology, actually. Now, this has special challenges, but we do know that intracoronary adenosine is unsuitable. A downstream lesion is going to interfere with our proximal values. And do we measure it into both, into one? What about the evidence base? Now, they're mostly observational studies, and it's underpowered in observational studies. But there have been elegant studies in which pressure wires were passed into both LED and LCX, and serially balloons were inflated. So you produce a stenosis in the left main with the balloon, and then gradually increase the stenosis in the LED, and go on measuring the pressure wire from both LED and LCX, and see at what stage does the LED disease interfere with the FFR of the circumflex when there is no disease in the circumflex. That's the model. Now, it's shown that as the severity of stenosis in the LED is increased by inflating a balloon there, the circumflex FFR becomes less and less reflective of the left main disease. And this becomes totally unreliable once the LED disease brings the FFR down to 0.6. When the combined FFR of the left main and the LED comes down to 0.6, then the circumflex FFR crosses over into being totally unreliable, and it doesn't reflect the stenosis in the left main anymore. This is the same thing that you see on a graph. As you go on increasing the stenosis in the LED, once the balloon inflation and this FFR comes down, the circumflex FFR in the non-diseased segment starts going up. So the increased flow in the circumflex will ensure that your FFR is actually negative. So it's no longer significant, or it's no longer reliable as an indicator of the presence of left main disease or not. So if you measure the FFR down both, then you can easily come to certain conclusions. Remember, this takes into account whether it is infarcted or otherwise as well. So this is a very, very useful there is interaction with RCA stenosis as well. If the RCA has significant disease and there are collaterals going off, one must take that out of the equation before making the measurement in the left main. So meticulous technique, use the correct drug, use the correct route, equalize properly in the aorta, and ostial damping, make sure that the guide is outside. It doesn't really matter, you don't have to be hooked. The guide just has to accurately reflect the aortic pressure. So if it's isolated left main disease, measure into either daughter vessel, it's reliable. If the left main is diseased and one daughter vessel is diseased, measure it non-diseased. It is reliable as long as this FFR into the diseased vessel is more than 0.6. And if both daughter vessels are diseased, then you know that you have to fix everything. These are the studies which we will not go into, but it has been shown that deferral of the left main based on a non-obstructive FFR is absolutely safe. This has been shown out to 2 years, and I think that's as good data as you can make it. In any case, you're going to keep these patients on follow-up and keep following them up in the long term. What happened to our patients? This patient was simple. She had a discrete lesion in the left main, and that was fixed. Post-PCI physiology was 8-7 into both. And this is the LM-LED crossover stent. A pot was done, and then the FFR into circumflex was measured. That was 0.88, so that was left alone. And this patient had diffuse disease in all three. So she underwent a DK crush, angioplasty, and revascularization into both. This is another one in which it looks like diffuse disease, but since the media cannot play, you'll have to just believe the figures. Just put one stent from the LM into LED, measured the FFR into both. The LED was 9.2, circumflex was 8.3, and it was left alone. Now, does it have use? Although this is old data, I assure you in India, I'm sure it's less than 6% of our patients who are undergoing physiology-based revascularization. Yes. And this is the other, as they said, disruptive technology. Non-hyperemic indices appeared in around 2009, 2010 after furious research, and initially they were thrown out of the room. The concept of the IFR is that there is one phase of the diastole from 25% into 5 seconds before the end of diastole in a patient with sinus rhythm, that during this time, the coronary microvasculature remains constant. The resistance given by the coronary microvasculature is constant. There is almost no resistance in this time, and the PDPA ratio in this interval is directly proportional to the flow for the same reason. So since flow occurs only in this phase of diastole and the resistance remains constant, the flow is reflected by the difference in pressure. And that is how we use this diastolic ratio as the PDPA ratio in this interval, being a surrogate marker of flow during maximal hyperemia. This is the wave-free period. There is also some suction which takes place during normal cardiac cycle, and this is eliminated in this time of continuous flow. And velocity is higher because flow is in diastole, so it's easier to discriminate. The phasic resistance in cardiac cycle thus is maximum in this time, and so you can see how these multiple indices have emerged, which are either only diastolic, IFR, DPR and DFR, or whole cycle, that is the resting PDPA, the FFR and the RFR. And these are the non-hyperemic indices that we use. These are an alternative to FFR. They are cheaper, quicker, fewer side effects. All indices use the ratio between the distal coronary pressure and the aortic pressure. This is what we've already spoken of. There are also angiography-based and CT scan-based FFRs that we need to look at. Proof of concept was with the Define Sweetheart and the Define Flare. It's been shown out to 2 years that the event rates are not significantly different if we use these to defer lesions. Remember, this was the most important outcome that you get. There is some data emerging that actually we are not measuring ischemia adequately with the non-hyperemic indices, but they do have their uses, especially when you have tandem lesions and you have diffuse disease. They are exceedingly useful to decide what lesion needs to be fixed. 20% of the time you get discordant values in these. The Americans still swear by FFR. The Europeans say they are equivalents. They are sensitive to variation of heartbeat. So sometimes patients with atrial fibrillation, etc., they are not so easy to always place reliance on. Both studies, they have fewer stents in the IFR group, but we don't know whether this because the IFR is less sensitive or oversensitive FFR. It appears that we are actually underdiagnosing ischemia with IFR, but it seems that it doesn't make so much of a difference out to clinical events. Out in the long term, major ischemia will always be diagnosed by both. There will be subtle differences in these, especially depending on which segment of the coronary tree we interrogate. Especially proximal LAD, we have maximum discordance, but it is not so large as to produce a difference in major event rates or clinical events. Tandem lesions, IFR is definitely better than FFR because the calculations are so complex and so difficult that it's always better to use a serial pullback. There is also DPR, DHR, whole cycle ratio. As far as, and there is contrast FFR, where FFR is, adenosine is actually replaced by contrast. They use a cutoff of 0.83. This was, furiously investigated about 8 years ago, but it's found that it doesn't have so much of a difference, and it's just a simple way of coming to the same thing. Less than 8.3 is always positive, perform PCI. 8.4 to 8.8, repeat the FFR with adenosine. And if it's more than 8.9, it's supposed to be negative and defer it. This is the RFR, which is available in the Validate Heart Failure study. The QFR, the vessel FFR and the FFR angio, 2 words on them. QFR is an angiography-based 3D software package where the flow equations reconstruction of the coronary tree is done with, you have 2 projections at least 25 degrees apart. The flow is derived from, initially was from the Timmy frame count. Newer software, you don't need Timmy frame count. You just use the intensity of contrast. The contrast flow velocity is derived using this frame count or the intensity of contrast. They estimate this velocity, and it doesn't make a difference whether you do it at rest or with hyperemia. This is what you get with the QFR. There is a favor pilot and a favor 3. There's also the vessel FFR, in which the pressure drop across the stenosis is calculated using physical laws, viscous resistance and separation of loss effect. But here you need the aortic pressure to be measured. The FAST study validated it, and this is an example of the VFFR. There are also imaging based modalities which are now appearing. They were offline, but now an online or a real time version is beginning to be tested in clinical trials. The CT-FFR is probably the most exciting advance in this phase, and I think this is something that we'll all have to learn. They actually look at the volume of myocardium subtended by a particular vessel, estimate what should be the flow there, then use 0.24 as an equation to generate hyperemia, and then see what should be the flow and actually measure what is the intensity of contrast. And you can use this to create a map of the coronary like this. You get a narrow stenosis, you can do a virtual stenting and actually see whether it gets better or not. Now, resting coronary physiology is thus now known to be a class effect. It's not an individual thing, and it's appeared in guidelines across, and a hybrid FFR. Now, post-PCI FFR is something that is very, very exciting. I've picked up this particular slide because this shows that we've known this for a long time. This is from the bare metal era. When the FFR after stent deployment was 0.75 to 0.8, the restenosis rate was 29.5%. Remember, at this time, this was a 6-month restenosis because this was a bare metal era. And when it was greater than 0.96 post-PCI, it was 4.9%. And this is reflected in multiple studies. Prognosis is directly related to long-term events in multiple studies. But can we use it to optimize the results? Yes, we can. Profit FFR showed that if you looked at FFR guided PCI at the end and you looked at angiography guided PCI, you had a half the rate of target vessel failure or target vessel revascularization at the end of 1 year. No significant differences as MI on death, but target vessel revascularization could be decreased. That means you did the FFR at the end, you found if it was negative, you actually did a pullback, found where the problem was and then fixed it. So this is just a case example. I think the computer is not going to run. Essentially, this is a, the slides are not moving. Can we get some help? Some do and some don't. So this was a primary angioplasty to the LAD, and then we brought him back to the table to see. Yeah. So this was the post-PCI. We brought him back to the table because an intermediate stenosis to the OM, that was negative. But we said, okay, we've opened an F wire, let's float it down the LAD. This was about a week after. And when we did the FFR to the LAD and the pullback, we found a sharp step up, 0.89, and this was at the edge of the stent. So we said, hey, what has happened? We've just done a stent about a week, 10 days ago. Why is there a step up there? So we went ahead and did an OCT, and you'll see in the OCT that as we come closer to the edge of the stent, I let it run. You can see there, you can see an edge dissection that was not picked up. This was done at the time of the primary, and that was exactly where the step up was. So we went ahead and fixed that with another small stent, this time looking at the size. And again, if this slide will move, my advice to anybody who has videos is to bring your own computer. This is the RFR at the end, the post-PCI pullback. So it's gone from 8.7 to 9.7. So you see that you corrected what stenosis there was. And when you did an imaging, you found a small edge dissection, which wasn't diagnosed on the angiogram. And this is post-PCI. The same thing. And after the second stent, that's the imaging. This is not required. That's the final angiographic result. Yes. So this is just an example of how we do this. This is a complex left main bifurcation with the CTO of the RCA. We first fixed the RCA CTO and then worked on the left main bifurcation. Quickly run through it. This is a rotatripsy of the left main bifurcation. We'll not go through all the steps, it's not really required. We finish with the DK crush, and at the end, yeah, that's our final result. And then you finish this with a post-PCI FFR and an RFR. And you see that our FFR to the circumflex is 0.97, the RFR is 1, and to the LAD is 9.5 and 9.5 respectively. And this is tandem lesion requirement is not there. Will it work if I escape? This was just to show how to approach a tandem lesion. We had 2 lesions. Shall I show it if we have time? So you see this angiogram. So this looks like a subtotal occlusion of the mid LAD. There's an intermediate lesion in the proximal part. This doesn't look too tight in the proximal part. It's okay. So we said we'll fix the mid part and then we'll see. So the mid LAD was fixed. This looks perfectly good angiographically. And then you do a RFR and you find it is 7-8. Now you do a pullback. And you see the pullback is entirely at the ostial proximal LAD. So this has to be done after you fix the distal lesion. Sometimes it's difficult to make out where the highest delta is. You see that the pullback. So we did an LM LAD crossover. Did a pot case pot. And now you do the RFR pullback and it's 9-7. So this is how physiology can help you. And that's the final angiogram. Similar, multiple examples are there. This is a patient for whom we did a side branch FFR. Now you have a stenosis like this after you've done an LM-LAD crossover. Do we fix it or not? We have now used to, for every such patient, we use a pressure wire. We do it into the L circumflex and pull it back. In this patient, it so appeared that there was a pullback. So we just did a balloon, a plain balloon, and then remeasured it, and we are fine. And that's our final angiogram. This is what we did for our, since it didn't run the first time, you'll have to believe me when I just show you the FFR figures, that we did the FFR and we found the LAD, which was intermediate, was actually tight. So we did the pullback in the LAD, defined where the tightest lesion was, finished it off, and then did the post PCI FFR. So this is our pre-PCI assessment. Now we've also moved on to doing pre-PCI assessment with physiology. Now sometimes when you have tight lesions or you have a single lesion, you always assume that that's the region for the step up. But if you do have flow limiting lesions, in our lab, we have now switched to actually doing a pullback prior to doing the PCI. Because this will tell you where the pullback shows where the maximum delta is or where the maximum stenosis is. And sometimes you can be surprised and you go in with a plan of something and it makes you change your plan. It makes you think what you're doing. The one thing that is going to emerge in this is now going to be virtual stenting after this. That means we will do a pullback, we'll decide this is where we need to do, and we'll actually virtually stent it and then say, right, this is the result we expect. Then you fix it and then you actually see whether it's better and then go ahead. Essentially, and then post PCI, always interrogate so that you have got a clear idea that you have abolished stenosis. As I said, I do feel that it is a very, very strong indicator of long-term outcome. PCI aims to abolish ischemia by removing flow-limiting stenosis. It doesn't aim to predict what is going to happen in the future. What ischemia we have today is best told to us by physiology. What is going to happen in the future is a complex interplay of multiple things, among which the only measurable thing is the atheroma burden. Pre-PCI physiology will always tell us ischemia. It will identify patients who will not benefit, but we must recognize its limitations. Post PCI, this has important prognostic limitations and it's used to optimize results. The future, I think, is where we simulate the PCI and predict the results. Our wire-based indices still remain the gold standard. Recently, resting indices are encouraging, although the discordant results, one should be aware of the limitations of both of these techniques. If there are no tandem lesions, FFR seems better. If there are tandem, probably the non-hyperemic indices are better. The hybrid approach is the current standard of care. Contrast FFR, CT FFR are still to find their place, but CT FFR, I think, is the most promising technique for the future. Physiology rules as far as intervention is concerned. Thank you for your attention.
Thank you, sir.
Between RFR and FFR. So RFR is positive and FFR is negative. So what should, because usually we approach there. If RFR is negative, then we do the FFR. But still RFR negative, still we have to do the FFR for the ischemia as per your talk.
Yeah.
So then there is a discordance. RFR is positive, FFR is negative.
So if you work in the US,
Could you
they
please
will believe
repeat the question for the audience?
Yeah. So the question is, if you have a discordant FFR, RFR, especially with respect to a negative FFR and a positive RFR. If the RFR is negative and the FFR is positive, it is simple. It is ischemic, we fix it. What about the reverse? That means one has an RFR negative and the FFR positive. Is that right? RFR positive and FFR negative. So if you ask me, the FFR negative is probably more reliable, but this must be interpreted with the presence of distal disease. If you have got distal disease or you have a problem with the microvasculature, then you have to interpret. The whole focus of the talk was that. Because the FFR can be false negative if one has diffuse distal disease or has inability to achieve hyperemia. And in that situation, the RFR with a serial pullback might probably be better than FFR. So you have to see the situation.
Thank you, Dr. Swami, for a brilliant talk. We've known you as a brilliant operator and also a very strong academic mind, and it reflected in your talk today. So why do you think the percentage of FFR overall in India is just 6.1? What is the problem? If you feel that it has to be done practically for every patient and every post-PCI patient, then why is it only 6.1%?
And so this 6.1% was actually drawn from the US. In India, I'm sure it's less than that also. And this is the situation in US where it is mandated by the FDA that you cannot address a lesion unless you have proven ischemia. That means if you do not do an FFR or a stress MPI or something, you are not able to intervene in that lesion and not get sued for it. That's the situation in the US. So it's very sad, unfortunately. But this has multiple problems. This is because it's a very market-driven kind of a practice. It's not pushed much. And it's important to see the subset that we're operating in. There are some patients for whom you don't need FFR. But I mean, to be honest, I'm baffled. I really don't know. In my opinion, it should be used much, much more. Probably because the fear people have that we may end up deferring the lesion and we don't need to put a stent or whatever. But I don't know. I mean, putting all that aside, I really don't know. Yes, Dr. Chadda has some answer for that.
See, I very strongly feel nice to see you after a long time. What happens with FFR is that right from the beginning when the therapy came in, it was not given the kind of respect it deserved in the by all of us sitting here.
In the world?
I see, in the sense, in the world, of course, penetration is low, despite it being part of appropriate use criteria in US. If you put a stent without FFR, you don't get reimbursement. So that is the kind of legislation they have there. But what happens in our country and what I see when I move around is that people don't know how to do it because it's kind of taken for granted. They feel it's like a normal coronary wire. You take it out, put it and measure. I have seen wires being reused and wires being pushed here and there. Nobody looks at the EQ quotient, whether it's within 10, minus 10 or positive 10 or whatever. They just put it, and I have seen live cases being done in a manner in which the title should be how not to do it. And you are doing all this to come to the conclusion whether you need to stent or you don't need to stent. That is absolutely... So I personally feel that we need to re-educate, we need to give it the kind of respect. It's a good tool, but it has to be used in a given setting. People use it in critical lesions to demonstrate to the relative that it's a very tight lesion, now we'll stent it. People don't use it in intermediate lesions saying that, no, I think it is tight, I will stent it. So, I mean, we need to introspect, we need to move forward, we need to educate more.
Slightly a tangent question to you. After your so much vast experience, how many times you think visually you will go wrong? How many times FFR will change your visual decision after the angio?
So it depends very much on the segment of the coronary that we are interrogating. I think the proximal LED I will always interrogate because you're always surprised because you never know what you're going to find. The intermediate lesion that I showed you, 90% of the time it would have been left alone. But I've learned that proximal LED, if a patient has symptoms, it must always be interrogated. Small lesions which are in... That's...
I understood. Suppose it's a proximal LED. Would you rather stent it rather than doing FFR?
No, never. That I would never do. I do not think we should place anything inside the coronary without its having a definite You should be convinced in your mind that this is going to benefit the patient. Only then we put in a stent. I would never stent.
No, he's had other stress tests and stuff like that. So he's to the cath lab
So
with
if
the background.
there is no other lesion anywhere, if you're dealing with a single vessel disease or a multi-vessel disease, the situation is different. The first example I picked was that a patient comes with angina, you do a test, it's strongly positive, and he has disease in all the three. Now, you can't get away from the table without deciding what you need to do in that particular patient. You just can't say, I can do this, so I'll do this. This looks tough, so it's probably going to be FFR negative. That's the wrong attitude. What we need to say is, this patient has ischemia, this lesion is causing his ischemia, I know because of the FFR, I'm going to fix it, or if I can't fix it, I'm going to give it to the surgeon or whatever. But the decision that you need to, the question that you need to answer is, which of these lesions is causing ischemia that is producing symptoms in this patient? If you focus on that, I think you'll never go wrong.
Yeah, excellent talk. But I had a small question. You said that even if the FFR is, say, positive, and we assure the patient and the relatives that you don't need any interventions.
You mean it's negative?
It's negative. But they also have some about 5 to 10% of risk to
Yes, they
develop
do.
So how do you address these kind of subsets who may have these sort of a possibility?
So I think you have to send him to the nearest astrologer and who will be able to predict. But on a serious note, I mean, this is something that you accept. Somebody is going to have an event, is going to have an event. The thing is, we are very good at populations. If we have 100 patients who have got negative FFR, I know that 5 of these 100 are going to have an event at the end of 5 years. But which 5 it is, we have no idea. Now, that doesn't mean that you go ahead and fix all these 100. So to prevent those 5 and end up with restenosis in 10 of them, that is not acceptable. So we have to accept the limitations of what we are doing and convey that to the relatives.
That I think holds true for the entire medical science. For the simple, ours is a science of probability.
Yes, absolutely.
And we have to go by that. Ajay, couple of things. It also, say for example, a question was asked about the mismatch. But I think Sujong Park's paper, which mentions about the mismatch and the reverse mismatch, that the lesion looks extremely tight and yes, the FFR could be completely normal. It could happen very often in circumflex lesions. One question is that many times we come across the CTO and it is richly supplied by collaterals angiographically at least. How do you assess that this CTO is producing ischemia or not? That's the question.
So right now, the lab-based ischemias are not there at the place where we can assess in the lab the propensity of the CTO to cause ischemia. We have to resort to other things, either MBF, myocardial blood flow along with CT or with a stress MPI. And most important is, of course, patient symptoms. If he is completely asymptomatic and he's done more than 9.5 months, you have to really scratch your brain as to whether you need to do only this CTO. And as far right now in the lab, we still don't have good enough techniques.
So what values you expect to be that long-term free from the mess after post-PCI for different vessels of FFR?
It's a great question. And this is something on which there is no single answer. For the LED, it is about 9.2 to 9.4. For all other vessels, it's anything more than 9 is more than 0.9 is also good enough. But for the LED, if you do not, it should be more than 9.5 for the other vessels. For the LED, because of the 25% who have got the intramyocardial segment in the mid LED, it's very, very difficult to get a 9.4 or beyond value for the LED. So if you get 9.2 to 9.4, you're fine for the mid LED. For the others, you should get more than 9.5.
So do we come across the condition in which you have a myocardial breach and then you have a lesion just
at the edge of the breach.
The edge of the breach. So do you recommend to go ahead with the imaging guided or both, like imaging plus FFR guided?
Yeah, so Syntax 2 is a great trial. Syntax 2 actually looked at historical comparisons of CABG results in similarly complex patients and compared them with state-of-the-art PCI, in which they used a combination. They used physiology to decide which lesion was significant, and they used imaging in 85% of patients. So in that group as well, and they also addressed 80% of the CTOs. So in that group as well, if you have a significant myocardial bridge, this is one of the limitations that you must recognize of physiology, that it's a little difficult. the recognition of the bridge is exceedingly important, because if one puts in a stent into a bridge, the risk of failure is exceeding very, very high, out to nearly 30 to 40%, because of the mechanics of bridging. And it's been shown in CTO interventions that majority of CTOs are actually on the borderline or very close to intramyocardial segments. And then if you are able to stent away from the intramyocardial segment, you are likely to get a great result. And nearly 40% of stent failures in this subgroup are because of our inability to recognize this intramyocardial segment, and you end up putting the stent inside. Every senior interventionist in this room has tried to post-dilate a stent in the LED, which did not expand and ended up with a rupture, I assure you, at least once, if not more times. So that's a great question, and the answer should ideally always be with imaging, if possible.
Thank you. Sir, one final question. As Tarun sir said, that some patients with negative FFR will continue to experience coronary events. So, sir, is there any role of imaging in such cases, like identifying the vulnerable plaque? I mean, what if FFR is negative, but we identify a thin cap fibroatheroma kind of plaque by OCT? So, does it make sense to stent such cases? And, sir, my second question. In some cases where there is severe microvascular dysfunction, the FFR can be falsely negative.
Correct.
So, does it make any sense to combine FFR with indexing the IMR?
Yeah. So I'll take the second question first. We were actually trying to work with IMR before the RADI wire was taken off, and we were impressed by the amount of prognostic information one got from microvascular disease. So I think that's a great question. We still don't yet have an answer, but we do know that when the IMR is beyond 40 in acute myocardial infarction, the event rates are 17 times higher than if they are lower. And we also know that if you are ending up, if your IMR goes more than 30, in that case, the relevance or the false negative rate of the FFR seems to go up. But these are the only two things we were able to establish before the RADI wire was pulled from India. And your second question is, as I said, astrology is better because it's impossible to predict in an individual lesion. And if you see complete OCT, I have a complete analysis of that. In that, they found a 13% event rate in the FFR negative TCFA positive subgroup of patients in whom they interrogated every single patient. That means you have to stent 100 patients to prevent these 13 events. Not a single death occurred in those 13 patients. They were just non-STMIs in small branch vessels in different places. Are we willing to do that? I mean, as a community, we need to take a call. You'll hear a lot of people who say, no, we should stent it, and it's a TCFA, and it's this, and it's that. I think we need to take a call there. If there are some patients who are exceedingly, somebody who's 35 and who's running the marathon, who's got a very large and extensive TCFA in the proximal LAD, this patient is going to have a bad outcome regardless of what you do. You put a stent, you don't put a stent, you send him for CABG, you don't send him for CABG. The 5-year event rates in this patients who have got bad genes, who have got bad atheroma burden, their long-term event rates are going to be bad. You have to choose the best option amongst in this group. And just placing stents wherever you see TCFAs is, I don't think is the answer. But it's a personal journey which we all have to go through.
Thank you, sir. I would request Dr. Jagdish Shirimat, sir, to felicitate our honorable speaker. Dr. Jai Shah, please come on the dais to felicitate our chairpersons. And Dr. Sanjeev Prajapati to felicitate our experts. For the next session, I would request Dr. Milan Chak to come on the dais to chair the session. Dr. Jayesh Rawal, please come on the dais. Dr. Hemang Bakshi, Dr. Shalin Thakur as experts, Dr. Anand Shukla, Dr. Gajendra Dubey. And the next talk is about the art of rotablation and drug-eluted stents. And we have none other than the respected Dr. Padma Bhushan, Dr. A.B. Mehta, sir, who would be teaching us about art of rotablation. troubleshooting, and complex cases. Dr. Mehta, sir, please.
Well, I think, first of all, Shah and team, thank you very much for inviting me. It was a wonderful evening yesterday, and now I'm fresh. We're going to discuss about rotational atherectomy, the cornerstone of treatment. The question is that you are going to deal with a calcified lesion. That information comes when you put your foot on the foot switch and do a fluoro. Because the only non-invasive method that can tell you about the calcium is a CT scan, and the CT scan is not routinely performed before you perform a regular angiography, so that you are going to deal with the calcified lesion. That impression, that information comes when you put your foot on the foot switch and do a fluoro. And on the basis of imaging, the calcium could be superficial calcium, eccentric calcium, severe protruding calcified nodule, and a deep calcified lesion. Of significance and importance to us is a superficial calcium. The calcium which is closest, closer to intima, and that is the one which is going to create problem for us. And when you see a de novo calcified lesion, how do you assess this calcium is severe or not severe? Merely by angiography, then there are following methods. The mild calcium is one which has a specks of calcium and you find a little difficult to even see. Moderately severe calcification, when you see calcification when the heart is mobile. And the severe calcification is when you see the calcium even when the heart is steady and the calcium is on either side of the wall, what we call as the tram track calcium. That I think is severe. All right. When you assess the de novo calcified lesion, is the lesion functionally significant? No. Functionally significant, we heard just now from Dr. Ajay Swami that how do you assess the functionally significant lesion? Then I think we are entitled to continue medical therapy. Then go down and see, is the lesion complex like left main, triple vessel, syntax score more than 22, diabetes? Yes, high. Then I think there's a reasonable option is coronary bypass surgery. If not, and low, then PCI. The angiographic calcification, mild, moderate, and severe, we just discussed, but then I think sometimes you will require IVUS and OCT on the basis of IVUS and OCT, but that's not the subject of assessment of calcium today, so I would not dwell on to it too much. But I think that suffice it might say, the simplest way without the imaging available to you to judge whether the given calcium is to be treated by routine traditional management like with the balloon and cutting balloon, or it would require atherectomy. Now, that I think the simple method is, my principle is this, that when I take that, all right, I want to give a trial, take a lesion, pass the balloon, and about 12 to 14 atmosphere, you find it's dumbbelling and not yielding, then I think I have no hesitation to switch over to rotablation. In other words, now that we have a drug-eluting stent which has been able to produce the result in chronic stable angina, fairly equivalent to surgery, even in long-term basis, I think it is good that we all have to learn how to manage calcium and calcified lesions and conquer the calcium. Now, the bird selection. First, you try to judge what is the size of the vessel. And usually we prefer these days not debulking aggressively, but 50% debulking for the lesion modification, which we call as lesion modification, which I think is a 50% debulking. And therefore, see the size. And the largest possible burr you might need, that should be the size of your guide catheter. To give an example, 6 French catheter can accommodate 1.25 and 1.5 with difficulty, but 1.75 burr will require at least 7 French guiding catheter. So I think in case if you feel that you are likely to need 1.75 burr, right from the beginning you should take the catheter which is 7 French or 8 French. All right. What are the contraindications? When will you not do? You found there is a calcific lesion, and when will you not do? These are relative contraindications, mind you. In the expert's hand, this may not be contraindication. Avoid the patients with ejection fraction of 25 or less. Avoid. I'm not saying totally abandon. Avoid. The reason is this, that no matter what you do, there will be some amount of microvascular surging and some loss of myocardium, and that may be too much for a patient who has a 25% ejection fraction. Anyone who has a systolic blood pressure of 110, because rota is a spasm-provoking procedure. At the same time, it is associated with rota, there is sometimes fall in blood pressure, and this might precipitate a profound myocardial ischemia in the lesions other than which you are trying to address. If there are many more lesions in the other vessels, then I think it can create a hemodynamic crisis. Do not burn more than 2 vessels at a time, because the total amount of microvascular surge, anticipated microvascular surge, can be damaging one. Avoid lesions which are longer than 25 millimeter. Mind you, these are relative contraindication. I might be able to show you some cases which are more than 25. Lesions with the angulation in excess of 45, we have to do it very, very carefully. And I think undersizing the burr in those kinds of situations is very, very essential and even important. Vein graft, no, you should not do. If especially the old vein grafts which are thrombosed, I think it is a contraindication for sure. And acute coronary syndrome with a visible thrombus, clear-cut, large amount of thrombus. A mild thrombus is still not a contraindication. I think the tips and tricks now. First of all, rota does not require strong backup, not needed. But it does require coaxiality. If your guide catheter is not coaxial to the initial segment of the artery, for example, left main or right coronary, then I think you will not be able to achieve a good rotablation result. If the burr is more towards the inner curvature, that means the wire. If the wire is traveling towards the inner curvature, then I think the burring, in case if the perforation takes place, it would be either in the myocardium or in the septum, it's a left coronary artery, and it's unlikely to create a cardiac tamponade, which I think is a deadly complication. Now, I think not much attention has been given to wire bias. So I'll talk a word or two about wire bias. Wire bias is a thing which you can adjust. It's a stainless steel wire. So it's not a floppy wire. It's a very strong wire. And you can adjust the wire bias by either pulling the wire back, or you can adjust the guide catheter position, either rotate it or withdraw it or push it in. This, I think, people who are performing TAVI, transcatheter auricle the replacement, they know the importance of how to move the wire and bring it in the center of the aorta or to the outer curvature. So the wire bias is important. Moreover, if the wire is biased towards the lesion, then it is likely to burr the lesion. And sometimes when the artery is large and the burr is a little bit too small for the artery, then the wire bias can be profitably used to selectively burr the lesion. So either by withdrawing or rotating the guide you can achieve. And how to manage the distal tortuosity. This slide is not meant to show you distal tortuosity. Whenever there is a distal tortuosity, your wire should not be too much inside the vessel. Just 2 or 3 centimeter distal to your lesion is enough. Longer you go, like it will have a draw sheet or curtain kind of effect, because the artery could be curved and it could be soft, whereas the wire is strong. It's like a rod onto on the curtain, and the curtain takes the fold. And that kind of thing happens, you get pseudo lesions. The pseudo lesions are likely to burr the intima and media, and it can create even a perforation. 2, pseudo lesion also limits the flow in the distal segment, which is very essential. Important thing for you all to remember, that whilst you are doing rotablation, tell your partner, tell your assistant, keep on injecting small amount of fluid or a dye continuously to make a washout. If the washout takes place, you will minimize. Particle size that is made by rotablation, 70 to 80% of the particles are 7 microns or less, but some particles are bigger. Now, therefore, if you're with the correct burring technique, If the particles are small, they will be washed out into the reticuloendothelial system because it will go to the capillaries and though eventually go to the spleen. But if the particles are large, then I think it is likely to cause microvascular sludging and little hemodynamic deterioration and sometimes little troublesome emergency, slow flow, no reflow, bradycardia. Those are the complications which I will deal in due course of time, but that is likely to happen. And that should not be allowed. For that, I think the perfect burring technique is essential. Two things is required: patience and appropriate knowledge. The burring speed, initial selection of the burring speed, not allow the rotation to drop by more than 5,000 revolutions. Do a wood packing movement. Don't try to push. If you push quickly, then I think it will make a large particles. And not only that, but there is a risk of a burr entrapment. So those things are very essential. And this you get either from the proctor or repeatedly doing the procedure, and then you acquire the expertise. Do not stop burring in the middle of the lesion. The burr may not retract. Occasionally, and there is a mechanism. If the burr speed drops by more than 15,000, there is a built-in stalling. It will stall, and then I think you will be landed, you will be in a big trouble because the burr may be entrapped, and then or it may be trapped, and I think it may be difficult. It may be so. Do not escalate and de-escalate the speed while the burring is on. One, you want to change the speed, bring it stagnant position, bring it forward, proximal to the lesion, change the speed, and then push it. 1 or 2 polishing runs are enough. What should be the standard speed? Currently, it is believed that irrespective of the size, 1.25, 1.5, 1.75, 160,000 revolutions per minute is the standard speed. But I do not agree totally. There are situations where the lesions are hard, and if the burr is especially small, smaller the burr, higher the speed is often needed. And I think at that time, I think it is left to the operator as to how to change the speed and escalate the speed as and when needed. All right, so basically I might quickly summarize that the wire should be, the guide catheter should be coaxial in the right coronary, preferably with the side holes. I prefer to have side holes in the right coronary guide catheter. Then the burring, bring the rota burr to the proximal segment, and I will show you in the due course of time. When you take the burr into the proximal segment, just proximal to the lesion, you start retracting it back. And you find that the burr is not moving, it is because of built-in torque. Moment you remove the complete torque, the burr will move. Then only after the burr, one moment the burr moves, you are very sure that you removed the complete torque or torsion inside the your burr or inside the drive shaft. Now, is when this happens, if you put your foot on the foot switch, if the burr lurches or darts, that's risky because sometimes it may risk right into the lesion, and then I think it will be a burr trapping. So please be careful that, and then give only a small little tap so that the burr lurches, it does not lurch too much, and that I think is very important. So what are the complications? Bradycardia and AV blocks, slow flow or no reflow, dissection, perforation, side branch occlusion, and hypotension. And what are the rotablation system failure, burr entrapment, burr detachment? Incidentally, I must say that initially when the burr detachment used to take place, it is used to embolize distally. So they started making the wire, the rota wire, if you now know, it is 0.009, but the distal tip, which is a malleable flexible tip, is 0.014. Now therefore the rota burr cannot cross that because its lumen clarity is 0.01210, so it can't embolize anymore. All right, fracture of the wire sometimes takes place. Usually it is benign, it does not create a problem. Let's take one by one. Management of bradycardia and atrial. Why does bradycardia take place? Well, we do not know precisely because the experiment showed the bradycardia takes place when the burr is rotated in the guide catheter itself. So it's some kind of a Barrow-Jerris reflex or something else is not clear, but bradycardia does take place. And therefore, it is my policy to have pacemaker handy, at least in the IVC or the right atrium, in cases at least of the right coronary artery, or in the proximal left coronary artery, or a dominant circumflex artery, or the left coronary is going to give a collaterals to the totally occluded right coronary artery. In these situations, I think the bradycardia can be really harmful and create a lot of anxiety. Therefore, the pacemaker should be handy. And why not to put in the right ventricle? Well, sometimes people have experienced perforation of the right ventricle, so they are a little skeptic about it. If you take a balloon-tipped right coronary pacing catheter, balloon-tipped pacing catheter, then I think the complications of perforation is very highly minimized. And so limit the ablation time to prevent bradycardia, 15 to 20 seconds. Then come back, give a rest of equal amount of time, like 20 seconds or 1 minute, and then proceed again. Pre-treatment with atropine has been recommended, but I don't believe it. I don't do it. Deactivate the burr when slowing of the heart rate is noted. If the slowing takes place, you take little rest. Ask the patient to cough, and that should be all right. By and large, bradycardia has not produced any harmful effect, and therefore not to worry. And AV blocks. Some operators advanced pacemaker, as I mentioned to you, and temporary pacemaker in the special situations. Acha, step-by approach, slow flow and no reflow. Slow flow and no reflow often can be eliminated by appropriate technique. Do not allow to drop in the revolutions by more than 5,000. Do not allow the significant heat to get generated by keep on using the rotablation in an active form at one single site. It will char the lesion. Limit the ablation for 15 to 30 seconds with a rest in between. Slower speed associated with lower platelet aggregation and therefore less likelihood of slow flow or no reflow. Just in case the slow flow, you see that you inject and you say nothing, distal artery is just not visible, no reflow at all, no flow. What could be the possibility? A, intense vasospasm, B, dissection flap, and 3, microvascular sludging. But how do you differentiate these three? The treatment for all these three is very different. Take a microcatheter and go beyond the lesion. If you inject the dye with microcatheter in that part, and if you find there is a stagnation of flow, surely it is a microvascular sludging. On the other hand, you bring the lesion and open it with balloon, the spasm will be broken. But if you find there is only a partial flow and the dissection is seen, I think the treatment is stenting it. 10% is the incidence of dissection, and this is particularly common in angulated lesions or due to wire bias. Therefore, placement of the guide wire appropriately is of paramount importance. Its cutting vector of the device should be appropriately placed. Yeah, set the optimal central vector for burring. Because the increased tension of the rigidity of the wire can cause pseudo lesions and therefore can create dissection of those lesions with intima and media, and this it can be avoided if you have proper knowledge and if you can keep carefully the wire just distal to the lesion by a couple of centimeters. And in between, the angiography should be performed after the wire is placed so that you know that pseudo lesions have developed or not. So, how to minimize the rota guide wire tension, that I already talked with you, that you withdraw the burr, and then I think it will help. Perforation, that I think is a very serious complication. Mechanism is that either you have taken an oversized burr or tangentially oriented burr due to trajectory of the guide wire. More common in severely angulated lesions, and I will show you an example of perforation when I show you videos. This can occur even in elastic vessels, since the strain or penetration of guide wire into the wall will exceed the elasticity of the vessel wall, and ablation of the tissues will take place with potential perforation, especially in angulated vessels. So, how to manage that? First of all, minimize the guide wire bias by proper coaxial guide catheter and guide wire placement. Relaxation of the guide wire is important, and that I think withdrawing it slightly so as to remove the tension on the wire. Undersize the burr in severely angulated vessels, and especially those which are straightened with guide wire or showing pseudo lesions. Wood packing moment that should be used to avoid excessive cutting. Side branch occlusion, how do you prevent that? Since the secondary protective wire cannot be used, you can't have any other wire whilst you are using rotablation, and that's what careful attention should be given. Whereas this side branch cross, the occlusion in ordinarily bifurcating lesions occurs due to plaque shift or carina shift. Here it will be solely due to microvascular sludging or particles moving into the side branch. I think vasospasm might also take. The burr entrapment, this I think is an important complication. It can occur if burr slips across without burying the lesion adequately. What happens is that when you go inside and you have gone without burying adequately, a lurch or a small latch of the calcium continues to remain in the vessel transversely. And now when you pull back, it travels onto the inner side of the artery. That is where the lesion is, so it will not come out. And I think it is a Kokesi effect or the Japanese doll effect. And there I think you require lots of efforts. So how do you deal? I will deal with little more in detail. The vessel management of entrapped burr. Disengage the guide catheter from the vessel ostium and send the other guide catheter from the contralateral side. Remove this guide catheter. Pass a second guide catheter is intubating the vessel, the culprit vessel, and pass a wire by the side. Usually you require a polymer wire or a strong wire, and usually sometimes even a Conquest Pro wire. And then I think pass a balloon. A small possible balloon might help you after expansion to dislodge the guide catheter, the burr, and then you can pull the burr out. So this is what it was published earlier. And then I think there is one more method which I'm going to show you in my videos. All right. If there is a stuck rotator burr, what can you do? Use a second guide catheter, recross with the second wire, ablate, and then if you are able to pass by the side of the burr, then you cross it with the balloon and then try to dislodge. If not, then you will have to cut off the sheath and then put a guide liner, and I'll show you how you should do that. All right. First case, this was a 65-year-old man with heavily calcified right coronary artery, borderline creatinine. He had multiple PTCAs, proximal LAD, distal LAD, povite to mid LAD lesion, so on and so forth. Now the target vessel that we wanted to treat was right coronary artery. The culprit lesions were at the bifurcation. Syntax score was 30. Heavily calcified artery. You can visibly see the artery, silhouette of the artery and the stents in the LAD. And this is where I passed a wire first. So 7 French guide catheter with the side holes, Filter FC and in PDA and BMW in PLB. 2 wires. 2 mm euphora balloon at 20 atmosphere. Lesion did not yield. So then change the policy. Took a rota wire, 1.25 mm burr. Drive shaft was not able to reach up to the lesion because it can only travel 6 centimeter. The rota burr can travel for only 6 centimeter. Then how do you approach the distal lesion? There are 2 ways. Advance the whole drive shaft as a one piece, like as you advance a balloon on the wire, in 2 ways. Inactivated way or an activated way. Inactivated way is simple pushing the burr into the artery to allow it to go as much as it goes. And then count 6 centimeter from then. Maybe it is within the reach of the burr for the lesion. If not, then you can advance in activated form. The speed of rota in that situation should be about 100,000. You can do it in Dynaglide mode, but it is better to use 100,000 because in Dynaglide it's a servo mechanism. If obstruction is encountered by the burr, it will be overcome by automatic change in the speed by dyna. But if you are 100,000 and you find that the bird is slowing down or is stalling, then there is a concealed lesion there also. So you come to know. Anyway, so we did that, but it still fell short. So we had to, we tried a 6 French guide liner. Heavy calcification, and the guide wire was backing out. And the balloon anchoring was done for this particular guide liner, but it continued to stay at that position only till the balloon was inflated. Moment I deflate the balloon, the whole guide liner would come back. So I stopped the procedure on that particular day and postponed and brought him after 2 days. Started after 3 days with a new strategy. Deep intubation of 6 French guide catheter was planned, and multi-purpose 6 French catheter was prepared for deep sitting by softening it and straightening it. So what do? You take it and pass the wire there. This is a multi-purpose catheter, and then you heat it with the hair dryer. This softens it's made up of polyurethane, so it is softened and it straightens up. This can be done quite easily. Since the hair dryer, Ajay, is not very easily available, you have to bring and asking your permission from your wife, and she would usually not give you because she is not sure that what for you using it. 2 filter FC wires were advanced for the support to 4 French guide catheter, 6 French guide catheter, the regular one. And for an additional support, even a 0.035 wire. Now with 2 wires inside the guide catheter, 2 wires inside the coronary artery, over this I slided over 6 French multi-purpose catheter, which was already softened by me. And with this, carefully avoiding any loops in the guide in the aorta, gently advance it, and I brought it right up to the lesion, deeply anchoring near the cusp, the crux. And over a microcatheter, the Grand Slam wire was changed to rotafloppy wire, and we started burring. And unfortunately, lesion did not give up even at the speed of 220,000 revolutions per minute, and to my bad luck, the burr got stuck inside the lesion. It did not come out with traction, nor could be advanced further, and it was completely stalled. So now what do? You cut the rota sheath completely. The drive shaft is cut, and the sheath is removed out. So this exposes with the sheath, it exposes the drive shaft now, and over this one can advance the guide liner. Since I did not require any backup because the stalled burr itself was providing me tremendous anchor, so the burr went, the guide liner went easily, but it did not work. And finally the patient had to go for surgery. Passing the wire by the side also did not work, and ultimately the patient had to go for surgery, and he found a lot of difficulty to remove the burr because it was so much embedded. He had to make cut piecemeal removal of the calcium from the endothelium, then did the atherectomy, and he then put a venous patch, and then he performed the plastic. Well, so this is the story about the burr entrapment. Now, one more difficult, because I think the time is over. So this is a heavily calcified coronary artery, and the right the circumflex artery. I had difficulty in not only crossing the vessel, but it would not cross even RC also, CTO, and the I'll proceed straight to the target artery. The wire was advanced, and fine cross microcatheter would not go. In such a situation, what one does is you jam the microcatheter as much as you can, remove the wire boldly, and advance the rota-wire. After doing that, proceeded corsair proexis did not cross, and then finally, having placed the rota-wire, after jamming the corsair with 1.25 rota. That also would not go very easily due to heavy calcification. Ultimately, after several attempts, when the burr became bald, changed the burr, and then finally crossed the OM distal lesion. Bradycardia, hypotension, responded to fluids, and ultimately pacemaker had to be inserted too, and went with the speed. It produced what is known as a neo lesion formation. There it is. You see the proximally. Does this arrow shows here? No, it will not show. You see that proximally there is a slightly ectatic kind of an area here. There I think the burr has traveled to the intima and media. Now there are two lumens. So this is called a new lumen formation, first described by Reisman, and it can be treated easily by stenting. And ultimately after this was up to the left main. So first we placed the stent into the OM, 3 mm stent and 3.5 mm stent, post dilated with pot done in the left main with a 4 mm balloon, and finally this was the final result. I think I'll leave some time for questions and answer because we have a short time. Thank you very much.
Thank you, sir.
Any additional information you would like to put?
Sir, thank you, sir. I mean, it's an honor to chair a session when your teacher is speaking. So it's good. So we always learn something from you. 2-3 questions or comments, because a lot of fellows are there. You told about atropine, which you don't use to prevent bradycardia. I mean, many times nowadays we use aminophylline 250 milligram over 15-20 minutes. So that is one thing. What is your opinion? Secondly, I mean, for rota wire choice, there is floppy wire and support wire. So for osteal lesion like left main ostium or RCA ostium, is it, do you recommend to use support wire, or is it okay with floppy wire also?
Okay, so just a word or two about osteal root ablation. First of all, when you deal with the osteal lesion, the guide catheter cannot be selectively intubated into the ostium, but it has to stay a little bit outside the ostium. This you can achieve that when you push the wire, the guide catheter backs out a little bit. You should be thoroughly coaxial. The burring starts from within the guide catheter itself. Although that the inside of the guide catheter is PTFE coated, and one is worried whether it will embolize or not, but it does not happen that way. You should start from inside. 3, that preferably you should use, especially in the right, the side holes, because so that in case if you wedge it, some perfusion takes place. And then I think whether you use a floppy wire or use a strong wire does not make any difference. And your second question was aminophylline. I don't use it, but I suppose people have described and they can use it.
Sir, it was very informative and comprehensive talk. So, sir, any tips and tricks about root ablation of stents, under expanded stents, or say calcified ISR within a stent. So how to, any special tips and tricks for root ablating such cases?
Calcified ISR?
Calcified ISR or severely underexpanded stent, if we want to
Severely
expand
angulated?
Underexpanded stent.
Underexpanded stent.
Yes.
Oh, okay, I think so. It does happen once in a while that you have not anticipated, and the stent, I think you find difficult to expand the stent fully. So at that point of time, you stop. Don't do anything at that point. Call the patient after 10-15 days, and then you think you can, now of course you can do it with IVL, but in the past when it was not there, we used to root ablation. And I think from the Spain, there was a paper published in the Management of Instant Restenosis almost 10 years ago with the use of a large size root, 2 millimeter root ablation, and that they were using it in the treatment. Ultimately, we found out that the instant restenosis, after whatever you can do, it expand it back, and I think the second stent is a much better treatment. Now, so burying that root ablation within the stent itself is not a contraindication. Not at all a contraindication. It is quite possible that it will touch the stent surfaces on the inner side and outer side, and maybe it might even ablate a little bit of part of the stent, etc., but it can be successfully done. Dr. Matthew showed one case in which he did the side branch with root ablation in a stented artery where the side branch was covered with the stent strut. He went through the strut, dilated the strut, and did the root ablation successfully. I would not recommend routinely, but just in case if you are compelled to do, he showed a feasibility. Yeah. A good question. He says now that the orbital atherectomy, when there is a low ejection fraction, since the orbital atherectomy does not produce slow flow, no reflow, because the particle size is 2 microns only. It has a burying capacity on both sides because it does it a loop, and therefore you can ablate while going forward and coming backward. So burr entrapment does not take place. Bradycardia does not take place. So the situations where you are dealing with a low ejection fraction patient, or those where you are likely to think that the bradycardia and hypotension due to microvascular sludging is going to create a problem, I can do that. Moreover, if the artery size is very large and you think that the lesion will not be purchased by the burr, then I think orbital atherectomy is good, because with the speed of 120,000, it revolves around the circle of almost 3 millimeter and more. So those circumstances I would use orbital. It continues to do that because when you move forward, it ablates forward. When you're coming back, it ablates backward. So it continues to do. When you stop and take your and stall it, then it stops. I think.
Well, I was told that you cross the lesion with orbital, distal to lesion, and then pull back retrograde and then.
For Australias.
Not all the other lesions.
No, for Australias, because that's the only way you can burr while coming back. Yeah.
Yeah.
Okay.
Thanks for excellent talk, sir. With a tortuous vessel, whether we should go with a smaller burr 1.25 or 1.5. Some says that it is 1.5 will not jump, 1.25 will jump too much.
Say that again, please.
Yeah, in tortuous vessel, whether we should go with a smaller burr 1.25 or 1.5. Some says that 1.25 will jump more in tortuous vessel.
Okay, all right. Now, that's a good question. Vast majority of the burrs which have been entrapped or embedded are 1.25. It's very rare that 1.5 gets embedded. 9 out of 10 times it will be 1.25. So by and large, our standard practice is to start with 1.5 only. You asked for a specific question in tortuosity. There you have to be extra careful. You start with 1.25 only, and then after burying, if it is necessary, then you jump to 1.5. Occasionally it has happened to me that even in tortuous lesions, 1.25 has not crossed, but 1.5 has crossed because of larger amount of energy. So reverse is occasionally true also. So I think it depends on the case situation.
Thank you.
Thank you so
Now,
much, sir.
now,
one question,
I
sir.
have developed vocal myasthenia. So no more questions.
Bhupesh, I think after some time you can ask your question to sir personally. Sir, please be on the stage. Sir, please be on the stage. Dr. Milan Chak, sir, please felicitate our honorable speaker. Dr. Anand Shukla, please felicitate the chairpersons. Dr. Dhruv Jadeja, please felicitate our experts. Dr. Dhruv Jadeja. For the next talk, again, an exciting topic, image-guided PCI. None other than Padma Bhushan Dr. Tejas Patel, sir. A picture speaks 1,000 words. That's the title of the talk. For chairing this session, I would request Dr. Mehta, sir, to be on the stage. Dr. P.K. Sahu, Dr. A.B. Mehta, sir, and Dr. P.K. Sahu, sir, to chair the session. And experts in the same session, Dr. Sanjay Shah, please come on the dais. Dr. Kamal Sharma, Dr. Abhishek Tripathi, Dr. Rupesh Singhal.
Good morning, everybody. Image guidance now has secured a very stable place in the intervention in our country also. And that's a good news. So today I am going to speak on image guided PCI. I have created the talk as a case-based presentation where, many times we have been successful, a few times we have failed, and the reasons of success and failure and how imaging helped us identifying the complication, even reaching the success, etc. So the first case was a 68-year-old male, diabetic, hypertensive, hypothyroid, and inferior wall MI, history of inferior wall MI before 6 years, presented with class 2 angina on medical management, mild LV dysfunction. It's not moving, the slide. Okay, yeah, it's moving here. Okay, it's not moving here. So it looks a very simple lesion. But here, I had problem with a regular wire, extra floppy run through, and I struggled even with balloon. It was simply not entering. And ultimately, I had to use pilot 50, and with a 1.5 balloon, I could cross. It looks very simple. But when you see, after pre-dilatation, when I did optical coherence tomography, this was the picture. It is a recanalized thrombus, very old chronic recanalized thrombus with a honeycomb appearance. So then we fixed it. This is the picture. We fixed it, and then OCT and the angiographic result was perfectly clean. So sometimes, you have to think of it, 6-year or a very old MI and presenting with patient presenting with simple lesion can be a functional chronic total occlusion. Another case is a 59-year-old man, diabetic, hypertensive. PCI of LAD was done before 4 years and presented with anterior wall MI to us with a severe left ventricular dysfunction. It was an interesting angiographic view, and we thought that it could be a spontaneous coronary dissection. Because what else? It looks like a flap. The stent is in the proximal LAD, and it looks a very awkward. There is some ectasia there. And we worked on it. It looks very simple at this point of time. We did left main to LAD and then kissing balloon and a perfect result. But then half an hour we spent perspiring and thinking what is going wrong. This was the picture. When we did it, initially the wire went through the strut in the main artery, and then we had to correct the wire, going through the proper channels. Now we did it properly with kissing balloon and everything. Interestingly, we did both OCT and IVUS image here. This is an OCT image. Just focus here on the shaft. It is now in the different channel, and now it is coming in the left main. There was an aneurysm which happened at that point of time in the edge of the stent, in the proximal edge of the stent. We confirmed even with IVUS here, this is a true lumen, and now suddenly you see the shift of the shaft into a different cavity, and this is the original cavity, and then again coming, you can see the left main. So this happened. These are the still pictures which we clearly show the lumen, the aneurysm, the shaft was going through, and then the correction was given, and this was a perfect picture. So these are the problems, you can identify. Otherwise, without imaging, you remain clueless and you don't know what you are doing. A very interesting case, a 25-year-old female presented with ACS, ECG showing inferior wall STT changes, raised troponin, a selective coronary angiogram, giant aneurysm, and we did MRI of the brain vessels, abdominal, just to rule out Kawasaki type of phenomenon, whatever. And she had moved around everywhere. Everywhere the surgery was advised. She was 25 and ready to marry after 1 year. She came with the fiance and the parents. And see, this is what it is, impending and rupture, aneurysm, huge aneurysm with impending rupture. There must be a good amount of clot inside too. When we measured the size of aneurysm, it was almost like 29-30 millimeter. And the papyrus stent, longest stent available was 26. What to do? We thought over it. Okay, you cannot overlap two covered stents. We gave the option of covered stent under image guidance. Inside this cavity, which is a very unstable type of aneurysm, here my colleague Sanjay came out with a brilliant idea. We created a platform with a metal stent, 38 millimeter Giants Expedition measured, 38 millimeter Giants Expedition stent was deployed, stented the region, and then overlapping two papyrus stents were deployed one after the another. You can see this is the another papyrus, and the aneurysm is gone. We checked it with OCT guidance. This is how we worked on it. We checked it using the OCT guidance. You can see the perfect deployment. The aneurysmal cavity collapsed because blood flow stopped going there, and you can see all the blood collection all around the site of the aneurysm, and you can even see the overlapping of the stents. This is how it looked, at the normal segment of the Giants Expedition and inside the aneurysm. We called her back again after 9 months, and you can see the perfect result. We even did OCT guidance at that point of time, and you can see the perfect result. There was some proliferation at the overlapping site, absolutely acceptable. There you see some proliferation only at that site, and then again the normal segment. Patient is doing fine. It is almost 3 years. So this is one way, because otherwise we had no choice but to give her a graft on the right artery, and which was pretty not acceptable for them. This is a 60-year-old female, hypertensive diabetic, presented with recent inferior wall MI history and mild left ventricular dysfunction. PCI to RCA lesion was planned. And see what happened. First injection, and there is a spiral dissection. Through and through, going right up to the PDA and, just at the lesion site. Complete plan was changed. Now, we wanted to dilate, stand, do proper, image guidance to see everything is fine. Instead, first worry was to prevent the extension of this dissection in the ascending aorta, because if it extends, it will go up to innominate and it can create disaster. So we changed our strategy. We fixed the ostium first. And once we fixed the ostium, of course, there were a lot of issues. Patient had pain, hypotension, everything. We deployed another 2 stents and reconstructed the artery. It looks pretty good, and in different views we checked. We didn't compromise any of the major branches, and you can see the optical coherence tomography image. It is very acceptable, with some areas of intramural hematoma happening, beyond the dissection area, but perfectly acceptable result, and patient remains stable. Dissection and hematoma, we are using IVUS and OCT, but in this particular situation, many times we get a better, more information with the OCT guidance, which is a very regular affair in our lab in almost 50% of coronary intervention. We have an investigator-initiated IOPUS trial where simultaneous IVUS and OCT imaging have been done for the same lesion, and you can see this is how it looks in IVUS, this is how it looks in OCT, dissection and hematoma looking in IVUS and OCT, another image, a huge hematoma there, which looks like this. In OCT, if the artery is very big, sometimes, you can misinterpret this hematoma. In IVUS, it looks better in the bigger arteries. And another example. Another case of a 68-year-old man, hypertensive diabetic, class 3 angina, fair LV function, left main bifurcation Medina 111, syntax score 18, mini crush of LMCA lesion, bifurcation was planned. This was, in the beginning when we got a new software of the OCT, that is before 3 years, I suppose, or 4 years. And it was done in a perfect copybook style case, mini crush. Everything was done as per the book, LAD to LMCA OCT run, and this is how the circumflex looked. Distal crossing was done, again dilated, and then circ to left main run and LAD to LMCA run, perfect result, and this is what you see as a result, end result. Another case, this was a 66-year-old male, class 3 angina, hypertensive diabetic, angiography, left main trifurcation. Of course, if you consider bifurcation, Medina 111, high syntax score, patient refused surgery, and we accepted for intervention. Here, rather than creating crowding around the area of carina, we have used the technique, a mini crush, and for time being, we became selectively blind to the ramus intermedius. Because it is extremely tight lesion there, we presume that there is a good amount of ischemic preconditioning. Even if it occludes, we'll see what happens. And then we worked on it, kissing a mini crush, kissing balloon, and perfect result. And the ramus is flowing as it is. And this is how it looked in the OCT. You can see the perfect result. And we have now almost the data of more than 200 left main bifurcation done under OCT guidance. And I'll show you the original, the standard teaching is, you have to identify whether, you have to see 2 things, link free carina or link connecting carina, and distal crossing or proximal crossing. Standard Japanese teaching, because Japanese have done the maximum work on it, is link connecting or link free carina is not in the hands of the operator, whatever you do. But proximal and distal crossing, you can always think of. And they say that more you do distal crossing, you get a better cosmetic result. And of course, MACE and TLR rates are also low. But in our experience now, with almost 30 months of median follow-up of about 200 left main bifurcation OCT guided cases, we have stopped doing seeing proximal distal crossing, and we are doing it exactly the way, the kissing and all those things. And we have not found any sort of major problem as far as the MACE and TLR is concerned. That publication, we are going to write on it, and you will see that publication down the line. This was the original traditional teaching, but we are now not thinking of proximal or distal crossing, and we are working, in a normal fashion. This was a 49-year-old male diabetic hypertensive presented with anSTEMI, normal ventricular function, and angiogram revealed a tight 90% ostial left main lesion. Of course, we always use intravascular ultrasound for this, and here, we tackled it properly. This is the end result, which looks perfect. But when we did the post-stenting IVUS run, this is what we saw. Despite a very clean angiographic result, there was a damage to the struts of the stent which are protruding outside, and that has created a quite oblong type of lumen, which was corrected with post-dilatation, and this is how we got 11.44 minimum stent area, which is the perfect result. Another case of 65-year-old male hypertensive diabetic presented with a very high CT calcium score in the left main region with a normal ventricular function, and you can see a tight ostial left main. We went ahead to stent the left main ostium under IVUS guidance, but to our surprise, you can see there is a good amount of calcium. Of course, the lumen does not look absolutely circular, but minimal lumen area is 10.26. So we deferred the intervention. A 55-year-old male, diabetic hypertensive, hyperlipidemia, anSTEMI, raised drop, class 3 angina, fair LV function, presented to us. And this was actually, in another country when I was giving a live demonstration in the national conference. And we had available in our armamentarium IVUS, OCT, and rotational atherectomy. We rotablated this lesion. What should be the strategy? Strategy was we rotablated this lesion. We did optical coherence tomography dilatation run after post dilatation after rota. We thought that everything looks good. Here we got stuck, and this is what after stenting we see. It looks very scary. Why it happened? Because the time slot was 35 minutes to finish my case, and I hurriedly interpreted the optical coherence tomography image in the proximal area. I thought everything has been rotablated, looks perfect. And then the rotablator, the optical coherence tomography catheter was simply refusing to go inside. And I had to use IVUS catheter, which has a better muscle, and I could cross it. And here you see there was a nodule which I missed, and that created problem. There was a hematoma, and the minimal stent area was very, very low in the very proximal LAD, 4.51. Fortunately, to my fortune, the nodule was towards the diagonal side of ostial LAD, and I could significantly dilate it to make it 5.5. And this retrospectively, when I interpreted the IVUS or OCT image, this is what happened. The message is, if you are doing it, imaging, spend good time to interpret it. Otherwise, you can create problem for yourself. Dilatation and then the satisfactory result. One more case is a 67-year-old male hypertensive diabetic, class 3 angina, mild LV function, LV dysfunction, and this was post-bypass case. you can see. Whenever I see this type of picture on angiogram, particularly in a post-bypass, long duration bypass case, without imaging, now I can at least predict that I have to encounter a very bad nodule in that region, calcific nodule. And then we try to initially break with the non-compliant balloon at a very high pressure, because here, you know, sometimes giving a rotablator or whatever, at that time, of course, orbital atherectomy was not available. So we dilated. It is a very bad nodule there. You can see spiked nodule. 2 or 3 balloons ruptured, but you know, we were able to break a lot of calcium at and around nodule, but we could not get the best of the result here. And we, from 3.17, we could create a 6.88 lumen, which was acceptable. Of course, it was not very nice to see, but here I have to hold in the interest of the patient, because if you try further, you can create 2 problems. Number 1, you can perforate the artery, and if not, then you do a stent fracture. If you do stent fracture, it is very, very significantly high chance of patient coming back with the restenosis or acute initial problem. And if you perforate, you know, you are creating problem for the patient. So this is another case which was taken in IOPUS investigator initiated. These are the nodules with a spike, which are malignant nodules, and here normally the balloons don't work. You have to rupture the balloon, you have to damage the vessel in the surrounding, so you have to be careful. Even the lithotripsy does not work in this type of situation when the surrounding area is good and this type of nodule is there. With a limited experience of several cases we have done with orbital atherectomy, this is where orbital atherectomy helps because of its mechanism of moving around at the axis. It can, you know, ablate and make it little more blunter for the balloon to open it up. And this is what, this is one case where you see the calcific nodule, spiked nodule there. It looks like a spiked nodule. And this is what you see on optical coherence tomography, a sharp nodule with a sharp edge there, and orbital atherectomy. And you can see a good amount of ablation there, and you can see the result was perfect after dilatation. And this is how it looks. Another similar case, you can see high CT calcium score. Here is a shelf lesion, which is a shelf-like lesion. At times you feel, if it occupies the whole area, you feel it is a membrane. But this, I was pretty sure that I am dealing with a sharp calcific nodule. Again, orbital atherectomy. This is what it looked, you know, in OCT image, which we did before going for orbital atherectomy. Ablation done with orbital atherectomy, ballooned, and you can see how it was broken. And then with stenting, you can get a perfect result there. And this is how it looked, and this is how you achieve the end result. So what is the importance of calcium plate fracture? Again, a seminal, small but beautifully done study. Initially, the score was given by Fujino and Mahera, the calcium score, OCT calcium score, 1, 2, 3, 4, according to the amount of calcium less than 90, circumference less than 90, 90 to 180, and more than 180. 90 to 180 is 1, more than 180 is 2. And then the length of the calcium, more than 5 millimeter is 1, about 5 millimeter or more is 1, and the thickness, more than 500 microgram is 1. 1 and 2 means you can break the calcium with balloon, non-compliant balloon. 3 and 4, you have to use the technology. It could be rotational atherectomy, it could be orbital atherectomy, it could be intracoronary lithotripsy, or it could be cutting balloon, whatever. and then you have to break the plates. Why? What is the importance of calcium plate fracture? Again, a beautiful study by Akasaka et al. Most of the OCT initial seminal work has been done by Dr. Takashi Akasaka from Japan, a thinker and an innovator. A calcium plate thickness less than 500 micron was corresponding to cutoff value of predicting calcium plate fracture by high pressure ballooning without using any technology. So what does it mean? You can see how does it transform in clinical practice. Minimal stent area with a fractured calcium plate is higher as compared to non-fractured calcium plate, and stent expansion index is higher in calcium fractured plate as compared to non-calcium fractured plate. So how does it matter in clinical practice? It has a direct impact on the long-term result. Binary restenosis 14% vis-a-vis 41%, and target lesion revascularization 7% vis-a-vis 28%. Significant difference. So use imaging in any calcified lesion, and here IVAS has scored over many situations over OCT, but many situations OCT is better, so they are complementary. We have a preference for OCT for most of the cases. Here OCT will help you because you can create, you can calculate the calcium score, and accordingly you can decide your strategy, and you don't overuse the technology. And you use the technology whenever it is appropriate. So lesion modification should be attempted to reduce the calcium thickness if it is more than 500 micron, and try to reduce calcium thickness to less than 500, whatever technology you are comfortable with. More the calcium fracture, better it is always. And these are few examples. You can see 360 degree calcium, around 90 degree, more than 180 degree calcium. Here high pressure ballooning leading to calcium fracture plate. Again high pressure ballooning leading to calcium fracture plate. Rotational atherectomy will give you this sort of pulverized type of calcium disruption, and then you can break it with the balloon. Here rota followed by high pressure balloon. You can see big sort of blocks of calcium once you have done the rota followed by high pressure balloon. Again you can see many calcium blocks once you have done the rota followed by high pressure balloon. Baseline is like this. This is lithotripsy. Again lithotripsy, sometimes you may or may not be able to appreciate the calcium fracture, but once you dilate with the balloon, and ultimately when you stent, you get an excellent minimal stent area. Only caution is, like if there is a calcific nodule and if the surrounding area is reasonably good or fibrous or non-calcified or normal, then lithotripsy, you are going to waste lot of pulses, and particular area it will not work so well, particularly in isolated, discrete, bad calcific nodule. Again, this is an example of the same baseline, shock wave, final. This is another example, shock wave, high pressure balloon, and final MSA. So the value of experience is not seeing much, but saying it wisely. Thank you very much for your kind. Thank you, sir.
Thank you, Dr. Patel. You have covered everything in a very lucid manner and very interesting cases you have shown. The message is well conveyed. As per your last slide, the value of experience is not in seeing much, but it is seeing wisely. That's the most important thing.
I have known Tejas for so many years. He spent some time at Just Look with me, and one of the brightest fellows that I can recall. And then thereafter he continued his good work after coming to Ahmedabad. And his entire efforts to popularize the radial catheterization and radial intervention with his book, a remarkable book that he has written, and he gifted it to me. And I find that his contribution in the field of interventional cardiology is unparalleled. And I think
Thank you, sir, for your blessings.
And I think, as regards the question, I just only have one suggestion. For people, from practical point of view, let me say that what did I do and how did I deal with undilatable lesions in the days when the imaging was not available, because I have seen the spectrum for the last 55 years. Now, I take a balloon, visibly calcified lesion, open it with the non-compliant balloon, and if I said already that if you see that the dumbbelling takes place and the lesion does not break, I immediately switch over to rotablation. After using the rotablation, oversized balloon at a low pressure, like say in 3 millimeter artery, I'll use a 4 millimeter balloon at 1 atmosphere. You know the Laplace's law states that the tension at the wall of the balloon is directly proportional to the inside pressure and radius. Larger the radius, the inside pressure can generate the same amount of voltation. If that does not open, I switch over to a higher burr. And this way I call it as interpolated angioplasty. It would amount to sometimes my dilating the balloon on the rotawire itself. I don't want to change to something else. And although there is a slight slurness when the balloon has a rotawire is 0.009 and balloon is compatible with 0.014, but it does not matter. So this way you can, but I think it is true that if you can measure the thickness, which I think the only way the thickness can be measured is by OCT. You can't measure thickness with IVUS. So in that respect, I think in calcified lesion, the OCT scores. It scores over the IVUS. And I think it's a good thing that I think your treatment is very accurate, that if you find that the thickness is 0.5, I think you will not hesitate in debulking with ablation therapy, whatever you want to.
Yes.
Yeah. Yeah. Orbital or rota, whichever it may. You people, yeah.
Sir, excellent talk, and I've been hearing from you that you want to do this talk. I could finally hear it from you. Images speak 1,000 words. So, sir, two important things. You are the person who has done maximum IVUS as well as OCT probably in the country.
Not IVUS, but OCT certainly.
No, the combination. So my question was, sir, in which cases, though it would be a rarity for somebody to have both the imaging modalities in the same patient, but you have done that probably in one of the largest series. We know from the Octavius trial that there is probably no difference in terms of the outcome. But, and also there is no difference in terms of the renal deterioration because of the myth that OCT will have more contrast.
Yes.
Even that is not true. MACE is not different. Contrast problems are not different. Then how would, apart from the left main and the proximal and the creatinine apart, would you firstly combine the two imaging and secondly choose between the two imaging?
When I want to combine two images, I don't combine on regular day-to-day basis. This is just to create a good academic, sort of collection, because I am in the process of writing atlas on imaging, and probably it will be the first atlas of that kind in the world where OCT, IVUS, imaging and discuss both in a very balanced manner. That is one. In my clinical practice also, intuitively I feel, now if I am working on a left main, which we are doing regularly now, and if I find that left main seems to have a diffuse disease throughout, right, which involves some ostium also, and then some mild disease and a critical left main bifurcation, I will open up both the catheters, IVUS as well as OCT, because I want to make 100% sure. Because the ostium of the left main, sometimes you don't see properly, or most of the times you miss with optical coherence tomography, and there, IVUS interpretation can help. And if you are not doing that, and if you are, despite you feel that you have done a proper pot, if you keep a space between like 5.5 or 6 millimeter arteries, sometimes we get bigger arteries, space there between the arterial lumen and the stand struts, then further intervention can be difficult. So we have to make 100% sure that you are doing a proper optimal pot at that point of time. Secondly, seeing the ostiums of the circumflex, I don't think any modality can give you a better image than OCT. IVUS will certainly not, because we have that experience. IVUS interpreters, like in Trico, you have seen, I don't know whether you have seen, Akasaka Dr. Akasaka is a regular visitor. He and Dr. Saito left main bifurcation and proximal and distal crossing. They were discussing on the basis of IVUS image. And then Malcolm Bell, who is the head of Mayo Cardiology, told that hardly anybody can understand what these two authorities are discussing and about this image. So that was a different level of discussion at that point of. Here with OCT, it is a naked eye scene, you can see whether it is a proximal crossing or distal crossing. Secondly, after so many bifurcation left main cases, we are going to write on it. It doesn't matter whether you are crossing proximally or distally. It is simply, the cosmetic image which looks better. If you have given good lumen at the carina, at both the places, nothing happens.
I tend to agree for two reasons. Gary Mills, when he was here in Bombay, and I heard him personally in so many meetings, there are two phenomena: immediate stent malposition, ISMA, and late acquired stent malposition, LASMA. Both ISMA and LASMA has not been definitely proved to be resulting into any kind of mace. It is still to be seen. So therefore, he said that in the medium-sized artery, if you have a 5.5 lumen area, and if it is corresponding to an FFR of above 80, you are done. Any waste of time can lead to sometimes complications.
Yes.
Yeah. Vijay, we have three experts here. G.S. Chada, Vijay. So I want little input from both of you.
And as you said, overdoing is not good. I think if you get a good lumen area and without a major under expansion, I think you should do. I think there are two small papers that have shown that if you over aggressively do it, create more injury and result in more adverse events. Then I think it does. Imaging again helps in where to stop also. It is not that based on imaging you do overdo things.
And I think, Ajay, you can say that. But I think, Vijay, the LASMA is commonly seen when there is a positive remodeling or when there is an acute MI where the clot disappears.
And it is actually only one study from Korea that they followed up for 10 years where they done a baseline imaging, 9-month follow-up imaging where they see acquired malposition due to your polymer or stent related toxicity. That is the one going to be related to increased adverse events. And most of the time in ACS, you implant a stent and the thrombus resolves and create a malposition.
Yes.
And provided the stent is well expanded, and they don't result. And none of the studies have prospectively shown that malposition in a well-expanded stent result in adverse events. Even though there are small OCT studies, increased volume of malposition resulted in adverse events. But none of the major prospective randomized studies have shown that acute malposition create a major problem.
So one question.
You wanted to add something?
No. Just agreeing with what our teacher Dr. Patel said. This is about the left main bifurcations. So there was a small study called OPSI-BRAE that was published in Cath Cardiovascular, in which the only predictor of side branch failure was actually the presence of metal at the ostium of the side branch. And it didn't matter. I mean, unfortunately, we didn't see where we had crossed from, but the single predictor of side branch failure was the presence of metal at the carina. So I think that would be very, very logical in waiting for what sir has to publish.
Good morning, sir.
Sir, I have one statement to make. I wish all the authorities sitting here will agree.
Yeah.
Most of the time, imaging is interpreted by the company person who is sitting there. I have taken it as a mission after radial that young generation of this country should know how to interpret the image by oneself. And by considering that, like interpreted image from the company person, you will simply commercially, you will be upgraded, but patient does not benefit. And sometimes you can create blunders also. So I personally feel that everybody who is into imaging must learn how to interpret the image. And that is what, since last 3 tricos, we are struggling to make a point that you interpret your image yourself, and that will be better for you as your understanding of the pathology as well as for your patient's better outcome.
Good morning,
Thank you, sir. Thank you.
So one question. So we've been learning from you from my residency days and still learning from you. So when we were doing more and more imaging, so what we have realized with LAD especially is that when you have an ostial LAD lesion, you almost, the plaque extends to the distal left main. And even if you have disease till the ostial LAD. So whether it is better to try to nail the ostium, or you prefer to put a crossover single stent from the left main to LAD, recross into the circumflex. And second question is, even if you do that, what are the rates of restenosis of the ostial circumflex? Because when we try to nail the ostium, when we do an IVUS, we almost always find that there is some struts in the left main, even if you feel that you have nailed the ostium.
Good question. I think, let me tell you my experience. I have actually, when I work for my patient, I have two different souls working in myself. One is my clinical soul and one is my academic soul. And when there is a confrontation between my clinical soul and academic soul, I believe in my clinical soul. Because then I have under my belt more than 125,000 procedures experience, and I follow my clinical soul. Secondly, if you have this situation, again, if you have OCT, you realize whether that area has a fat embedded there at carina and the distal left main or not. If there is a fat and your proximal landing is inside the fat, just not to go inside, then restenosis is guaranteed. This is again the data from Akasaka et al. So you deploy your proximal and distal landing should be in the normal area. If it is not normal, then some calcium, some fibrosis is fine. But in a fatty region, when you deploy your landing zone, then restenosis is very high. So in that case, you cross over and then you do crisscross. Again, another observation from our left main bifurcation series, what I have found is many times the circumflex is around 2.5 or 275 or even smaller than that. That's codominant to non-dominant. And when we take an OCT run from LAD to left main, we hardly see any strut in that region. One strut which is a little eccentric, this and that. We even don't do crisscross and leave the result as it is. And we are watching now, and observing the patients, and as of now, we have not encountered any misshape in that. I need to know from the other experts what is their feeling.
Thank you, sir.
Sir, one question, sir. Sir, here. What has your experience with contrast-free OCT, like with saline OCT? You have done so many.
See,
lectures.
again, you attend TRICO and we will show you how to give a good injection. Sanjay is the best injector, and when he does an injection, we see hardly any whirling. That is a technique. So you don't need that. And even if you use contrast 15, 20, 30 cc more, it cannot, harm your patient. But for the information, if you see the trade-off between what information you get vis-a-vis what contrast you inject, of course it has to be rationalized. The information scores over, against what contrast you are giving.
Thank you, everyone. Request Dr. A.B. Mehta, sir, to hand over a felicitation memento to Dr. Tejas Patel, sir. Yeah, last question, please.
Yeah.
So you, how do you determine your size of the stent, same as the imaging share, or you undersize? This is the problem where many times.
I am more biased towards my distal landing. Like if there is significant difference, like proximal landing is at 3.5 and distal landing is at 2.75, I will love to use a 3 millimeter stent and then do a proximal expansion. Just to make sure, because if the area is, if artery is bigger, then chances of dissection are less and you are more in a sort of control of the situation. Like in the artery which is 3.5 in the proximal part and 2.8 or 2.9 in the distal, you take 3.5 stent, there are significantly higher chances of doing distal dissection and landing with giving one more stent.
Thank you, everyone. Dr. A.B. Mehta, sir, please hand over a felicitation memento to Dr. Tejas Patel, sir. Would request Dr. Dr. Bhavesh Thakkar to come on the dais and felicitate our chairpersons, and Dr. Neerav Shah to come on the dais to felicitate our experts. For the next session, to chair, would request Dr. D.S. Chadda to come on the stage and Dr. Jai Shah to chair the session. Experts in the same session, Dr. Bhavesh Roy, Dr. Joel Shah, thank you everyone. For the next session, please come on the stage, Dr. D.S. Chadda, Dr. Jai Shah to chair the session, and experts, Dr. Bhavesh Roy, Dr. Joel Shah, Dr. Riaz, and Dr. Rutvik Trivedi. This talk is by Dr. Vijay Kumar. Imaging Guided Left Main Interventions, a Mixed Bag of Challenges and Triumphs. Dr. Vijay Kumar is from Chennai. He's a very distinguished imaging expert.
No, but go to the presenter.
And at present working as a clinical lead cardiac imaging services, Apollo Hospital, Chennai. Dr. Bhavesh Roy. Dr. Bhavesh Roy.
Showing presenter view, it is how to. I just did it. It is slide home, slide show. Maybe I can close and slideshow. No. See. Okay, middle one. Yeah, okay. Thanks. Okay. Let's see that. Stuck. After putting that, no, after putting that, it got stuck. Okay, that's come. No, you just put this one on.
By the time talk starts, I think we can have some questions about imaging from Dr. Vijay, sir, if anybody wants to ask.
ATM here.
You can go ahead with the.
Yeah. Okay. Okay.
Yeah.
Thank you so much. After the fascinating talks, this is going to be a very simple, basic talk for next 15-20 minutes. So why we need IVS for left-mind PCI? And second thing, what we are going to discuss is basic tips and tricks of acquiring a good IVS in left mind and IVS segmentation of distal left mind and role of IVS during left mind PCI pre-procedure, during procedure, and post-stenting. Why do you need IVS or any form of imaging for left mind PCI? This is one subset. There is an absolute mortality benefit, which is not in small number, ranges between 4% to 7.6% absolute decrease in the mortality. So one subset, if you want to use IVS or any form of imaging, that is your left mind PCI. Particularly when the lesion which you are going to deal is complex, particularly the distal left mind lesions. And in specific, if you are going to use 2 stents, that is when the maximum benefit happens when you use imaging in left mind. And what are the various tips and tricks you use for left mind? One, use a non-aggressive guide catheter. Align your catheter coaxially. And always, if you want to image the left mind ostium, it is best practice to disengage when the IVS catheter is close to your ostium. And always pre-dilate in case of tight lesions, because it takes some time for you to image. It can create ischemia. And it is important to keep your imaging depth to the maximum so to not to miss any details in case of big left minds. Do always an automatic pullback, where sometimes in left mind the image, the length matters, accurate estimation of length matters. For bifurcations, it is a good practice to do pullback from both the branches. And how do you size your left mind? The sizing should always be done from the pullback in the most coaxial branch. More often it is from LAD to avoid oblique. So whenever you do from the angulated branch, the imaging what you create is an oblique image that results in overestimation of your left mind size. So it is important to do your left mind sizing from the most coaxial branch. And if you want to image your side branch ostium, that is again, it is LCX. Again, it is very important to do your size estimation from the side branch rather than from the main vessel where that oblique imaging happens. And particularly when you use volcano type of catheters in an angulated branch, there is a phenomena called a leap. The catheter jumps when you come from angulated branch to the main vessel. So it is important to always use a push forward phenomena, push forward to acquire images, particularly in the angulation, not to miss any of the MLA in that place. And how do you segment your left mind into different parts? It is almost like what is happening with your bifurcation QCA. It is divided into 4 segments. Just to see this longitudinal view, whereas your left inflection point of your side branch, the vessel proximal is your main vessel. And just see the figure of 8 from side branch and main vessel pull back. And where you see the first frame of figure of 8, that is your ostium of the distal main vessel or side branch. So the segment from the figure of first frame of figure of 8 to the proximal 3 mm is called as ostium of the distal main vessel. And in the side branch full back from the figure of 8 frame into the 3 mm distal, it is called ostium of the side branch. And in main vessel pull back, the area between the figure of 8 to the inflection point of your side branch is the area of polygon of confluence. That is how the IVS segmentation of left mind bifurcation happens. It is almost similar to what you do with the bifurcation QCA. So what are the various roles of pre-procedure imaging? One is assessment of LMCA stenosis severity. Second is evaluation of ambiguous lesion morphology. Third one is stenting strategy, 1 stent versus 2 stents. And fourth one is lesion preparation. And fifth one is stent sizing. So what happens with assessment of LMCA stenosis severity? In contrast to non-left main lesions, there is a good correlation between IVS and FFR in the left main territory. The MLAs varies between 4.5 mm square, that is mainly from Korean study, studies to 7.5 millimeter study, that is from Mayo Clinic study in the Western population. So what parameters use for assessment of intermediate lesion evaluation? Only one area that has been prospectively evaluated so far, that is the LITRO study, which has used an area of 6 millimeter square. Anything less than 6 millimeter square, they intervened. More than say are equal to 6 millimeter square, those lesions differ. If you see the outcomes, there is no difference whether you intervene based on your smaller lumen area and differ based on your bigger lumen area. There is absolutely no difference in the outcomes. The worst outcomes happen in a group of people where patients had less than 6 millimeter square lumen area and were treated medically. So why not 4.5 millimeter square area? This is a Korean study. If you see that we use a 4.5 millimeter square area, that is 41% mismatch. Most importantly, 25% reverse mismatch. You end up missing 25% of the patients with significant lesion with ischemia that may be missed if you use the 4.5 millimeter square criteria. So how do you use this one? When you find an intermediate lesion in the left main area less than 4.5, and you have to you just advise revascularization. Anything more than or equal to 6 millimeter square, deeper revascularization. When you have in between, you have to rely on other non-invasive or invasive modalities for assessment of ischemia, or if it is not feasible, assess the patient's body habitus, age, presence and absence of remodeling and plaque burden to make decision regarding revascularization. So this is an example of 81-year-old female and with unstable angina who previously had LAD RCS stents. Both came with ISR. She additionally had borderline LCX and distal left main lesions. She had for repeat stenting of this LAD and RCA lesions. Then we assess this LCX. You see that this area is more than 4 millimeters square, which has a very high negative predictive value for ischemia, so that was left alone. And this 81-year-old small stature female, this area of 0.5 millimeters square, even though it is less than 6, can be left alone safely. That is what done for this patient. And the second role is evaluation of ambiguous lesion morphology. You see both the lesions here, both appear similarly, and on your angiographic image, the first one is actually a calcified nodule causing significant stenosis at the left main ostium. The second one is obviously a STEMI patient with a thrombus. Both appear similarly. Suppose this patient is present in ACS but non-STEMI scenario, and IVS helps in differentiating between these two lesions. And this is another patient, 60-year-old female, diabetes, hypertensive, unstable angina, lesions in LAD and OM, come for PCI. This angiogram was done using a 5 French diagnostic catheter outside, but when we use a 6 French catheter, we observed significant ventricularization. So what I was showed here, you just see that distal left main had an area of 26 millimeters square and the diameter of 6 millimeters. And if you see the ostium, the diameter is only 4 millimeters. This is an example of significant negative remodeling, which is commonly occur in ostiums. Suppose you size based on your distal vessel, this patient, you might have produced an aortic root injury. So fortunately, this patient had additional lesions in LAD and LCX, and both were positive by FFR and went for surgery. And this is a 27-year-old female, no cardiovascular risk factors, presented with inferior wall end STEMI. This is an angiogram, smooth appearing distal left main LAD LCX lesions. So this is what the IVUS showed in this patient. You see that IVUS pullback was done from, the wiring was not very difficult, fortunately, in this patient. And this is what the IVUS showed. If you see that there is a spontaneous coronary dissection extending from LAD into the left main. You can just see clearly here, this is, and absolutely there is no atherosclerosis in this patient. And this is the pullback from LCX. So this is a case of spontaneous coronary dissections presenting at STEMI. This patient was left alone, and she's still doing well. This has been done, I think, 2018 or 19. And because there's no flow limiting lumen compromise in this patient, except a bit narrow area at that LCX ostium, the remaining area looked good, and she was left alone for medical treatment. This is an additional other patient, 36-year-old female, diabetes, ostium secundum ASD, severe PAH, bidirectional sign, moderate alveolar dysfunction, presented with recent onset angina. So, and this is what that angiogram showed, and this is an IVUS image here. You can just see that eccentric slit-like orifice of your left main ostium. So this patient, so this is actually what we saw at the ostium, And this patient underwent a stenting for the left main with a 4 into 12 millimeter DES and final optimization, and this is what the final images. So this is a significant left main compression produced by your enlarged dilated pulmonary artery. This is another patient, 41 female, ostium primum ASD, severe PH, bidirectional shunt. This patient did not have much of angina, but during cardiac catheterization, this was what the pediatric cardiologist observed. So we did an IVS imaging and an IFR for this patient. IFR is 0.9, and you see that the lumen areas, even though it appeared very narrow angiographically, it is a well-preserved lumen area. This patient was left alone for medical treatment. And this is an elegant study published in 2017, where what are the various things you observe in a patient with severe PAH. One, this is normal distance. You just see that there is a gap between your left main and pulmonary artery here, even though here the both are contiguity between these two, but there is no compression and there is some form of dislocation, but still lumen areas are adequate. This is what happened in our second patient, and this is what happened in our first patient. So where there is a significant left main compression from your enlarged pulmonary arteries. And this study, about 94 patients had abnormal CT angiogram, where they found the last two patterns and they underwent invasive evaluation. More than 50% diameter stenosis was observed in about 48 patients, and 45 patients underwent a PCI, and 41 had sustained angina relief. So it is not a very uncommon scenario when you deal with patients with the Eisenmenger syndrome with the grossly dilated pulmonary arteries. The one significant finding is most of the compression occurred when your diameter of your common pulmonary artery is more than 40 millimeters. And this is an interesting patient, 42, female, diabetes, hypertension, smoker for a female, and asymptomatic, and had a positive stress test. So he came for a diagnostic angiogram, positive stress test. This is what the first injection. What do you think has happened to your left main? Any guess? And this is what happened after first injection. They stopped injecting and patient remained hemodynamically stable. In view of suspected iatrogenic dissection, she was advised emergency CABG. However, patient refused to undergo the same and got discharged from the hospital. And 2 weeks later, came to our OPD and reviewed. So what do you think? What are the various possibilities in this patient? What has happened? Patient absolutely remains stable, nothing. It is okay. So actually, most probably an iatrogenic dissection, highly unlikely to remain stable, that type of dissection. And the second one is spontaneous coronary artery dissection. Again, it's a very uncommon to get in that, unless you have a left aortic dissection that was extending into left main. It is very unusual to get. So somehow we convinced the patient for an IVS, and it's this, actually this wiring took almost half an hour. Every time you put wire, it will just go on blindly. But see, all the time we were doing in caudal view, this is what happening here. You just goes and blindly end in the cavity. Once you switch to cranial view, we left the wire there and use the second wire. You can just see that how compromised is your left main here. And after wiring, and this is your IVS. Any guess? What do you think this is? And it is a very significantly narrowed left main. If you see that it is a ruptured plaque in the left main. So it is not a dissection, it is an extensive ruptured plaque. You can see nicely the fibrous cap remnants and the cavity there. So this patient underwent stenting for the left main. So this is what the final result is. And the third role is stenting strategy, to select between one stent versus two stent strategy. This is a study from Korea. Whenever your side branch lumen area, osteolumen area is less than 4 millimeters square and plaque burden of more than 50%, those are the patients who had a significant FFR post stenting. So those patients maybe start to straight away start with two stent strategy rather than a single stent strategy. And the fourth one is about lesion preparation. We now have calcium score, IVS-based or OCT-based calcium score. Whenever your score is more than 2 and you need some form of lesion preparation using specialty devices for optimal stent expansion. How do you size your stents? Stent sizing is based on the landing zones, and the landing zones are the site with no plaque or the largest lumen with 50% plaque burden in the proximity of the lesion. And main vessel landing zone should be at least 8 millimeter proximal to the carina for helping you to get a good part done. And stent sizing is based on the distal main vessel landing zone and side branch landing zone. And stent diameter is average of the distal landing zone lumen diameter upsized to the nearest 0.25, taking into account the stent expansion limit in the main vessel. And main branch stent length is the distance between the two landing zones in the main distal main vessel and the proximal main vessel. And the side branch length is the distance between the distal landing zone and the intended amount of protrusion into the proximal main vessel. Part balloon is sized to the proximal landing zone, averaged to the reference lumen diameter and upsized by 0.25. That is how you size your stent and balloons for part and post dilatation. And during procedure, and IVUS or OCT helps in identifying the following things. One, you do a crush. It helps in identifying whether the crush is complete or incomplete. When you have an incomplete crush, it may be very difficult to wire into the side branches. This is an example of incomplete crush. You can just see that wide gap between the stent studs. And the second role is to identify whether your crossing is proximal or distal. It may be a little difficult with IVUS. When your wire goes close to the carina, that is distal crush. When it is close to the bifurcation point and it is a proximal crashing. This is an example of a distal crossing. You just see that the wire comes into the main vessel closer to the carina. So that is how you identify distal crossing with your IVUS. Another important thing is IVUS or OCT helps in identifying abluminal wiring. Here you can just see that this is an example of abluminal wiring. Wire lies behind your stent studs rather than inside the stent studs. And for identifying side branch crossing, Tejas showed elegantly in his cases. So OCT might be better comparing to IVUS because of his 3D capabilities. And this is an example of coulate stenting where the side branch was crossed through the distal cells. You can just see that the wire is going through the distal cell. And here again, wire you can just see going through distal cell. And if you see in two-dimensional imaging, wire is coming closer to the carina. That is how you identify distal and proximal crossing. And after stenting, you do the routine parameters of under expansion, malposition, geographic misdissection, and longitudinal deformation. How do you define expansion? Different criteria have been used. The easiest to remember is expansion should be more than 90% of your reference of either the side branch and the main branch and the proximal main vessel. So that is how you define expansion easily. These are multiple numbers. The latest one is 11.8. 8.3 and 6 millimeters square. That is what the recent Korean study with the double crush data showed. Just remember a number, at least you should be end up getting at least 80% of the reference. That is what at least a minimum requirement for your expansion. And malposition in left main, try to correct any malposition, even though significant malposition is defined as more than 400, length of more than 1 millimeter because of the fear of abluminal wiring. Correct any malposition, at least in the left main. So other places, any malposition more than 400 microns and more than 1 millimeter length requires correction. And geographic miss and any plaque burden more than 50% at the edges, reference lumen area less than 4.5 square millimeters within 5 millimeter of the stent edge. Better to correct. That has been again shown by Dr. Ajay in his presentation. And edge dissections, the same criteria, extension into the media, angle more than 60 degrees and length more than 3 millimeters. That is what the dissection which need for the treatment. So in some examples, this is a patient, a left main bifurcation, double crush. So this is how the optimal extension should be. You see that LCX ostium is 9.6 millimeters square, LAD ostium is 12.1. Your polygon of confluence, we no more use this parameter, but it is 10.8 and the left main is 14.5. This is an example of optimally expanded stent. And this is a patient who had left main to LAD pullback, and part was done with a smaller balloon. You can just see that there's a gross malposition in the left main, and this is what happened after optimized it. We used a 5.5 millimeter complaint balloon to oppose your studs in the main vessel. So this is an example of left main malposition. And this is a patient who had a tap stenting. And you see that amount of protrusion into the left main. So ideal should be less than 3 millimeters. So this is a large protrusion into the left main. And this is again the tap stenting. You see that very small protrusion and optimal tap stenting. And this is an example. This is a patient who had an ostial LAD lesion. The plan was to do a left main to LAD crossover stenting. That was done. And this patient is 110 kgs and severe sleep apnea. And when we were planning to do part, he took a deep breath, everything came out. And it took long time and to rewire it. So somehow we wired and the balloon flossing was done. And this is what the image we got. Anybody wants to take this one? I just play this. I was playing and I put the images here. Sorry, it is not playing. So this is an example of a deformation for there is, you can just see that there is some deformation in the hostile part, but the main deformation is happening in the shaft of the stent. Initially, our thought process after seeing this IVUS image that we went outside the stent and came inside. And that is what the thought process is. We thought we dilated and put an additional stent. But you see that this is one case, stent boost gave more information than your IVUS. You see that we are actually correctly into the lumen. This deformed stents like stents that's producing this appearance of your IVUS catheter is lying outside. And this is what happened after dilating with a 3.5 and 5 millimeter balloon. See that nicely it is expanded. So this is an example of deformation that has happened in the middle of the stent rather than at the ostium. And this is your final result. And this is another patient suspected to have some form of autoimmune disease and a tight ostial LAD lesion. And we dilated it. It was done during one of the workshops. So dilated, and 5 millimeter stent was implanted, and a nicely optimized part was done. And this is what we observed in post-part imaging. There is hardly any stents in the proximal 4-5 millimeters. So again, this is an example of longitudinal. This is almost actually, we didn't have any stent in the left main. So everything has migrated into LAD. Then we did an additional. You just see that fluoroscopically there is absolutely no stent in. So these form of things can happen. It's very difficult to predict unless you do stent boost imaging. Very difficult to predict angiographically. So further dilatation was done. An additional 5 millimeter stent was implanted. And we all know this is a very important phenomena which occurs in left main. The Excel trials shown that 6.5% is your deformation, mostly occur in the ostium, and sometimes it can happen 15% of the patient in the soft. You see that outcomes, 3-year outcomes, it is more than 100% increase in your outcomes when you have longitudinal deformation. And this is our recent study. Again, it has shown that 18.5% deformation rate in your left main stenting. And the most heartening part is if you identify them and correct it, 2-year even rate is 0%. So that is the most important role what imaging plays when you do left main stenting, because the left main is one subset where abnormalities go undetected even for a highly experienced operator. And we see some examples of stent failure. Again, this patient was done in one of the workshops. So initially, it was done long back, 2011. So this is actually, operator felt V-stenting might be okay into this lesion, and lesion preparation was done. Those days only cutting balloon was available. Cutting balloon was done. And this is what we ended up with. You just see that grossly expanded LAD part of the stent, because if you see carefully, there's a big chunk of calcium sitting here that was not recognized properly. And so this is what we found. This patient had sudden cardiac arrest at home after a month, so most probably under expansion related stent thrombosis. And this is one of the patient I showed you, the long Carina tap stenting. This patient came back after 6 months. You see that the entire bifurcation is stenosed, tight stenosis, and that was wired, balloon dilated. And this is what found. It's a calcified lesion. Again, gross under expansion of the stent is a cause of stent failure in this patient. And this is an interesting patient. This patient had ostial LAD and distal left main lesion that was stented from proximal LAD to close to the ostium. Unfortunately, the stent was not enough to cover the ostium. We did an IVUS imaging. There was hardly any plaque, but it is, the lumen was very good. We thought it is not appropriate. We can just leave it. 2 months, you see that patient came back with a tight stenosis at the ostium. So the lesson learned in this patient is when your lumen, your left main is not very big size, better to cover up to the ostium rather than just to leave it ostium uncovered. And this is another patient, 48-year-old female. This is a very unfortunate female. This is what happened actually. This lady came for AVR. We did an angiogram. Hardly any lesion in the left main, and RCA looked very good. So surgeon tried doing some root enlargement and ended up closing RCA and put a vein graft to RCA. And unfortunately, I think she has developed some injury to left main ostium as well during surgery. And this is what within 4 months he came back and see that your vein graft in 4 months, and that was stented. And that is the time you see that left main, it was some lesion was in the left main. We did a FFR, it was 0.83. We thought we just leave it alone. She comes back in 4 months time. Again, the graft is a problem. Then cutting balloon, other things were done. Additional stent was implanted. We reassessed through left main here. This time lesion appeared to be 8 months time. That lesion appeared to be progressive. Did an FFR, 0.83 became 0.76 now. And so we did an IVUS. IVUS showed a minimal lumen area of 6.2 because we have a physiological evidence that the lesion is significant, and we thought we should stent it. Stenting it is a routine stenting. We had a lot of difficulty in maneuvering the catheter across because there is not much space in the root, and the surgeon has put a biggest possible valve. Again, it is very difficult to maneuver. So this is what done. What do you think the stenting results? Any comment on the stenting result? Looked good, right? It is stent is optimally expanded and is coming out of the ostium, entirely covering the ostium. That's what we thought. And she again comes back in 4 months time. So it is graft is now totally occluded. Then we just left it, no point in dealing. And there's no native option because ostium is completely occluded. And you see that FFR 0.65. And we did the IVUS imaging. Any comment on this IVUS imaging? And so the reason is longitudinal stent deformation because there's much of crowding. Most probably when pulled back IVUS catheter or pulled back your guiding, that has deformed your stenting. And so this time went back and dilated. Unfortunately, for the past 6 years, he's doing well. Still she's alive and doing well, and no further events. So simple things, correct? So at this time, we just see that in the end, we took this thing, make sure that the stent is there in the ostium. So it is. So again, this is what the final result is. And these are the rare causes that I've been discussing. I think the last case we discussed, one is your neointimal coverage of your side branch studs. And this is a stent failure that is related to abluminal wiring. When they did a cooler stenting, the wire went behind the stent cells. So this is resulting in your stent restenosis. So to conclude, IVUS guidance in left main PCA reduces mortality and improves patient outcomes, helps in procedure planning, confirms optimal side branch wiring, and confirm that appropriate non-stop crushing and ruling out abdominal crossing helps in stent optimization. So one subset, if you want to use IVUS, is your left main subset. Thank you.
Thank you, sir. Thank you so much. Comments from the chairperson.
Vijay, as expected, phenomenal talk. I have a couple of questions.
Yes.
Given a choice in your lab, which imaging modality will you pick, OCT or IVUS? Because there are a lot of fellows here, so and why?
There is not much difference, as I think alluded in the last talk. It is both should be considered as a complementary modalities rather than competing modalities, and each has its own advantage. IVUS is imaging capabilities, big vessels, CTO, and where you don't want to use contrast, and if you want to do multiple runs of imaging, IVUS is better. But the other thing is, if you want to get a precise information, particularly you take a bifurcation stenting, if you want to see the deformation, and if you want to see the side branch crossing, and OCT is much better than IVUS. And any ASCs, any stent failure, again, OCT is much better than IVUS. And if you get a catheter with both, I think near future we are going to get that would be the ideal modality to have.
So I feel that acquiring images with IVUS is very easy. All you need to do is just de-air, put the catheter inside, and just stand behind and observe. Acquiring images with OCT requires a little bit of training. So, and if you don't produce good images with OCT, the game is over. You will just infer nothing from those images and get nothing at all. But as you very correctly pointed out that both of them complement each other. One gives surface details, the other gives in-depth analysis. There was another question which was asked in the previous session. I thought I'll just take up those two questions. One was in the left main scenario, if you have osteal LAD disease, which is the plaque is extending onto the left main, what would be the approach and how do you do it?
And unless there is a gross mismatch between the sizing of LAD and left main, what you get when you have a dominant LCX. It is always a better strategy to do left main to LAD. That is very easy to deal with if something happens. Suppose you compromise the side branch, that is a scenario very easy to deal with. You just wire the side branch and go put a stent or balloon dilatation. The problem comes when your positioning is not correct. I think we did a study, 130 patients of isolated osteal LAD stenting. You don't believe only 30 stents were in the correct position. 100 stents either inside or outside. It's very, very difficult, even for very experienced. This is all done by very experienced operators doing about 25-30 angioplasties a month. But still, positioning is, it is not that operator's fault. It is the anatomy is such that it is very difficult to nail the ostium. There are so many techniques have been described. I'm sure any big volume operator know that none of the technique is ideal for osteal stenting. And it is whenever feasible, when there is no gross mismatch between left main size and LAD size, where you can use a stent which cannot be expanded to left main dimensions, it is always left main to LAD stenting or left main to LCX stenting rather than isolated osteal stenting.
So probably the only situation where you can do LAD osteal stenting is wide bifurcation.
Wide bifurcation.
So and you're absolutely safe, even if one or two struts come into the left main, which it in effect should come. You are absolutely safe. You can get into circ. That's the only area where you can do the osteal LAD. And the last question before I give the mic to Jay is saline OCT. There was a question but was not answered.
Saline OCT works very well in RCA. So, and in left main, maybe one you have to, in the left side, you have to use more volume or you have to use some form of guide liner or guide extension catheters. I think most of the time, contrast OCT is much better than doing.
Would dissuade anyone to do saline OCT for left system, especially if the only a single, that means only LAD is disease and the circumflex is open. Saline OCT will work on the left. If you have diffuse stenosis in these segments, then you'll have good clearance. But saline doesn't work on the left system. In the right, it will generate good images. Right is a tube. So clearing this thing, and please don't attempt to do half contrast, half saline OCTs. You'll give more contrast. You know, you'll use a 20 cc syringe, you'll generate a lot of pressure, and God forbid if there is a plaque in the proximal parts of RCA, you'll have a good spiral dissection, which is all.
And with one injection in any of the views is more than enough for till you stent it. So that information you co-register it, and one contrast injection. You don't have to take multiple views. So that one good contrast injection and OCT imaging, and second injection you need only when you finish your stenting.
Vijay, it was excellent talk. 2 questions. You have shown that the osteal left main, which is getting compressed by the outer structure. So what will be the natural history of those PCI stenting? And second, those cases which is having a negative remodeling at the left main ostium without plaque burden, without any osteal narrowing, atheromatous plaque burden, would you like to treat that, or you just have to see the MLA? If it is sufficient, you leave it?
And the 2 things. One isolated negative remodeling doesn't produce a significant gradient. If you do an FFR studies have been there. Isolated negative remodeling, even gross negative remodelings. We had even one of the workshops. It was a patient was taken up for left main osteal stenting. Absolutely, there was no plaque. It was negative remodeling, and you don't believe 0.95 was the FFR. So most of the time, if the plaque is the one which creates the turbulence and gradient, it is not the pure narrowing. So the one. The second thing is gross negative remodeling. I would refrain from stenting. See, I think one of few ruptures we have most of the time happens from gross negative remodeling. And in aorta osteal lesion, there is the chance of extending your dissection above your aorta. Better if the patient is suitable for surgery, you send for surgery. That patient, fortunately, we had additional lesions in LAD L6, was good for surgery. And in addition, we didn't have a stent which can expand up to 6 millimeters that time. And if you have to do, and you have to be extremely cautious in doing those type of lesions.
And what is your take on uses of IVL in distal left main calcified lesions?
IVL, we can use it provided that patient remains stable during. The only thing is the stability, means hemodynamic stability. Most of the time we end up just giving 5 pulses rather than 10, means 5 pulses rather than 10. If patient tolerates, and IVL is again a good modality for calcium anywhere.
I think in trust of time, we should conclude the session here.
Thank you so much. Thanks for
thank you, sir. Thank you, Dr. Vijay.
The group.
Thank you, Dr. Vijay. Dr. Jai Shah to felicitate the speaker. Dr. Shaurin Shah, please come on the dais to felicitate our chairpersons, and Dr. Devang Patel to felicitate our experts. Dr. Devang Patel, please come on the dais.
For the next session, I'd like to invite Dr. Tarun Madan and Dr. Hasit Joshi. And our experts are Subhash Chaudhary, Dr. Tejas Patel from SIMS, Dr. Vishal Sharma, and Dr. Devrat. Please join the floor for this session. And I'll request Dr. Tarun Madan to invite our speaker, Dr. George Joseph.
Hello. For our next talk, we have a very distinguished speaker from Vellore, Dr. George Joseph. Sir, he is a master of endovascular interventions. We would learn from him tips and tricks for carotid artery stenting, recent advances. Over to you, sir.
Thank you, Tarun. I am not exactly sure why I was given this topic. It seems rather out of place for a interventional, coronary intervention meeting. And so if half the audience leaves now, I won't be surprised. But if those of you who have an interest in where this field stands today, I will give you an overview of carotid artery stenting. So we all know that stroke is a leading cause of morbidity and mortality, and of carotid artery occlusive disease accounts for 20 to 30% of strokes. And it has been established long ago that endarterectomy is superior to medical management both in symptomatic patients and in asymptomatic patients with atherosclerotic carotid bifurcation disease. So this atherosclerosis that causes stroke is predominantly at the carotid bifurcation. So the NASET and ACAS studies demonstrated that doing endarterectomy is superior to medical management as it was practiced at that time. We are looking like 40 or 30 years ago. So endarterectomy was started in 1953 by Michael DeBakey, and basically they core out the atheroma that's located in the carotid bifurcation. But this is an invasive procedure. Invasive meaning it's surgical, and there's a scar and morbidity and all that. So people have been looking at percutaneous methods of dealing with this, and the first percutaneous carotid angioplasty was done by Klaus Matthias in 1981, and then he's also the first to have done carotid artery stenting in 1989. And in India, we jumped onto the bandwagon in 1996, and this is the first publication on carotid stenting in India, which came out in 96 in the Indian Heart Journal. Since then, there have been numerous studies looking at both endarterectomy and carotid artery stenting. And you can see that over the last 50 years for surgery, that's the top set of bars, and more than 20 years of carotid stenting, that is the bottom set of bars, the death rates and 30-day stroke rates have been steadily falling for both the techniques. And now both the techniques are actually excellent. And we are now in like 1.7% for endarterectomy and 1% for stenting. So techniques have improved on both fronts, and all along we've been comparing these two. But this is the one study that I will put out for you. It came out in 2010. It's the CREST study, which compared surgery, endarterectomy with carotid stenting. And there were 2,500 patients with both symptomatic and asymptomatic carotid artery stenting, stenosis. They were randomized to either endarterectomy or stenting. And the primary composite endpoint was stroke, myocardial infarction, and death from any cause during the periprocedural period. And then they also looked at stroke 4 years down the line on the side of the lesion, ipsilateral. And they had a follow-up of 2.5 years. So if you look at the composite endpoint, it was pretty much the same all the way out to 4 years. Not much difference between the two techniques. But if you broke it up into death, stroke, and MI, death was the same. Stroke was significantly more for carotid artery stenting, 4.1 versus 2.3%, highly significant. Whereas MI was more in the surgical group, 1.1 versus 2.3. And the ipsilateral stroke at follow-up was the same in the two groups. So if when you do a quality of life survey on patients who've had endarterectomy and stenting, they tend to take stroke as terrible. You know, it really affects quality of life. But if you have had a small MI, it doesn't really change your lifestyle very much, because most of these MIs were small MIs. So this kind of result was replicated again and again and again. You know, every study you compare the two, you find the stroke rate is higher with stenting. And the CREST strokes, of course, they were mostly minor, mostly ischemic, mostly anterior circulation, and mostly ipsilateral. But they were associated with significant morbidity and nearly threefold increased future mortality in these patients. So care of all the CREST trial and many other trials, these are the current guidelines. Of course, there are many guidelines. I won't take you through all of them. I'll just take the one that came out last year, the ESC guidelines. And if you look at symptomatic carotid stenosis, endarterectomy gets a class 1A indication if the stenosis is 70 to 99%. And if it is 50 to 69%, again endarterectomy gets the priority. It now becomes a 2A indication, not a 1 indication. So when will you do carotid stenting? So the only indication that is 2A for carotid stenting is if the surgical risk is high and you have a 70 to 99% stenosis, then you can do stenting, and that also it's only a 2A. It's not even a class 1. So this is pretty depressing for us cardiologists and interventionists, that even after 20, 30 years of a lot of work, this hasn't beaten surgery, and surgery is considered the treatment of choice. And if you were to do stenting, you should restrict yourself to the younger age group, that is below 70, because above 70 the risks go up. And then it becomes actually a 2B. So it is not even agreed by everybody that you should do it. What about, so I was saying this high risk for surgery, it can be clinical or anatomic. Anatomic is like if there's been a neck radiation or the various other things that are listed here. So if these are there, then only you will think of doing a carotid stenting. So what about asymptomatic carotid artery stenosis? Now here, currently with very good medical therapy, they say that if the patient is asymptomatic and there are his life expectancy is short, or he doesn't have what are called high risk features. I will explain what is high risk feature for carotid lesion. If those are not there, then just leave him alone. Just manage him medically. Don't do any kind of intervention. So when will you do intervention for asymptomatic carotid stenosis? So if the surgical risk is average, then and there are these high risk features, then you will do endarterectomy. And if in the same group, if you were to consider stenting, it's only a 2B indication. So again, endarterectomy gets the priority. And if the surgical risk is high, and of course, in that case, you will want to do carotid stenting, they still give only a 2B indication. So both for symptomatic and for asymptomatic, stenting has been kind of relegated to second place as compared to endarterectomy. So these are the high risk features which should be there in case you're planning intervention for asymptomatic lesions. So that it could be imaging features or clinical features, and it's something like vulnerable plaque in the coronaries. So if you have large plaques, echolucent plaques, in hypoechogenic area, then you will say that this is a high risk lesion, and you will think of an intervention. Now, stenting has some conditions which you should try and avoid doing stenting, both clinical and anatomic. I mentioned that elderly patients do badly with stenting, and anatomically, if there's a high grade arch atheroma or a very curved arch like type 2 or type 3 arch, then on all these conditions that are listed here, these are not suitable patients for doing stenting. So there are high risk features for surgery, for stenting, and the lesion itself. So, people have been looking at why is this stenting always having a slightly higher risk of stroke. That's because you've got to reach that lesion in the carotid bifurcation. So you have to go through the arch, and if there is atheroma in the arch, you may dislodge that. And then you have to cross the lesion in the bifurcation. And even if you want to put an embolic protection device, if it's a filter, you have to first cross the lesion, then only you can put the filter. So both of these are essentially unprotected, going through the arch and crossing the lesion to put a filter. Of course, now we have a different kind of protection device, which is a proximal occlusion device, which doesn't need to cross the lesion before crossing the lesion. And also, when you balloon the lesion, put the stent, and do a post dilatation, then again you can set off particles, and these particles can be quite tiny. So the filter that we put, it only stops particles more than 100 microns. So they found that 60 to 80% of particles are actually less than 100 microns. So they do get through, even with a filter. So that is why we have more stroke with carotid artery stenting. So people have been now looking at another technique, which is called transcarotid artery revascularization, where you directly enter the carotid artery. So then you don't have to go through the arch. You are directly entering the common carotid artery. So this is called TCAR. So it is a hybrid procedure. That means a bit of it is surgical and the rest of it is endovascular. So you need to make an incision in the lower part of the neck between the two heads of the sternocleidomastoid, where the common carotid is located. And then you put in a very short sheath, and that sheath just goes in like 2 centimeters into the artery. And then surgically they put a loop and they close off the proximal carotid artery, so the flow stops, and then they draw blood out of the common carotid and feed it back through the femoral vein. So they are reversing the flow in the common carotid artery. And after that, they cross the lesion with a wire and put a stent. So this has avoided the two risks that I mentioned in the slide before. That is the risk of embolization when you go through the arch and the risk of embolization when you cross the lesion. So this has done pretty well. Of course, you can't do this if the internal carotid is very small or the common carotid is very small or very short. but it has done pretty well. So if you compare this TCAR with stenting, the stroke rate is significantly less. And if you compare TCAR with endarterectomy, the stroke rate is almost the same. So now you've got the lower stroke rate of endarterectomy without having to do a completely open surgical procedure. So has this made it into the guidelines? The only mention is in the ESVS 23 guidelines, where they give it a 2A indication when the femoral approach is going to be difficult. That is a lot of arch atheroma and so on. The reason why it hasn't made it into all the guidelines is there is no randomized trial yet with this technique. Now, just this month, trial was published in JAC Interventions, the Performance 2 trial. And this is pretty exciting results. This is traditional femoral approach angioplasty, carotid stenting, but with a big difference. One is, of course, you've got to engage the artery and you've got to cross the lesion. So that bit is still the same. But this they have a combined device now which has a stent with a balloon inside and a filter attached. So all three in one. So it's a 3-in-1 device which is 6 French, and it has, this filter has a 40 micron pore size. So it is going to trap a lot more particles than the previous filters. And remember, this is done with the regular filter on top. So this is going through the carotid artery with already a regular filter there, and now this is coming in with a second filter, and then you just have to deploy the stent and balloon it, so the manipulation is also much less. And this is this is the second study. This is Performance 2. Performance 1 was the feasibility study. Now Performance 2 is a pivotal trial, and pretty amazing results. The minor stroke rate 1%, that is, and then the intention to treat stroke rate is 1.3%. And that when you follow them up to 1 year, it doesn't go up very much, just 1.4 and 1.8%. So this is the lowest rates ever reported. And what is new about this system is that we have this 40 micron filter, which is going to filter out much more of the particles than before. And this is associated with the lowest ever reported rate of stroke in any type of carotid revascularization, whether it's surgical or not. So now they're moving to a comparison, the use of this in TCAR. So you can, instead of going through the femoral artery, now you go directly in and then use the system. So it may be even lower when you do it in this way. And that's going to be the next study called Performance 3 study. So that is where carotid stenting stands today. The new techniques coming in which may finally tilt the balance away from open surgery. So what about CABG and carotid disease? This is a common problem that we face in our practice. So if a patient has to go for CABG and he's got carotid disease, then what should you do about it? So if it has been symptomatic, that is TIA or stroke in the last 6 months, and it's an ipsilateral carotid stenosis 50 to 99%, then you need to do revascularization. They recommend endarterectomy today, and it can be either along with the CABG, that's synchronous, or staged. So first endarterectomy, then the surgery. In all other situations, if it's a total occlusion or the stenosis less than 50, you don't do anything for the carotids. What about asymptomatic? Here again, in all situations, you don't do anything except if it's bilateral and severe. And then again, you do either staged or synchronous endarterectomy and then the bypass surgery. So that is atherosclerotic carotid bifurcation disease. Now, the topic says carotid stenting. So we do carotid stenting in a number of other situations other than just atherosclerotic bifurcation disease. And I'll just go through a few of those conditions. One is carotid aneurysms. And I'll show you a few cases. Now, this is a patient who came with neck pain for 6 months, inflammatory markers high, and he had a left carotid bifurcation aneurysm, which you see on the CT reconstruction here. This is what the angiogram looked like. It's sitting right under the bifurcation. So these can be treated with covered stents. Now, I'm told that my videos won't run, so I'll just quickly skip these, and I won't be able to show you this one. Okay, that was Viabahn stent. Now, this is another case, similar case with carotid aneurysm. Here it's the right common carotid artery, and this is the angiogram. And so here we deployed fluency stents, 2 overlapping fluency stents, and then a bare stent right on top to smoothen out the angulation that was at the top of the fluency. The fluency stents are rather rigid, and that is the result we got. And this is the follow-up. You can see that the stents are patent and the aneurysm is excluded. In some situations, we use balloon expandable covered stents. Here's a 47-year-old female with an aneurysm. This is a large aneurysm of the common carotid artery. The artery is quite compressed, and there's also disease in the right subclavian artery, and the vertebral artery is patent. So here we put Jomed covered stent in the common carotid artery, and then we put a stent, a bare metal stent in the subclavian artery, and we got this result. So you can see the aneurysm is excluded, the subclavian is patent, the vertebral is flowing, the carotid is flowing. And this is the follow-up 2 years later, showing patent stents and excluded aneurysms. This is an 8-year follow-up of the same patient. Again, a pretty good result in all areas. Nowadays, we use the Covera stent because we don't have the Viabahn. And so this is a large aneurysm treated with the Covera stent. This angio is running. You can see this was a very difficult to cross aneurysm, but we managed to cross it. And we don't put stiff Amplatz wires into the internal. We actually put 2 Roadrunner overnight wires, and then over that we deploy the stents. So that's a Covera stent being deployed, and then we extended it the bare metal stent to stabilize it. And this is the final result there. And this is the follow-up CT showing the patent stent and thrombosed artery. This is the 3D reconstruction of the same thing. And we can also do the same thing in pseudoaneurysms. This is a internal carotid artery pseudoaneurysm in an infant, 8-month-old infant treated with a covered stent. That's the follow-up CT. And this is another pseudoaneurysm, huge one of the common carotid artery treated with a covered stent. So this is pushing the artery forwards, and that's the Covera stent being deployed across the aneurysm. So in conclusion, you can actually treat most of these carotid aneurysms and pseudoaneurysms by covered stents, and you need femoral access long sheaths, and we don't put stiff wires up into the internal carotid. We rather use 2 Roadrunner guide wires, give dual antiplatelet therapy for 3 months, and immunosuppression is mandatory, and you need long-term surveillance. Are we run out of time? I can, few more slides I've got. The last area I want to talk about is carotid stenting in Takayasu arthritis, which we published our series on percutaneous interventions in 23, and we had 942 patients undergoing interventions, and in these we treated 2,450 lesions, and many of them multiple times. So we had 2.6 lesions per patient and 1.5 interventions per lesion. And the carotid was 333 patients, the lesions, 333 lesions. So if you look at the outcome in the different vessels, the best outcomes we get in the aorta and the iliac arteries. The success at follow-up is more than 90%. Then come the carotids, renals, and mesenterics, where the success at follow-up is more than 80%. And the subclavians and the coronaries do the worst. They have success rate more than 70. And on the extreme right is the average number of interventions required per lesion. So they are all around 1.4, 1.3, except the subclavian, which is 1.8. So subclavians need repeated intervention because of restenosis. So carotids, 80% of them are stented, and we usually underdilate these lesions. Initially, we just do a plain balloon and underdilate the lesion to avoid hyperperfusion, and we may stent only at the second sitting. So by the time you follow up, the success rate goes up. So there are three issues with carotid stenting in Takayasu arthritis. One is crossing these occlusions, because many of them are occlusions, avoiding cerebral hyperperfusion, and dealing with restenosis. So I'll show you a few examples. Here's a lady who came with bald aortic arch, all arch vessels occluded, syncope, diminished vision, stroke. So we opened the right carotid first and the left subclavian and left vertebral. And this is the follow-up. And then we opened the right subclavian and right vertebral and the left carotid. And we stented the left subclavian. So this is when we finished opening all the vessels. And this is 2-year follow-up and 4-year follow-up. Similar case, innominate left carotid occluded. So we opened the innominate and the right vertebral, and then we opened the left carotid. And then this is follow-up at 3 years and 5.5 years. So the problem of opening all these in one shot is the risk of hyperperfusion. So in this patient, we had opened the right carotid and then we opened the left carotid, and the patient developed an intracerebral hemorrhage, which proved to be fatal. So you shouldn't open all these vessels in one shot. You should do it in a graded manner. So to cross these occluded common carotids, you should see the internal on angiography through collaterals. If the internal is occluded, then it's a contraindication to recanalization. And to avoid hyperperfusion, do staged dilatation. Preferably don't stent in the first sitting, just do a balloon dilatation, stent 6 months later. And then don't do all the lesions in one shot, do them in staged manner. And restenosis basically correlates with disease activity. So you have to be aggressive with immunosuppression, and then just plain balloon dilatation repeatedly finally succeeds. And you should use long balloons to prevent melon seeding, because you can have intimal embolization and stroke if you use short balloons. So I'll stop with that. Thank you for your attention.
Thank you so much, sir. That was indeed an excellent presentation on carotids. Any comments from the experts?
It's a very nice presentation, sir. We have this problem of cerebral hyperperfusion, atherosclerotic carotid disease also.
Yes.
So
yes.
what's your take on that? And also, do you recommend testing for autonomic dysfunction in these patients?
No, I don't think it's related to autonomic dysfunction. So if a patient comes with bilateral carotid disease and has ischemic cerebral symptoms, syncope, TIAs, those are the ones that are likely to develop cerebral hyperperfusion. So if you are going to do these cases, don't do both sides at the same time. Do only one side. And if it's Takayasu, you don't have to stent the first time round. You can just do a balloon dilatation. Then post-procedure, put the patient in ICU and check. Keep checking whether they're having headache, blurring of vision. In worst cases, they have seizures and all that. So bring the blood pressure down. So very aggressive lowering of blood pressure in these patients, and you have to keep it down for a few weeks, because this can happen up to a month later, this hyperperfusion symptoms. But it can be fatal. So if it's not it's seen after endarterectomy also. And the literature says it's slightly more common after stenting, but I'm not sure why that is so.
Undersizing the post-dilation balloon help?
Yes, you have to take a balance between keeping the stent open and facing stent thrombosis and undersizing. So generally, if you're doing atherosclerotic carotid stenting, never dilate more than 5 millimeters. That's the absolute limit. In fact, if the result looks good, don't even do a post-dilatation, because post-dilatation when the maximum number of emboli go up.
One question. Excellent lecture as usual. Any role of a drug-coated balloon in Takayasu?
Yes, I had mentioned in the last slide, we've been using drug-coated balloons to treat instant restenosis, and a marginal benefit over plain balloons. Nothing very dramatic, like maybe 5% difference. That's because Takayasu is a pan-arteritis. So there is inflammation going all the way to the adventitia. And this drug is never going to reach the adventitia and reduce the inflammation everywhere. So we don't see great results with drug-eluting stents and drug-eluting balloons. Drug-eluting stents we compared with bare stents, no difference whatsoever in restenosis rate. Drug-eluting balloons, a marginal difference, something like 35 versus 40%.
Thank you very much, sir. And I request Dr. Tarun to felicitate speaker, and Dr. Jaisha, please felicitate chairperson, and Dr. Utsav, please felicitate our experts.
For the next session, would request Dr. Ajay Swami to chair the session and Dr. Anup Gupta. And experts in the same session are Dr. Sandharb Patel, please come on the dais, Dr. Nikul Panchal, Dr. Abhishek Rawal, Dr. Jeet Prambhat. And this talk is about tips and tricks to manage calcified nodules, a deep dig into the LCBI. And we have a distinguished speaker among us, Dr. D.S. Chadda. Please come on the dais, sir.
Good afternoon. It's a great pleasure to introduce Dr. Chadda, my senior teacher, colleague, and an expert in all kinds of complex intervention. So we're going to look at tips and tricks to manage calcified nodule, not mangle it, but manage it.
Thank you, Ajay. It's always a pleasure to be here. I think my third consecutive year. Always happy. So over the next 30 minutes or so, I'll be dealing with the calcific nodules. Managing calcific coronary artery disease is challenging because the lesions are very complex. We know they have very high syntax score. There is left main with triple vessel disease. Lesions are tight, angulated, and they are ostial in location. CTOs are not uncommon. Most importantly, these patients are elderly. They have multiple comorbidities, COPD, diabetes, CKD. It's not uncommon. And if you look at the lesion morphologies, calcific nodules and thick circumferential plates. Now, it's these morphologies which make the procedure even more complex. Now, if we look at calcific nodules in the subset of ACS, they account for about 5% of the patients presenting to us with acute coronary syndrome. That's probably because of thrombus formation over the surface, and they are associated with very poor outcomes. As you can see on the slides, the MACE rates are very high, and the other outcomes in terms of other long-term outcomes are equally bad. Cardiac death on a higher side, you have TLR rates on the higher side, and you have more stent thrombosis. So this is a very difficult subset. Before I launch myself into this, and if you see the slide, it tells you that the event rates in a lesion or a calcific bed where there is a nodule, the event rate is going to be 3 times higher. So I thought we'll just touch upon a little bit of pathology of the calcific nodule, and we'll see as to how it develops and how it comes into being. Now, it's generally seen in the proximal segments of all the large vessels. That means, as you can see on the slide, in the proximal or the mid part of the RCA, it commonly involves, mainly seen in the proximal LAD as well as in the proximal circumflex. Why this part? Because this is the portion where you have a larger necrotic core. This is the portion where you have a big gap between the intima and the media. So more plaque buildup can happen in these areas. Well, when we look at the evolution of the atheroma, I thought I'll just touch upon this part. It all starts with the deposition of ApoB, which binds to the proteoglycans, and this causes diffuse intimal thickening. The next thing which happens is the vasa vasorum start growing. They attract some monocytes coming in, mature into macrophages. These macrophages in turn internalize the lipoproteins and become the foam cells. And when they kind of rupture and they are engaged in some constant activity of preventing atherosclerosis, that means there is TGF beta as well as interleukin which is coming in, which kind of takes away the apoptotic cells. But it's at times difficult for them to keep pace with the degenerative material which is being produced. And what happens is that there are some vesicles which are left behind which have not been taken up by these macrophages, where hydroxyapatite gets deposited, and that leads to microcalcification. As this microcalcification grows, it becomes macrocalcification. So in effect, what is happening, as you can see in this slide, it all starts with spotty calcium, which becomes an eggshell calcification, and there later it becomes hard shell calcific nodule. Now, why I'm telling you all this? Because this has got implications on what I'm going to tell you in my talk subsequently, because this is kind of what we used to read in anatomy. What I'm going to do now is applied anatomy. We are going to dwell upon on the basis of what I have told you. Well, as I told you, the calcific nodules develop in the proximal part of the vessel. These are the parts where there's a lot of torsional motion which is going on. So the necrotic core here builds up, and it's in between the calcific. Can I have a pointer? It's in between the two calcific plates that you get to see. Yeah. So these are the calcific plates, and in between them there is a necrotic core built up with calcific plaques, and this core is now gradually calcifying, and at the hinge point it starts protruding, and moment it protrudes, it breaks open into the lumen of the vessel, and you have a nodule formation which now breaks into the lumen. Now if I use the OCT images, this is the commonest type of plaque which you get to see, which is the superficial calcific plate, and this could be thin, thick, it could be segmental or circumferential. Now multiple of these plates, when they coalesce, they break open into the lumen of the vessel. When they break open, there is a little bit of thrombus which comes along with it, a fibrin which is there, and they have a very jagged surface, and this is what is called an eruptive nodule. This is a biologically active nodule. It accounts for 25% of the nodules of the calcific plates which we see, whereas a nodule which is just protruding from the media into the surface of the vessel is smooth, absolutely smooth. There is no jaggedness or irregularity over its surface. It accounts for about 7% of the total nodules seen, and this is biologically inert. It does nothing at all. So how do we evaluate? Now that we've seen that there is genesis of these nodules, how do we evaluate? Angiography is not good enough, but what you see on angiography could give an impression of a thrombus, But if you see something, the positive predictive value of angiography is about 94%. But many a times, I'll show you case examples, nothing is seen and you find a nodule which is there inside. So angiography cannot differentiate between eruptive and protrusive nodules. Well, we use imaging, but imaging except for the OCT, the IVUS is not going to tell you whether it's an eruptive or protruding nodule. So this was a case which we did last week, 9th of January. There was a distal disease in the RCA. So we thought a discrete lesion we'll get in, and you see what happened. The balloon, now a small balloon also is not getting into the proximal part, which looks pretty okay. It doesn't look to have anything there. And when we did the OCT, there was a big protruding nodule which was lying just next to the wire. As you can see, the wire biased by the guiding catheter. And this was a protruding nodule which prevented. So these are nodules which are not visible, on angiogram. Well, the limitation of the IVUS and the OCT is that IVUS produces a kind of acoustic shadow, and beyond that you can see nothing. And unfortunately, even OCT produces a negative shadow. OCT otherwise in a calcific plaque goes around the vessel. It can give you the thickness of the plaque, but in a nodule, the segment is so thick that it also creates a kind of negative shadow, and you can see nothing beyond it. So the OCT is also not very helpful. There's one technology which has been found to be slightly useful in the imaging segment, which is near-red infraspectroscopy. Now, near-infrared spectroscopy is capable of telling you about the configuration of the plaque behind the calcium plate. So, which neither IVUS or OCT can tell you. Do we have an equipment to do or to study the same? Yes, we have the Makoto machine with us. This is a dual imaging catheter system which kind of gives you co-registered images of IVUS as well as NERS, so that you get to know the plaque morphology as well as the composition of the plaque. HD IVUS is going to tell you what is the structure, and the NERS is going to tell you what is the composition of this plaque. By composition, what I mean is that, I must give you the background. The NERS has been used transcranially in the past to measure the cerebral oxygen concentration. It has a very high sensitivity, specificity of picking up lipid. And this is an histological confirmation of that. The core localization of lipid histopathologically as well as on NERS, but it temporally does not localize whether this lipid is superficial or is deep. So they did about 2,500 cross sections of cadaveric coronary arteries, and they found 95% sensitivity, specificity of NERS to pick up the calcium, to pick up the lipid pools. Now, how it works is that you have the NERS signals which get into the vessel and they get reflected back, and they generate a kind of probability score between 0 to 1. A score of 1 gives it a bright yellow light. Anything closer to 1 makes it little oranges, and if it is close to 0, it makes it red. So this is a kind of a color-coded interpretation of the vessel wall composition, which is called the NERS chemogram. So red means no lipid, yellow means lipid. If you see a few black dots, they are being produced by the artifacts of the wires. Now it quantitates, it not only detects, it also quantitates on a scale of 0 to 1000. LCBI score of anything more than 400 is considered to be significant. You also localize the point where you get maximum LCBI, which is called max LCBI. Any max LCBI score of greater than 400 is considered to be significant. Well, you see this max LCBI score which comes automatically when you do the run. This implies that in this necrotic core, 82.4% is lipid. Now, I must tell you here, since I'm not doing an ACS talk, it is lipid and only lipid which leads to thrombus formation. If you have a necrotic core which is devoid of lipid, you will have absolutely no slow flow or no reflow happening, or you will not have any kind of distal embolization which is leading to TIMI count flow less than 3. So it's only lipids which produce slow flow. Now, what has also been seen is that as your LCBI score goes up, the calcium in the vessel increases. So that means LCBI helps you determine plaques, or tells you about the plaques which are biologically active. And if you look at this forest plot, those with LCBI score of more than 250 had more calcium. That means these are biologically active plaques which are of advanced phenotype, and they'll lead to more calcium at a later date. How is it different? IVUS NERS, it's a dual imaging modality catheter which assesses the structure and composition. It has got a bigger imaging range than most of the existing systems. It images about 150 millimeters. It's got 3 variable pullback speeds of 0.5, 1, and 2. The lens moves bidirectionally. A click of button, the lens comes back to its original position so that you can do a pullback. You don't have to manually do anything. It's a very sturdy catheter with very good pushability, but most important is that it produces some amazing imaging pictures. So these are pictures which at times when I've gone around centers, people have said it looks like black and white OCT. Very nice images. The advantages, You have a co-registered nurse available which tells you about the plaque composition. It not only picks up the lipid but also quantifies it. And how does it help? It takes the prescription out of the lab to the OPD. If you're dealing with ACS, you know that the LCBI score is very high. You need to continue statins or add anything more to statins to get the scores down. And now this helps you predict, and there are a lot of studies, I'm not going into that. It basically helps you predict the MACE rate at a later date. That means those vessels with higher MACE score will have higher event rates, as was shown in the LRP and the Prospect 2 trial. The characterization of lipid behind the calcium, you'll see the applied anatomy of this in my subsequent talk, is basically helpful in selecting the tools which are required for dealing with the calcific lesions. Now, having talked about LCBI, let's come back to the calcific nodule and let's see as to how we go about managing these calcific nodules. There's a simple algorithm which I've made. If you have a suspicion of a calcific nodule on angiogram, the first thing you do is coronary imaging. So it's the intravascular imaging which is going to confirm the presence, and you kind of define what kind of nodule is this. Is this an eruptive nodule or a non-eruptive nodule? And your approach thereafter is going to be dictated by the type of nodule which you picked up. If it's an eruptive nodule, the first question is, can you deform this nodule? Or if you have the facilities of Iversners, you'll apply Iversners to look at as to the character of this nodule. I'll give you case examples. So if you cannot deform the nodule, you will have to rely on atherectomy tools plus minus IVL, and thereafter regressive dilatation has to be done. If you can deform, nothing else is required. It's a deformable eruptive nodule. You just do aggressive dilatation and stenting. But if you have a non-eruptive nodule, it's the orbital only which is going to help you. Road ablation is not going to help. I'll tell you the reasons why. Once you've dealt with the nodule, you have to ensure that you have an optimal stent expansion, and that is what is going to produce good results. But not all the patients you're going to do this. Certain patients who have only isolated nodules, CABG is an option, because the results of calcific nodules, I told you, is much worse than dealing with superficial calcium plates. So you must keep that option also open. Well, case examples of deformable nodule. This, as you can see, an angiogram with a shelf in the LAD, calcium nodule which was there. We did Iversners for this, and what you see is circumference. This is a calcific plate with the acoustic dropout, and you can see circumferentially this has a large lipid pool behind. So this, on Iversners, we could make out that there is a nodule, but this is at a stage where there is a lot of lipid pool here. We don't need any specialized atherectomy tools. This is a deformable nodule as defined on Iversners. The nurse shows a lot of lipid here, and no wonder his score was very high. 816 was the max LCBI score. That means the lipid pool in this calcific so-called plaque or the nodule was to the tune of 81%. So we just dilated. Now, as I told you, it does not localize. So this lipid could have been within this plate or could have been behind the calcific protrusion. Nobody can know this for sure, but it definitely implies that this is a nodule which is deformable. So what is a deformable nodule? That means when you dilate these nodules, the wire remains in the center and it does not go to one side. And a non-deformable nodule, you'll see the wire hugging only one side, and the balloon inflating only on one side. On the other side, it's not inflating at all. Correct? So this is a deformable nodule. This is a non-deformable nodule. Fine. So what we do is, and these things you have to keep in mind, we dilated this and you see the kind of slow flow. I was telling you, if you have high LCBI, you get slow flow. Now, it is very rare that you do a calcific lesion dilatation in a native coronary vessel and you get to see slow flow. So that's not very common. Now, this has been studied in a small study where they divided the patients into two pools. That means those with the small calcific plate and the large calcific plate. They noticed that the patients who, they are different cutoffs which they mention, but it's not uncommon to get slow flow in these patients. What is the reason for this? This probably could be distal embolization, redistribution, nobody knows. But if you have a high LCBI score, you should be prepared that there can be slow flow happening in these segments. Sorry. So we went ahead and stented, and this is the stented part. You see very good imaging qualities. The LCBI score has already come down to 260. This is a cartoon commensurately showing that a deformable nodule, which could be either of these two situations, it gets pushed and you get good MSAs in a deformable nodule. There's absolutely no problems in that. And this was the final angiogram of this patient, and it looked pretty good, both on imaging as well as on angiogram. Now let's look at some non-deformable nodules. Now atherectomy, as I told you, if it's non-deformable, atherectomy is of choice. Rotablation is suited for uncrossable lesions. So rota is the only front cutting device. So if you get into a situation where you cannot put anything across, it's rota which is going to bail you out, because this is a front cutting device. But does rota work in nodules? Yes and no both. What it does is that it does need a suitable wire bias, but most importantly, it modifies the nodule very little. So that means there is always a need of having large size burrs with a suitable guide wire bias, a combination of these two. And most importantly, what is true even for all the atherectomies in nodules, your MLA at that segment has to be very small. I'll show you a little later on about that also. So you can combine now rota with the IVL and do, and how it works is this way. Rota shaves off the peak, and thereafter you use the shock. You're using shock, it's like a dynamite. You're going to now crack this calcium, and once you crack this calcium, everything settles down and you can go ahead and stent. So that's how your rotatripsy works in a nodular calcium. Shave it and then kind of shock it, and you get the desired results. And this is what we did in this case. We went ahead, you can see the nodule here, so it's non-deformable. We did rotablation, post-rotablation, and now it was shown in the morning, and I show you my pictures. So this is a normal vessel, this is a suitable guide wire bias, and this is a eruptive nodule, and this is what is differential cutting. The normal vessel wall remains intact, and what rota does is a very small modification here. So rota, it depends on the size of the burr. So this is the kind of modification that you get, which is not sufficient for you to reduce the nodule. So this is probably a downside of the rota, but this is how it works. So it's a true front cutting tool for uncrossable lesions. We did IVL. There was a significant IVL waste to begin with, a little bit of air in the balloon, but thereafter on the fourth cycle there was no waste, and we went ahead and stented. For paucity of time, I'll skip. This is post IVL. This was the final LAD run. The nodule is kind of completely flattened. Well, longitudinal profile of the OCT, jutting nodule, and the nodule has been flattened post IVL. Now, how does intravascular lithotripsy work in a calcific milieu? Well, the advantages of IVL is that it works independent of wire bias. It modifies the nodule as well as the surrounding calcium, which is very, very important. It modifies both the superficial and deep calcium, and it kind of restores the vessel compliance, which is what leads to stent expansion. The outcomes which were noted in this current study was similar in patients with or without calcific nodules. So this is a big plus of IVL. That means it produces outcomes which are similar in patients those having and those not having calcific nodules. Now, protrusive calcium is a different ballgame altogether. Neither rota or IVL are going to help you as an isolated device. You need something which debulks, and this is where the role of orbital atherectomy comes. This was the RCA, which was previously stented. There was a big nodule, again, one of the recent cases. This is the kind of nodule which was there. And this is the nodular segment. We'll come to that. It's kind of hugging. So nodule. Now this doesn't have jagged edges. It's got very smooth edges. So it's kind of jutting into the lumen of the vessel. So this is a protrusive nodule. And we did orbital atherectomy for this lesion. And this was stented. Now, you see the pictures as to how it happens. This is a calcific nodule. The areas are very small. The nodule post-ablation, correct? And this is nodule post-stenting. So you get good MSAs, you get good luminal gain, it debulks the nodule tremendously. If you're using orbital atherectomy, thereafter you don't need any specialized balloon. NC balloons are good enough and they will work very well. So orbital atherectomy is most suited for debulking. It is best for large vessels. You start at lower speeds, then go to larger speeds, but the requirement is that the MSAs have to be small. Because if the MSAs are large, the device is not going to work. You see from this paper, those with MLAs less than 2.5, the percentage reduction was nearly 40%, and those with the larger MLAs, the reduction was only about 17%. It stands to reason, if you have a very large vessel, we know that orbital as a tool rotates and orbits. If your orbit increases, your centrifugal forces come down because it works with the formula where radius is in the denominator. So if the radius increases, your force comes down tremendously, so your debulking will not be good. Now in the ostial segments, we need to use a different protocol. There are a lot of ostial nodules which come. Now for the ostial lesions, the most important thing, there was a question in the morning, whether we should do retrograde or antegrade. This will answer that question. The crown has to be advanced, and if you are able to advance the crown beyond the nodule, you do start with the retrograde burring and then you can do antegrade and retrograde. But if you're not able to advance, then most important thing which you have to do is that you have to make your guide catheter coaxial, push the nose cone inside, and this should constrain the crown. If your crown gets constrained, the game is over. Then you will be able to get inside and come out. If OA engages, yes, then you can, after the initial pass, you can do antegrade, retrograde. If the crown does not engage and it does not go in, please don't waste time. You will be dancing right on top of the nodule. You can damage the vessel, you can cause perforation. Get into either rota or laser and do this case. So the other thing which has been seen with the orbital is that it works best in the aortoosteal lesions. Within the coronary segment, if you have CTO segments, please don't attempt to do orbital atherectomy. It will kind of perforate because now the burr is rotating or orbiting in a confined area and it can cause perforation. So you should be very mindful of that. One such case, ostial RCA nodule. The guide catheter wasn't, if you see in this image, the guide catheter here is not coaxial at all. We made it coaxial. We pucked the nose cone, it constrained, and the orbital was done. And thereafter, after having done that, we stented the vessel with good results. Whenever you're dealing with calcium, you should use stents with good radial strength, and probably the best stent suited for calcific milieu is Megatron because it has the highest radial strength. Well, stent optimization in calcific nodule is equally important. And what have we seen over this? There are certain predictors of calcific nodules which tell you that your stent is not going to expand very well. These are patients who have greater circumference of the calcific nodule and there is a lot of surrounding calcium, there is negative remodeling, or you have with your tools not been able to fracture the calcium well. Stent expansion, as I shown you in the case example, is more symmetric with eruptive nodules. Malapposition is pretty common in calcific milieu. One should not chase this with aggressive balloon dilatations, you will have complications. So as stated, in a deformable nodule, you get good stent expansion, but if you have a protrusive nodule, you will not get good expansion and you should not chase it any further. Case examples on the OCT, this is a nodule which is jutting out. These are the stent struts. It lifts the stent struts and it doesn't let you oppose here. That doesn't mean that you take a larger balloon and start dilating. It will not happen. You should not do it. So similarly, some malapposition which is correctable, some is not correctable, you should accept. And there is enough literature. Yellow dots show you the calciums, and there is enough literature which tells you that stent edge dissections as well as incomplete stent appositions are very common with nodules. So you should accept them. Overall, patients with nodules, as I told you, that they have worse outcomes. The TLR rates are much higher. And if I have to compare between these two, or eruptive and non-eruptive, or protrusive or eruptive nodules have much worse outcomes. This is probably because there is enough literature to say that there is reprotrusion. Because these are at hinge point, these are broken small calcium fragments. They protrude through the stent struts. then this happens within 6 months. There are a lot of case reports. And the other thing which can happen is that there can be small reprotrusion which gets calcified, or there can be recurrence which can happen. So overall, the eruptive nodules have much higher rates of target vessel failure compared to non-eruptive nodules. To summarize, I would say that there's need to identify these nodules. There's need to characterize whether they are deformable, non-deformable. In the eruptive segments, non-eruptive nodules are kind of stable. There are different tools which I showed you, case examples, which can be used for treating these nodules. Generally speaking, calcific nodules produce worse outcomes compared to those segments where there are no nodules. Amongst the two, the eruptive nodules are deformable, but they are notorious in terms of reprotrusion, so one has to be careful. The bottom line is treat the nodules only if there is an indication. So you have to keep the thresholds for treating nodules on the higher side. You shouldn't just go ahead and treat a nodule because it is present. You should treat it only if the patient is symptomatic and it's the reason for the symptoms. Imaging plays a very vital role. IVUS nurse holds an advantage over the OCT and IVUS. I showed you case example because it kind of tells you there is a lot of lipid pool behind. These are deformable nodules, or these are nodules which are early in their stage of pathogenesis. That means they have eggshell calcification. That means there is calcium on top, there is lipid core inside and calcium behind, and you can really deform these nodules. Well, you need a combination of tools to use in this setup. As I told you, eruptive nodules treatable, protrusive nodules are non-deformable, and they can cause stent under expansion. So please be very judicious in your approach towards these lesions. Thank you so much for your patient hearing.
Fabulous talk as always, and finished perfectly on time. Any questions from the?
Excellent talk. Couple of questions from my side. One is, after ROTA, how do you decide on imaging? You want to use IVL versus cutting? One thing. Non-deformable, what you said. So how aggressive you go, like, 1:1, or sometimes you go more than 1.1 in the vessel size before deploying the stent?
So your first question was about the eruptive nodule where we use root ablation. So there both angio and imaging is going to help you. How angio helps you is that it indirectly tells you the vessel size and the amount of nodule or the quantum of calcium which is there. As I told you, that root ablation is going to do a very little job. It will just shave the tip off if there is suitable wire bias. You definitely need to put in a balloon after that. And if you see dog boning which is happening in the balloon, you need to upsize your burr. If there is no dog boning and with 2.5 you are able to push this nodule behind or crack it open, the job is done. You need to upsize your burr, or else the better strategy is, as I showed you through the carton, that you shave the tip off, use an IVL, crack the base of the nodule, then use a balloon, and you'll be able to push it completely back. So, see, what happens is there are two things which predict stent expansion in calcific milieu. One is dissections, two is your fractures. If you feel that it's a very isolated calcific segment with a nodule, and on imaging or especially on OCT you've demonstrated a lot of fibrous tissue around, you can use cutting. Generally speaking, between the two atherectomy devices, there's definitely a role of cutting or a scoring balloon with ROTA. But with orbital, that role is very less, because orbital is a debulking tool. NC balloons are good enough. You don't need to cut or do anything, because we know that when we go on higher speeds, we induce dissections with orbital. So NC balloons are good enough for orbital. If you're using ROTA and if you feel that this segment hasn't opened well, cutting balloon is obviously going to help you. Now the cutting balloon adds to the cost. So it also depends who's on the table and what is the kind of insurance or the background the patient has. Perfectly all right. You can do that, but take it from me, cutting is not equal to IVL in a nodular calcium. So we are talking in context of nodular calcium, not for normal calcific plate.
Sir, have you come across any case of nurse IVUS where you can get the LCBI of 1000?
Yes,
because
I have one case right here.
Because we have done two cases along with you, and both the cases, they were around in the range of 400 to 600.
I have a ACS patient with a perfect score, and we had a lot of slow flow, no flow in that patient. It's their case example.
Thank you, sir.
Can you use the mic? I can't hear you.
To prevent microvascular obstruction, do you feel rota is better or orbital is better?
So I think this question was very well answered by Ashwin sir in the morning. So the particle size which orbital produces is nearly 1/3 that of the rota. And so microvascular sludging is not seen at all with orbital atherectomy. That is why if you read the IFUs of the orbital, it is cleared even in patients who have LV function of 25%.
But the speed of the rotation is less in the orbital compared to standard
So,
rota.
I mean, see, it's not in context of my talk. What happens in orbital atherectomy is that you have two components which are happening. One is the rotation of the burr. It's not a front cutting device. It's sanding the lesion. It's a crown which you have put inside, which rotates at two speeds, which is 80 and 120. So it kind of does a differential sanding. At the same time, it's an eccentrically mounted crown which orbits. When it orbits, it allows flow in between. Rota is a front cutting device, and once it goes in, it stops the flow. That's why Ashwin sir was saying that you need to give some flushes in between. In orbital, you don't have to do that, because once it is orbiting, it is allowing some amount of flow into the distal vessel. When it orbits, it basically it generates centrifugal force where the burr goes and hits the calcific plate. Maybe it is causing some fractures there, but it's not documented. That is why I was saying, smaller the vessel, greater is the efficacy of the orbital crown.
In that case, why to use rota? Why not to use orbital in every case?
No. So if, see, as I told you, this has got diamond burrs on the crown. It's like a ring which has got diamond burrs. So it will not get into tight lesions. It will not get into osteal lesions. It'll not work very well in very long segment disease, because orbital atherectomy has to be done at a speed of 1 to 3 millimeters. And if you go at such a slow pace in a very long vessel, patient will have a lot of discomfort. A front cutting device, rota, is irreplaceable in tight, balloon uncrossable and osteal lesions. So it's going to work the best in these scenarios.
Thank you, sir. I think in interest of time, we conclude this session. Would request Dr. Anup Gupta sir to facilitate our speaker, and request Dr. sir once again. Dr. Bhavesh Thakkar to come on the dais and felicitate our chairpersons. Dr. Jay Shah to felicitate our experts. Dr. Jay Shah to felicitate our experts, please. You can click a picture of Jay with all of them. Yeah, together. Thank you. For the next session, would request to chair the session Dr. Urmil Shah. Please come on the dais. Dr. Jayesh Prajapati. And experts in the same session are Dr. Vipul Kapoor, Dr. Pooja Vyas, Dr. Zishan Mansoori, Dr. Dhruv Jadeja. And for this session, we have a very distinguished speaker from Bhubaneswar, Dr. P.K. Sahu sir, who would be speaking on OCT versus IVUS, a tug of war, when to choose what in ambiguous lesions. Dr. Vipul Kapoor, Dr. Pooja Vyas, Dr. Dhruv Jadeja, and Zishan Mansoori. Thank you.
Good afternoon, everybody. In fact, thanks to Dr. Shah for bringing me on the podium. Last year, I was talking online. In fact, when I think about all these things, I think when we were doing our DM under Professor Mehta, we never had any problem about this calcium nodules, etc. It was only one thing, rota, no imaging, nothing. but things were very simpler, but day by day it becomes complicated. Now the tough job is OCT versus IVUS, when to choose what. Now since morning we have been listening about OCT and IVUS, everything is good, but let us try to see what happens. This is not a debate, not with one coming with a dynamite, another with a bomb. So it is just that we should have an insight, and I'll give my take about what I feel where OCT should be placed and where IVUS should be placed. For example, if I show you this picture, can you identify a crocodile and an alligator? Very difficult. You must have seen multiple times crocodiles, multiple alligators. The simplest answer, the crocodile is next to the alligator. That's very easy to say. So that is why this is where the two spectrum comes, whether OCT or IVUS, both are complementary, but I'll give about my take. Now, when to use IVUS and when to use OCT. Commonly, when you used to see the angio, the first thing that you said, dude, I just see a hole, nothing else more than that, some plaque. But believe me, after this imaging came, there is more to see and evaluate. And people go on evaluating so much, and the table on the patient is on the table, and then the next cardiologist knocking at you that you have to clear the table because I have got 2 more patients. That's the whole thing. Now, my take about all these things will be on these subset: aortosteal lesions, LMCA, bifurcation, calcific, ACS, tackling ISR, BRS, CTO, renal failure detecting. All these subsets have been dealt with. I'll quickly go with some examples. First, aortosteal lesions. See the typical left main osteal lesion. Very difficult to know with OCT. The best thing is to go ahead, take an IVUS, do the procedure, and you see the pre and the post. There are specified criteria where you know that you have done a good job. So definitely IVUS is the answer. Now here, supposing in this case, you might feel that the osteal, all osteal are to evaluate it properly. For example, this case, the MLA is 4.11. So this needs that you have to work on it, use a cutting balloon, and then go ahead. Cleaning blood from the aortoosteal junction is really difficult and it's problematic. So definitely IVUS is the choice when you're dealing with LMCA osteal lesions. Next, we come a little bit further to the LMCA lesions. I find this quotation very important. We are among interventional cardiologists here, but it's important to realize that there is scrutiny in the left main space because the results of the surgeons are good. The surgeons are much better than us in left main. We have to accept that. Whatever may be the reason, whatever amount of debate we do, and if it is our relative, possibly would have sent it to the surgeon. So just don't consider the LMC as a tubular structure. As it is said, that definitely intravascular imaging is beneficial in LMC lesions. But when do you do it? All LMC interventions. This is the take-home message that should go. If you're dealing with LMC lesions and you have to compete with your surgeons, you have to use it in all LMC lesions. There may be borderline LMCA and osteal LMCA, shaft and distal. For example, whether to stent or not, this is a very common diagram from the JAC, which shows that if it is in 4.5 to 6, you go for FFR. If it is beyond 6, just leave it alone. If it is less than 5, try to do something for it. Now, these are the recent criteria which states that we do not stick to the numbers of 5, 6, 7, 8. We now have to go to the numbers of 7, 9, 12. This is the minimum criteria that we have. But of course, Indian population is a little bit lesser in size than the Western population. So we have to follow it. And the values are only validated by IVUS. It is not validated by OCT. So the take-home message is IVUS is for left main. So these are the figures that we should attempt. What we should aim for, as I told, larger the better. But at the same time, if I show this case, this is a shaft left main with a LED, where I went ahead with this thing that is IVUS, and I saw that there was a very fibrotic plaque and the area was significantly occluded. So the next thing to be done was to just go ahead and go for a single stent strategy after doing a cutting balloon. And post cutting balloon, you can see how the cuts have come. You can see the red arrows which are showing the cuts. And after the cutting balloon, you can see it has expanded to 6.55, but there's still more to do. That is, you go with one of take a run from the circ to the LMCA so that you're sure that you're not obstructing the circ osteal, and then go ahead with from the LMCA to LED, and you have acquired a 10.7, which is more than sufficient for your LMCA. So in LMC lesions, you have to be very careful because just doing a stent, putting a stent does not finish the job. There is something more to be done than that. Now, it is seen that in LMC lesions, almost 74% of the patients we have to change our strategy. We may think that we have done a good job, but possibly not, so we need to change. Now, if you ask me where do I use LMCA, OCT and IVUS, if it is an ostium, mandatorily you have to use an IVUS. If it is the body or the bifurcation, you can use either of them. Because sometimes it is very difficult to imagine because it's very peculiar. All LMCs are not same. So you have to be very careful that where to use which modality. But IVUS would be my choice of this thing imaging in LMCs. Now, so IVUS scores over OCT in left main, mainly ostial, and usually if the vessel diameter is more than 5, because many left mains that we deal are more than 5, and OCT will not cover in the spectrum, and you'll see that is not possible. Now, very little data with OCT about LMCA lesions, so try to stick to IVUS. That's a clear-cut message that should go. Next, come to bifurcation lesions. We have two questions to be answered. Will my side branch be compromised, or should we go for a single stent or a double stent strategy? There are all guidelines which some people say it is single stent, some people say double stent, with the complex, the lesions. So we know there are certain eyebrow signs, which is LMC LED, which gives us an idea from the angio itself or on the IVUS that no, we need to go for, need to expect that this might occlude. Now, baseline, you have to do an IVUS run and have to see. And then if there is an IVUS sign is present and the eye sign is present, eyebrow sign, possibly occluding. So be prepared to keep a wire there and try to see what is to be done best. OCT has good predictors in side branch occlusion. There are two things, the cranial angle, which is less than 50, or the BPCT, that is branch point to carinative angle, carinative length should be less than 1.7. I'll show you two examples. Bifurcation lesion, how I decide one stent is possible. Take this case, a 48 years male, recent ECS. I calculated the CT angle and the BPCT length. BPCT length is 2.7 millimeter. The carinal angle is more than 70 degrees. Single stent only. You'll never crush your side branch. Very simple, single stent, keep the procedure simple, and there is the lesions. Wide, the side branch is flowing well, you don't have to be worried. So OCT helps by specific criteria about how to do a bifurcation. The next case, which I'll show, where to use a two-stent strategy. Now, you see this case. It has almost a Medina 111, the LED diagonal lesion. Here also, when I took the runs, I saw that the BPCT length is quite small. It is 1.5, and the carinal angle is just somewhere around 45 degrees. So outright two-stent. No, nothing to worry. Go for two stents, where you'll fall in trouble if you go for one stent. So this is the steps that was a DK crush was done, and this was the final results, the pre and the post. And the post PCI LED run of the bifurcation, which shows the lumen to the circumflex is very well opened up, nothing to be worried, and you can leave the patient very safely because the stents are well opposed. Now this is a post PCI diagonal to LED, where you can see everything is well opposed and the patient has got a good carina, the results are good. Both are useful in bifurcation. What you have in your lab, you have an IVUS and OCT. I have both, so it is my prerogative, and seeing the patient's pocket, I use what I have to do. Now let us come to calcific lesions. Both are good, but definitely for OCT is better. We have demystified the calcium scoring, and we have good scores where, for example, as Dr. Chadda was showing about a calcium nodule, you can see something in the right coronary artery. You can see something, structure. Is it a thrombus or is it a calcium? This can only be known when you do a pre-imaging OCT, where you can see the calcium nodule very much present. There is a 360 degrees calcium, there is a calcium nodule, there is calcium. So naturally, you have to debulk this lesion, and the way to do it best is what I thought based on the calcium scoring. The calcium scoring had 2 points of the arc, 1 point of the length, and 1 point of the thickness. So naturally go for higher modality of debulking, and the best what I could use was IVL followed by NC balloon, and that did the trick. Went with an IVL 3.5 into 12, 6 atmosphere, 10 cycles, 100 pulses given, and this is the imaging where you can see the post IVL cracks. You can see the cracks very well, and this means that you have done a job well and you straightforward go ahead with the NC balloon and then deploy the stent after the NC balloon, the results will be definitely good. So these are the final OCT pictures, but you can see the lumen area has gone up to 9.21 even in the calcium nodule, but don't be too aggressive because you may rupture the artery. So this is how OCT helps us in calcium nodule, and possibly that is the tool that is to be used, because in calcium nodule in IVUS you get lot of reverberations and you are not able to see what is beyond. That is the final results that you can see, the small calcium nodule. This is in fact a member of the parliament who presented with ACS, and this was the problem with him, and I couldn't know what to do. I thought it's a thrombus, but it was a calcium nodule. Now, a very problematic thing is when we do not prepare the bed and we just go ahead and do a stenting. This is what happens. Now, if you see this thing, the stent has been given, and this was done by one of my registrars. In fact, he did it, he thought it's a cakewalk, and you see what has happened over here at the red arrow. Still the stent is not opened up. So here this OCT gives us a lot of idea, because OCT penetrates the calcium best compared to the calcium on the IVUS. So whenever you see calcium, think of the Titanic, because OCT helps in managing calcific lesions in a calculated manner. The Titanic sank because it didn't know where the iceberg was. That was the whole problem. So now there is quantifying calcium can be easily done on OCT, and based on that, on these three criteria, we know what is the protocol to be followed. For example, this one, balloon uncrossable lesion, looks calcific. So the best thing to do is, you can see the time track calcium over here. So you are sure there is a 3-cystated calcium, and it's a balloon uncrossable lesion. So the best thing is to go for a rotational atherectomy or an orbital. We didn't have orbital that time. This was a case done in 2020. So this was what we did. We just went ahead with the rotational atherectomy. And then this was a post-rota, this thing, calcium debulking, which you can see, but it still needs work to be done. So we had to work on an NC balloon. And finally, post-NC, you can see it has expanded well because the shaving has been done. And based on this, we could put in our stent, and this is a result of post-stenting, where we can see that the stent has expanded. The area that was totally occluded or very constricted has expanded well. So these are some cases which can be easily seen on OCT, and the results are good when you do it. Deciding when to use IVL, very clear. You do a calcium scoring either by the IVUS, this is known to all of you. But then came the generation when I started working with the 40 megahertz. For 6 years I worked on 40 megahertz. It was like the standard TVs. But then came the high definition TVs that were the 60 megahertz. And believe me, the 60 megahertz IVUS is almost similar to OCT, but I'll show you some cases where I've done OCT and IVUS in all these cases. For example, calcific lesions. If you see the first image that is of OCT, you can see almost a big chunk of calcium. Same thing with the 60 megahertz IVUS, you can see there is a big chunk of calcium and nothing seen between. So these OCT and HD IVUS can be compared and can be usable in such cases. And you see after the IVL has been done, you can see the cracks over here, and also you can see the cracks on the IVUS. Only thing is that IVUS is easy to use, OCT is easy to use, means easy to interpret but difficult to use, but that is the vice versa for IVUS. Next, the stent was given, it was compared, a larger lumen seen in the IVUS, a smaller lumen seen in the OCT, but the stent is well expanded and is well opposed. Next, the problem with calcium on IVUS is that there are reverberations. The scoring systems are not very well documented. The OCT would be my choice if it is for calcific lesions. Then let's just come to ACS lesions. ACS lesions, we know that we have to do an OCT because we want to know whether it's a plaque erosion or a plaque rupture. If it's a plaque rupture, it's a stent. If it's erosion, it's all your pharmacotherapy. Now, imaging modalities have improved so far as IVUS or OCT is considered in acute coronary syndromes. This is a plaque rupture where I have done both the HT IVUS and the OCT, and you can see this is the classical case of the plaque rupture where you see, and similarly what is seen in an HT IVUS. So both are comparable. If you don't want to use more of contrast, do a good imaging with IVUS and you can get it. So stent this lesion because it is a rupture. Similarly, in erosion, you can see
that you can clearly see the erosion on the OCT and you can see on the IVUS. It's a little bit difficult to interpret an erosion on IVUS, but if you're used to interpreting images, you can see how the IVUS, ST-IVUS looks like. So I do a lot of cases where I do both modalities just to check my knowledge, whether my knowledge of IVUS is correct or whether, because OCT confirms a lot of things which IVUS doesn't, and you keep learning in that way. So no stent over here, just leave the patient out. Now, red or white thrombus, erosion or rupture, all you can know by OCT only, no IVUS. Next, tackling ISR, definitely for ISR, the best way to do is to go for an OCT. So, for example, this case was a case of 2011, which was done, and here we did an OCT to know what is going on. There was an ISR of the LED in 2020. So, after 9 years, this patient comes, and this is what I see in the ISR of the different segments after a little bit of predilatation. What do I see? I see a long segment involving a 90% of the stent length, beyond the stent and proximal to the stent. It was an undersized stent that I had put in 2011 when we didn't have imaging. Significant luminal layering, it is a homogeneous one, and extensive neo-intimal proliferation. So here normally what I do, I debulk with a cutting balloon, use a NC balloon, go for a larger size stent with a different compound, post-dilate at high pressures, and finally check with an OCT. This was done, and finally this was the result. And if you see the pre and the post ISR intervention with a 338 stent, and if I show you the images of the OCT post ISR stenting, it looks pristine, the diagonal is well preserved, the LED is well preserved, and there is almost 90% apposition well expanded, and the apposition index shows white line all across. Strut coverage, new atherosclerosis, stent failure, always go for OCT. Now, let's come to imaging BRS. We have to agree that for imaging BRS, OCT is the choice of imaging modality. And this is what happened. This patient underwent an BRS, and you can see whether the images, there is some amount of malapposition. This can be further dilated, but I have got cases where the BRS fractures. You go to very high pressures, but finally you get good results and you can leave it at such. So for imaging, you get a better visualization of the device and ideal follow-up for follow-up in these cases. So OCT is a choice of imaging modality. Let's come to CTO. CTO requires a lot of flushing during OCT and may propagate dissection. So IVUS is the point of interest. In fact, I have not brought any CT. Here you take the CTO catheter to the side branch, and from the CTO you can know where is the proximal cap and try to assess it if you are in the true lumen, and then optimize your post-treatment that is results. But here you might have to take a 8-Finch guiding if you want to do the procedure along with the imaging catheter and along with all your devices. Last, PCI and renal failure. We know that low and no contrast PCI IVUS helps. It is a hyperreality. Definitely, if the patient is an advanced renal failure, use saline flush for protection. For example, this is a very simple case for a patient of CKD with creatinine of 7, where the 2 marker wires are there. You just do an IVUS, put your stent, and just then finish it off with just 3.5 plus 3.5 cc contrast. One for the imaging, one for the last shot. This is all that is done. So pre and post stenting angiograms can be easily done, and people are doing a lot of work on this, on post that is no contrast procedures, but I believe that is a misnomer. There should be minimal contrast. Then contrast load may exacerbate renal function, so always use IVUS in CKD. Lastly, detecting complications. For example, this is a case of proximal LED lesion where there is a tight lesion on OCT, and for this case, extensive dissection occurred when balloon was used in the LED. Now the problem was, for this extensive dissection, I had to put another stent from the LED till the LMCA, and after that you can see the results are very good, and we have achieved whatever are the required diameters, 100%. Now supposing you have a dissected LMCA, sometimes you might have like this. The coronary angiogram was done in another center, and they did an angioplasty of the proximal LED, and what they did was the PTC of the procedure done at 3.5 into 29 DAs was put, and what happened later on was the artery got closed. They didn't have any imaging method over there in that center, and moreover, the patient started having chest pain, was immediately shifted to our center, and this is what we saw. There's the last dissection, patient reaches our hospital with ongoing angina and hemodynamics, but were luckily stable. I just told him, don't take out the sheath, just send the patient the sheath inside. And this is what we saw, and you can see how the dissection has taken place in the left main. And so there is no other way out but to take another stent, cross into the true lumen, put the stent, and come out. So this is what I did, a 5 mm into 22 DS was put, and this was the final result, what we got after putting a second stent. And this is the result where you see the left main is well protected, the patient became asymptomatic and finally did well. Detecting complication dissections, definitely OCT is better, but be careful, because if you have a 60 megahertz IVUS, you can use it if you don't want to use contrast or you don't want to give forcible injections. So definitely you have to take a choice between the two. Now, malapposition and under expansion, angiography cannot help. Even like, for example, malapposition is when how many strats are beyond this 200 microns, and under expanded stent is a stent which does not expand in the heart eccentric lesion. Very simple. This is malapposition, and this is under expansion. So you have to differentiate between these two. What is malapposition, what is under expansion, and you have to go, and OCT helps in that. I'll show you an example. This is an acute antival MI, window period 15 minutes. The patient was taken on the lab for a primary angioplasty, thrombosuction done, stented, post-dilated, port done, and finally you see what you see over here. It is still under expanded. Malapose, under expanded. So here what has to be done, you go for a higher size balloon and go with a 4.5 balloon, you start expanding it, and you see it is well apposed now. This is the final OCT. So if you have to detect very clearly about malapposition and under expansion, get an OCT done, and that really helps. So this apposed and well expanded. So now both these images are like the third umpire. If you cannot detect anything, call for the third umpire and they will give you the detection. They will tell you what is to be done. Is he out or is not out? And I finish with it that don't be deviated by these colorful images, because even these black and white images are equally good. But you have to choose, this is not a tug of war, you have to choose which modality to place where. So here I finish with a very simple story that two buffaloes were waiting. They were waiting something seeing on the river. First person told CH is enough. The other person, no, IVUS or OCT is required. The first buffalo was very confident and he told that, let me jump in. It's nothing but a log of wood. So he jumps in. It's nothing, just a log of wood. Nothing, still nothing, log of wood. Finally, there was an alligator who gobbled him. And then the next buffalo says, no, OCT or IVUS is required. So this story is that don't underestimate any lesion. Whatever imaging modality you have, use it so that you get the best thing. As it is said, to summarize, that you use OCT in all these conditions to study the morphology, length, diameter, polarization, dissection, apposition, expansion, and keep your IVUS for CTO, LMCA, oscillation, advanced CKD. So this is my take home, that this is where you have to place your devices. What? So I finish with it that we are lucky that it is now a class 1A indication as per the European guidelines, and any form of imaging, whether an IVUS and OCT, can be used to see that you do a perfect job. So two cats, black and white, it doesn't matter. The color of the cat doesn't matter as long as it catches the mice. Thank you very much for the patience.
Thank you so much, sir. Thank you.
Thank you so much for Dr. excellent talk on IVUS and OCT. Any questions?
Hello. So I just wanted to ask one question. In case of medial dissection or flaps, if you are using OCT, what special care you ask your registrar to take while injecting the saline or the contrast?
See, normally, if you are very clear of a dissection on the angio, you need not go for an OCT, number one. Number two, if the dissection is very extensive and you see that you are not able to differentiate between the true lumen or the false lumen, something of that sort, you have to be very careful injecting. I usually use a hand injection. I don't go by an injector. Because sometimes we just need the information that what is the extent of the dissection, from where I have to land, and what will be the size.
If the wire is in, then better to stand first and then image.
Yes, put in wire, and if you I always, what I do first, take a run of an IVUS. If I'm very comfortable by wiring the true lumen, then I see what is taken OCT also. I use them interchangeably.
Sir, we have IVUS criteria which were being used like 5, 6, 7, 8.
Yes, yes, yes.
So 7 was for POC.
Yes.
Now with the recent advancement,
You go much higher.
yes. So
But POC is not important these days.
it's not.
No, it's not.
So there is no need to go ahead with the both.
Don't go calculate. Just see the main, this thing.
Figure of 8 is enough.
Figure of 8 is enough. Try to achieve more in LMCA, up to 11, 10, the more the better. So long you don't cause any complication.
Sir, you have shown the last case where the left main dissection was transferred to your center.
Yes, yes, yes.
So at that time, by injecting the dye to get the OCT image before stenting, that is any
Actually,
special-
what happened, first when I crossed the wire, I was not sure whether it was in the dissection or not. I took a risk of doing an OCT to know whether I was, till what is the extent of the dissection. That is why I did an OCT.
Regarding the newer AI-enabled technology, will make a difference for IVUS and OCT interpretation?
Yes, no. People are more into AI, but trust your eyes more than the AI. That is what I'll say.
Sir, these osteal lesions with OCT, with the telescope catheters and all those things, I think you can still get away with, if you don't have an IVUS, I think you can still get away with an OCT, isn't it?
Yes, it is correct. But what you do that when you push your telescope catheter inside, then you start having problems. Because in the IVUS, you can keep your guiding outside and you can take it. Because not necessarily that the ostium has to be round. It may be a conical sapate or something, various shapes of this thing, ostium is there. So I prefer to use this thing that is IVUS in osteal lesions. That is my this thing device of choice.
About the saline OCTs, I think that also are now quite possible, mainly in LEDs and all, maybe RCAs may be difficult.
LEDs, no.
Yeah.
RCAs means I don't use saline. In fact, people go very good images, but I don't know. My technicians, I don't get so good images.
Regarding the IVUS catheter of Philips, Miss Volcano and this one Boston, deep difference is there. So in CTO specific things.
I have no experience with the Philips catheter. Both my devices are of Boston.
Thank you very much, Dr. P.K. Sahu. I request Dr. Jayesh Prajapati to felicitate Dr. P.K. Sahu and Dr. Tarun Madan to felicitate our chairperson and Dr. Dhruvkumarsinh Jadeja to felicitate all our experts. Jayesh being the person, Dr. Tarun.
For the next session, would request Dr. Prakashvir Parekh to chair the session and Dr. Bhupesh Shah, sir. Experts in the same session, Dr. Kiran Prajapati, Dr. Karthik Natarajan, Dr. Ronak Shah, Dr. Pankaj Singh. Please come on the dais. And would request our speaker, Padam Bhushan, Dr. A.B. Mehta, sir, to deliver his talk. Audiovisual team, please be ready for the next talk. Connection live થઈ ગયું? Okay.
What about the height slides? Show the height slides. Moving you. In the coffee break, I was asking the people who were at the back, I said, are you able to see the slides? They said, yes. I asked them, are you able to hear me? They said, yes. Any problem? Yes, we are not able to see you though. So, because with minuscule structure of mind, visibility could be a problem also. Anyway, when you do CTOs, you also acquire mastery over non-CTO lesions, because some of the techniques which are used in conquering a CTO would be quite helpful in situations like tortuosity, hard lesion, non-crossable lesions, non-dilatable lesions, etc. I think a CTO, you must prove first of all, when should you do a CTO? 3 things are required before you address a CTO. Number 1, you must show that that CTO is responsible for the symptoms of the patients, namely angina. 2, that if not, then it should be related to a left ventricular dysfunction, the ischemia related dysfunction in relation to the CTO. And thirdly, you yourself must make a self-assessment that would you be able to successfully do this CTO or not. Without that, I think you should not. If your success rate is 70% and above without producing myocardial infarction, death, then I think you can make an attempt to do a CTO. So dedicated CTO hardwares are microcatheters, dedicated wires, of course, balloon and stents, and those are lesion specific and anatomy specific. Let me illustrate what do I mean. You see this particular case, the origin, the right coronary is anomalous in origin. The vessel has not been adequately and properly cannulated. The proximal segment is so very proximal that just in case if I need for support by taking, let's say, an anchoring balloon, that may not be possible. The entry point is not very clear because a couple of branches are coming out at that point of time, at that point of anatomy. Missing segment, now it's important. If the missing segment, that means if you have outlined the proximal segment and the distal segment by contralateral injection, and if they move in opposite direction, then the intervening missing segment is curved and tortuous. I repeat, if the proximal segment which you have seen by antegrade injection and the distal segment you have seen by the contralateral injection and the missing segment between the two, the antegrade opacified segment and the distal segment, if they move in opposite direction, the intervening missing segment is tortuous and curved. All right. Okay. The importance of bilateral injection is that very often you will find that the CTO is much shorter than what you anticipate when you do the bilateral injection. And here again you see that the antegrade injection is not collateral, it is not coaxial. The catheter is actually not selectively engaged, and therefore this you know very well that you can't use the same. But when you use an AR2 catheter, now it has selectively been engaged, and you can see that CTO is a little bit easier than what you thought initially because it's outlined well. Microcatheters. What is the function of microcatheters? So many times people ask me, how about over-the-wire balloon? No, it's not a substitute for two reasons. Over-the-wire balloons have a larger profile. And number two, I think the over-the-wire balloons, we use it sometimes to save the cost, but that is not so because over-the-wire balloons, they have a heart. And second thing, the microcatheters, the inner lining is with PTFE coated, Teflon coated. So therefore, it has a smoothness and the wire movement is sleek. Second thing, the space between the microcatheters lumen and the wire is just minimal, so that it hugs the wire quite reasonably well and do not allow it to dangle. So you should use microcatheters and not the balloons. All right. What does it do? It facilitates wire and gives the support. It gives you an opportunity to change the wire very easily, and you do not have to keep on re-entering the coronary artery again and again. With a microcatheter, you can do a super selective angiography. It can increase the tip load. When you bring the microcatheter closer to the tip of the wire, the force, the power of the wire is enhanced, can increase the tip load exponentially. Lower crossing profiles than angiographic catheters and balloons, and better torque and pushability, and these are the properties of microcatheters. There are two which I have addressed, three: Fine Cross, Corsair, Crusade, and the latest is Corsair Pro XS. Corsair Pro XS is now my preferred but microcatheter. Before it came in, Fine Cross was my preferred microcatheter. And why Fine Cross was my preferred microcatheter? Because A, it has a tapered tip. 2, the entry profile was very small, 0.01718, and therefore snugly fitting and easy crossing profile, allowing the penetration very easily. Okay. Carvel is a better profile, but Carvel cannot be rotated. If you rotate the Carvel, it will fracture, and that will create a problem. Corsair Pro XS, Fine Cross, they can be rotated, torqued. You can't do that with Carvel. Okay, so the resistance for rotation, and that is what will happen if you attempt, so do not rotate the catheter. CTO wires, we must know all about. So many CTO wires, but basically we must achieve the penetrating efficiency. What is penetrating efficiency? Penetrating efficiency is dependent on three factors. The tip, the surface area of the tip. For example, some wires are tapered. Filters 0.009, Conquest Pro 0.009, Conquest Pro 820 0.008. So these wires which are tapered, they have a better penetrating efficiency. Tip load. What is a tip load? The wire which can bear the weight when it is straight and yet not bend. For example, on a wire which you hold straight and put a load of 12 grams on the top of the wire and yet it does not bend, the tip load of the wire is 12 grams. Combined together, side lubricity. If the wire is hydrophilic or polymer coated, it is very easy to slide. So combined together, the sliding property, the tip load, and penetrating efficiency by tip surface gives you a total penetrating force, which I think is proportionate and based on the three properties which I just enumerated. Recently, one more wire has come that is called Suho wire. Suho wire's tip load is very, very low, 0.3 grams only. And this wire is specifically used for entering the septal channels for retrograde CTO procedure. All right, so same case now I'm showing you. So now here we see that the proximal artery is very adequately cannulated, and I have used a wire, and this wire, having entered up to a certain distance, is not able to cross any more further. So I started to think about using Gaia 2 wire and not Conquest series, because Conquest series wires are not easily torqueable and are meant for straighter segment. Anywhere if there is a curvature, they will easily create a perforation or dissection, and therefore Conquest Pro is meant for a specific purpose. So finally the Gaia 3 wire entered, but when we check by the contralateral injection, it is trying to enter the side branch. Is it seen clearly? That is trying to enter the side branch. This is the side branch. Okay. So I tried to change the direction with a Miracle 6 wire, but it did not happen. So I decided to go into the side branch, confirmed its location. Yes, I am correctly in the side branch, and dilated the side branch. When you dilated side branch at the level of the fibrous cap, the distal entry point, there is a dissection there. That dissection allows the side branch technique here, illustrated diagrammatically, creates a dissection which can become then a penetrating point in the target artery in its distal segment. This is called side branch technique. One can profitably use this technique where it is available and where the side branch, the main branch, distal main branch segment is difficult to enter. Then I dilated that area with 1.2 and then followed by 2 millimeter balloon, and then brought the microcatheter back, and I can now very clearly see the artery. Now it is very easy to enter. Brought the microcatheter back and made an injection through the microcatheter and saw that there is a visibility of a distal segment. Then Whisper extra support wire successfully crossed the right coronary artery and dottering with the microcatheter, and then we placed 2 stents, one by one, distal first and then proximal, and this was the final result. So this side branch technique is worth learning and can be useful when you have one more thing, parallel wire technique. What is a parallel wire technique? Many times you come to know that your wire has entered a wrong dissection and a wrong lumen, or it is subintimal. Only you come to know when you have opacified the distal segment contralaterally injected. You realize that wire is not going into the correct passage, but it's wrong. So then how do you do? Let me show you the principles. First of all, penetration of the proximal fibrous cap and CTO vessel is straightened up. The wire is entered into the false passage. Then you have to use a second wire without removing the first wire. You may make 1 or 2 attempts to correct this by rotating the wire, but if you do more frequently, only the false passage will start enlarging and making the true passage smaller and smaller and more difficult to enter there. So then you take a second wire. The second wire should be a little stronger than the first wire in tip load. It has a more angulation and it should enter beyond proximal to the point where the wire has entered into the false passage. The second wire is helpful because first wire has blocked the passage. It is also gives you a geographical mapping, and thirdly it gives you some support. The second wire running parallel, and it comes down here and enters the true lumen. So this is the principle of parallel wire technique. So here again, the first wire has a smaller angle, second wire has to have a little bigger angle because it has to re-enter and enter into the true lumen. The angle, secondary angle also is a little bigger, and the second wire should be stronger. So let me show you the example of parallel wire technique. This is a stumpless CTO of LED. I can't see anything. So there are two ways to approach this. A, either completely retrograde. B, I use an IVUS and try and find out that where is the carina, and if the carina is found, then I find that is the suspicious area where it could be arising, the LED, and try to penetrate under the guidance of IVUS. Or thirdly, is that after having found by multiple injection a protrusion, a stump, I decided to enter with Fielder XTA wire, pilot wire, but both of them have gone into the false passage. So I said, let me go and try the retrograde approach. The retrograde approach also had failed, and now parallel wire technique with again 2 wires, but both the wires are in the false passage. The third wire is only a reference wire going into the ramus. So these both wires were in the false passage. So then the next day decided to do again the parallel wire, and we used a Conquest Pro wire. The retrograde technique which I showed you is failed. Here is the retrograde coming from the right coronary, septal, and trying to enter, but it came to a broomstick appearance here. So we can't do it. And finally, the Conquest Pro wire entered. Subsequently, I don't have a slide, but then I think the cannulation followed by stenting, recanalization of the artery, and revascularization was easy. Sometimes the artery is calcified, curved, and tortuous, and the distal segment also is calcified and tortuous, like as in this case. First of all, it is traveling upwards, so little bit shepherd's crook kind of an appearance that makes the entry a little more difficult. There is a large branch available here, which I can use as an anchoring balloon technique, so that I get the support to this guide catheter, and then I started. So Fielder XTR, Gaia 2 not crossed. Ultimately, cyan black wire successfully crossed. Now why? Cyan black has a less tip load, only 0.6, but it is a tremendous lubrosity because it is polymer coated. And it has a very high torqueability. If you find a correct microchannel, then I think even a soft wire can enter. But after this, the microcatheter would not enter. So I had to take an anchoring balloon technique. 1 or 2 words about anchoring balloon. You must always use the useless or clinically insignificant vessel. Here, this is a sinus node branch. Intermittently, I might have to deflate it, not to produce sinus node ischemia. Try and go as much distally as possible and anchor it with an appropriately sized small balloon at not more than 6 or 8 atmosphere. Thereafter, I tried to enter and produced a serial balloon dilatation, done, and delivered the stent, and that was the final result, which I think, I'm not sure, I'm sorry about it. But now this is an RCA CTO. Sometimes it looks very simple. This is a short CTO, and you think it's going to be a cakewalk and will be done in no time. After the bilateral shoot, you realize that yes, it's easy, small segment, straight segment, but it was extremely hard. BMW with microcatheter to bring the microcatheter up to the surface, up to the entry point, and then change to Fielder XTA wire. And after that, the fine cross and 1.2 balloon, nothing crossed. It would just not cross. Anchoring balloon technique did not work. Nothing would cross still. So then what to do now? I decided to take tonus. Tonus is that microcatheter which is 8 strong wires are interwoven in the form of a rope, and when you rotate it clockwise and anti-clockwise, it slowly enters and creates the patency, And little patency is good enough to allow the microcatheter to go, and subsequently you can address the CTO after regular balloon dilatation, and this would be the final result. 2.5 40 millimeter long stent, and this was the final result. In case if the tonus fails, then you have still two options: laser, and occasionally we had to resort to laser, but the laser might not be easily available in many labs. But I think if the tonus doesn't work, what you can sometimes do, wedge it as much as you can, and then change over to rotawire and then do a rotablation. Sometimes you have to have a primary retrograde approach, and this is possible. This is required to be done when there is a total occlusion at the level of stump, like LAD stump. So here you go into the donor artery, study the collaterals. These are straight collaterals. If the collaterals large and straight, they are very good, class 3, according to Werner's classification. If they are tortuous and small, they are bad. But between the two, the size and the tortuosity, I would say the one which is smaller but less tortuous is still preferable. The regular wire has been brought up to here. Over this, I thread the microcatheter. After threading the microcatheter, I make an injection through the microcatheter. And I find that there is a broomstick kind of an appearance here, out of which I will have to select that channel which connects accurately and goes forward. So I change the wire to Sion wire. This is a Sion wire which has gone all the way up to the proximal fibrous cap, but Sion wire is not powerful enough to penetrate the distal fibrous cap of totally occluded LAD, or the, let me say, the stump of the LAD in this case. So it can't. So therefore, I pass a corsair and advance retrograde right up to the total occlusion. Take a reference wire. There is a curve here. One has to be careful. When we took a lateral, we found there is a curve here. Enter that. Enter into the parent vessel. And in the parent vessel, the wire is trapped with the balloon, and we create a passage by the microcatheter traveling up in the direction towards the ostium of the LAD. Change the wire and come now, integrate now from the contralateral groin. I can come back because the wire has come out from the contralateral groin through this catheter, other way, and then dilate with the balloon. Take a regular wire then and dilate it, and this is dilate more, and this is the final result. So I think various techniques are to be applied. And now I should say that of late there has been growing interest in the drug-eluting balloons. The advantage of drug-eluting balloons is obvious because it requires, it eliminates the technique for delivering the stent. There is no metallic jacket. The anti-proliferative effect of the drug continues for more than 6 weeks, and the limitations of CTA angio, which I think is difficult to give any information in a stented artery, and I think it is eliminated. The drug is very often found in the tissue for 3 months. And you know very well that the complications of benign neointima, neointimal hyperplasia, stent restenosis, and stent thrombosis are eliminated. And I think the studies are now ongoing, which one to use, sirolimus or paclitaxel. Dr. Colombo believes that if you have prepared the lesion well and you have released the elastic recoil by cutting balloon and without dissection and a good TIMI3 flow, I think a drug balloon will take over the stent, and you might not have to use the stent in future. This is especially true if you are dealing with a bifurcating lesion, CTO, and the distal lesions. Thank you very much.
Thank you very much, sir, for your very nice and enlightening lecture.
Well, I must say one thing. Somebody asked me, Prakash, what's your achievement in after so many years of practice? You treated hundreds of patients. That's fine, everybody treats. But I feel that my students like you, Prashant Sahu, Tejas Patel, in the various parts of the country and even outside the country, in the United States, keep on doing practice and extending their services to hundreds of patients is my investment which has grown. Okay, your question, Prakash?
Any questions for the sir? Great talk. So I wanted to ask you, so in some of the cases, if we have only antegrade options, you're doing parallel and you're not successful, there are no retrograde options. So if you do a star, for example, in a RCA, you do a star technique, you enter the distal RCO balloon, the whole segment, do kind of an investment. So in how many cases in your vast experience, when these patients come back, you feel that the whole of the RCA is now, it's healed and you don't require stents or you require very limited stents. So what is the follow-up of these patients who you are not able to open the CTO, you do a star and leave the patients alone and bring the patients back? So how many of these patients, how do they do on follow-up?
I'll change your question a little bit. Whenever the wires entered the false passage beyond the distal fibrous cap, within the missing segment, true, false, true, doesn't matter. Not only that, but you can't even know. You can't know because you don't know where you are going. But when you come to distal fibrous cap and you see that the wire has migrated outside, you know you are in the false passage. And from where, we do not know. Now, 2-3 approaches. Star is given up, but ADR I'll talk about. Antegrade dissection and re-entry. What they do is that the stingray balloon, and with that, they enter the wire. Any wire will do, but they have the specific wire which you keep on rotating fast and do this way. Americans feel that is faster and more effective. Although you travel for a long segment into the subintimal passage, what is its impact on re-entry? I personally feel re-entry rate should be higher. When you are true to true, from proximal to distal, I think you have a benefit of a much less restenosis rate. I do not know of any data, but it makes to my logic. It sounds more logical that if you are true to true, then obviously you have reconstructed the real anatomic form of the artery originally.
Thanks for excellent talk. Just regarding the DCB, what we believe is indication in in-stent restenosis, ostial lesions or side branch lesions like that.
Yeah.
Apart from that, what opinion on de novo lesion and CTO and ACS regarding the DCB?
About the two things about the CTO. Yes, compared to a non-CTO lesions, CTO lesions have a higher restenosis in general. Rotablated lesions have also higher restenosis no matter what you use in general. But I think because in Andreas Grunzig's word, Andreas Grunzig, that restenosis is not a complication, it's a sequelae. Many operations are done twice. Hernias are done twice. Varices are done many times. Cataract is also sometimes done with after cataract. So he thinks that as long as the patient is available to you for the further treatment without any damage, it should not be hated. What do you prefer? 2 sticks in the groin or 1 large 6 inches incision on the chest? That the patient has to decide. Okay, now regarding your question.
DCB de novo lesions.
We do not know, but now Dr. Colombo, when he came in, I attended his lecture, he has a series now, and he has shown that the DCB and comparing with the conventional treatment with the drug-eluting stent, he has been finding comparable results. Okay.
Thank you so much, sir. Would request Dr. Prakash V. Parekh, sir, to felicitate our honorable speaker. And would request Dr. Anand Shukla to felicitate our chairpersons. And Dr. Shaurin Shah to felicitate our experts. Thank you, chairpersons and experts. For the next session, which is a online talk, and some of the audience, if they are hungry, they can join for the lunch on the third floor. There is a screen displayed over there for this lecture. And for chairing this session, I would request Dr. Tushar Shah and Dr. Bhavesh Thakkar to come on the dais. And experts in the same session are Dr. Abhishek Parmar, Dr. Anitesh Shankar, Dr. Shaival Majumdar, and Dr. Kunal Parwani. There is a screen display on the third floor in the lunch section. You can attend the talk from there also. Good afternoon, sir. Dr. Ajit Mulasri, sir. Dr. Ajit, are you there? Dr. Ajit, are you able to hear us, sir?
I can hear you. And can you hear me?
Yes, sir. Loud and clear.
Okay, good.
We have in the chair a renowned cardiac surgeon from Ahmedabad, and experts are also two of the cardiologists and three cardiac surgeons. You can start your talk,
Can I put
sir.
up my presentation if you can share, unshare?
Team, please start the presentation. Presentation start, please.
Can you see my presentation?
Just a minute, sir.
No.
Sir, you please share from your end.
Okay. Can you see my presentation?
Yes, sir. Your presentation is seen.
Can you hear me?
Yes, sir.
Yes,
Okay.
sir.
Thank you. Just tell me when to start.
Yeah.
I'm having some echo from your side.
So you can start the presentation.
Okay, so thank you, Jay, for inviting me for this meeting. Unfortunately, I couldn't come there because of the sentient, and I'm presenting from Bangalore. So hopefully you can see my slides. Can you hear me and see my slides?
Yes, sir.
Okay, so I'm going to talk about thrombosed mechanical prosthetic valve management and what is our approach at Madras Medical Mission. So as you know that the valve disease is predominantly in India due to rheumatic heart disease. Though repair of the rheumatic valve is an option, it may not be very good because the mechanical valves are good for durability, but once you have to put the mechanical valve, then you have to anticoagulate them with vitamin K anticoagulants. You cannot use, NOACs for this purpose. The most important thing is to maintain the prosthetic valve function and to avoid the thrombotic complication, and the INR should be between 2.5 and 3 in this scenario. Despite all the dedicated clinics, we still have a large number of patients who will present with stuck leaflets, and the valve thrombosis is high in the mitral and tricuspid as compared to the aortic position, and it ranges from maybe 1 to about 5%. In a tertiary referral center like ours, I get one a week, either referred directly or coming from another center. A guideline treatment consists of giving heparin infusion, thrombolysis, which can be low infusion, and redo surgery. Transcatheter manipulation of immobile lifeless can be pursued if patients are thrombolytic or surgically high risk as a bridge to surgery. Now, if you look at this paper, which was published in JACC, the Hatusha study, you can see the study cohort of 276 patients, but a lot of these patients we had to be not recruited because they were not thrombolysis eligible. And there were a lot who had surgical, so only 2 out of 200 patients, ultimately only 214, that's 1/3 got excluded. And we had a final study population of 158. And if you really look at it, the success was defined in that study as documentation of complete improvement in ball hemodynamics, reduction in major diameters, area of thrombosis, and symptomatic improvement. But none of them had fluoroscopy and CT opening to be checked, because I feel if the CT doesn't show the leaflets are open, then we will be in trouble for the whole thing, because leaflet which is not fully open on the CT will again get into trouble and get restuck. And in this study, obviously, surgery had poorer outcomes as compared to the thrombolysis. And what was used was a slow infusion of TPA for the study. Now, what is the problem? The problem is you have a leaflet, which you usually buy leaflet valves in most of our practice, and the hinges get clots, or the lateral orifice gets a clot. And then what happens is the leaflet gets stuck. You can see on the top the picture live, and here is a cartoon which shows a stuck valve. And the stuck valve can have a clot on the left atrial side or the left ventricular side. And it also can come on the hinge. And what we are proposing here is that we put a wire and coronary balloon across, balloon dilate the hinge, so that what happens is that the leaflet gets unstuck and the clots gets released. Obviously, you have to protect the brain and other circuit with filters so that we don't get into trouble with embolization. And this is how a leaflet will come open after we open the valve out. Now, the research question here is that when you're doing this balloon, will the leaflet dislodge or avulse? Will there be a ring fracture? Or will the annulus deform or malfunction? And if there's a strong bond between clot and leaflet, will it force to release? Coronary and cerebral and other systemic embolism is the next issue. Now, this last number 5 can be easily done by a filter or thrombus aspiration or a transcatheter embolectomy, but the rest is not studied. So our research question started with an animal study or a bench study. Could you answer this problem? And this is the most important thing, because there's lack of information on these areas of what these leaflets are like, what are the sizes in between the leaflet and lateral. Now, how do you check to address this research lacunae? I can take brand new valves and see if they break during balloon dilatation. Unfortunately, they are not a mimic of in vivo scenario where the wear and tear at core body temperature over several years will make the valves a different valve than a new valve. So we can't study it in that way. An animal study has a problem because implanting the valve and waiting for the stuck valve after several years is not feasible. And you won't get an animal to survive that long to get this done. The closer in vivo scenario is to explant mechanical valves during resurgery in humans and then to see how it goes. And this is how you do. This is a 2-year, 4-month-old ATS valve which got stuck. We measure with calipers the interleaflet distance and the lateral orifice distance, and then get a balloon sizing for the valve. Remember, this is very important because you need to have a CT picture of most patients to be completely. Echo is a poor indicator of all this. Now, what we did was we bench tested this right either in the center with a balloon and in the lateral orifice with another balloon. So you can see both the pictures and the videos on the other side in the cath lab on a Sunday. And then we see that when you put on the central balloon and dilate, you can see as the pressure goes up, this is a 10 millimeter Mustang. Normally a 5 millimeter balloon is what you use. And at 12 atmospheres, you'll see that the leaflets start bending. And at a critical point of time, the leaflet you can see will fly away like this. And you can see in the last part of the picture how it flies away from the valve. So this is dangerous. So if you start doing high pressure with big balloons, you're going to land up with that sort of a problem, and the leaflet will fly away. Now, but it is interesting that when you do it on the lateral surface and not in the center, the leaflets just get broken into shreds. And this again, you can see how we are checking in the bench what is happening. And clearly the leaflets gets broken into small shreds when we do this here. So the issue is that we need to have the correct size balloon. We need to have a CT to measure these things. And we started out of desperation in certain patients who were either thrombolysis who could not be given because of stroke or something, or who failed the thrombolysis. You should understand that thrombolysis is not completely safe. The success rates, even with the best low infusion 48 hours thrombolysis, is 85%. 5% will fail and 10% will have bleeds in the brain, and there's a 5% mortality. So it's not a completely safe procedure if everybody says that's okay. And this was the data on 39 stuck valve procedures which we have done since 2020. And let me tell you, these are patients who are surgically rejected because of multiple surgeries in the past or thrombolysis not eligible. So what we do is we puncture the atrial septum just like you do a BMV. Then put the wire, INOE wire down. Then we take a deflectable Agili sheath, which is what we use like in TMBR and in electrophysiology testing, which can be deflected into the mitral valve. We protect both the brain carotid structures with bilateral 6 millimeter spider filters. We could also use the Boston Sentinel filter if you have the money. You could use that. That's also one thing, and you can go radial. We Doppler both upper vertebral, upper limb, and lower limb, and we also check the lactate levels before the procedure. And this is a cartoon of how we do the procedure. The catheter goes through the valve leaflets in the center. There's a coronary balloon, which is 5 or 4 millimeter with a wire. There's 2 cerebral filters here. And this is how the leaflet would be measured before to check on CT what is the size of the balloon in the middle and the lateral. And you can see it's a 4 to 5 millimeter balloon in the center and about 10 to 12 millimeter balloon on the lateral side. So we make the balloon size and then we cross it in the center with the wire and with the directed, and we put a 5 millimeter balloon in the center. And you can see as the balloon goes up, the left atrial pressure will start suddenly going up because there's free MR, and the patients will develop usually pulmonary edema. Most of these are ventilated patients, so you can see the LA pressure going up, and you can see then the leaflets are getting open. So there's a complete release of the leaflet, and both the leaflets are moving well. And we measure the angles, and this is very important because the measuring of the angles is the most important thing that the leaflet is. So you can see this leaflet has moved in systole to diastole and come back, but this leaflet has not in the pre-situation. But in the post, and you can see here that in the post, you can see both the leaflets are open, and then once you release the clot, then the leaflets come back to position and the gradients drop. Remember, even one leaflet opening up will drop the gradient. So gradient is not a great indicator, because if the other leaflet is still stuck, you're going to get trouble with the whole problem. 30% of our patients will have debris in the brain caught on the filters or the sentinel. And so you cannot do this procedure without a cerebral protection. We also look at Dopplers of both lower limb and upper limb just to check there's no embolism, and we look at the ECG to hope that there's no coronary embolism, and lactates for mesenteric artery. So these are the various valves we have checked. You have the carbomedicus, the ATS-AP, St. Jude, all that sort of valves. I don't want to go through all that. But we first published our first paper of 6 patients in structural heart for the mechanical at the mitral position. And this was in 2020. Then we published the next 6 with aortic position in JSCI. And you can see the stuff. It's not necessarily clogged. And the final big paper we published in Circulation this year for patients with this problem. So this is the big paper in Circulation, which we have now published for patients who are not eligible for lysis and surgery. And this was a Petros. Petros is a short form for percutaneous release of stuck valves. We can do a primary in patients who have a contraindication for fibrinolysis, or who are not willing for fibrinolysis, or you have a rescue where there's a failed fibrinolysis or stroke during lysis. And we have followed these patients for 48 months. And these are the various leaflets. And what I conclude is that you have a 92% success in this. We had 2 deaths. One was a sudden death on follow-up at 1 year, and one was a death who had a vertebral stroke. And that was not protected with our filters. The recurrence is there, but you can fix it either by reintervention or fibrinolysis, and a repeat Petros is performed in 2 patients. The most important thing is that the gradients are great at follow-up of 4.7 mean, and the ejection fractions are slowly getting better, and the right ventricular pressure and TAPSE are coming down. This is a Kaplan-Meier curve showing a very good success rate of 92% at 2 years. So what this showed was that mechanical valve thrombus has been clinically treated by surgery or fibrinolysis in high-risk surgical patients. What this adds is another method of releasing these patients if they are not candidates for either of these. This was a letter to editor which came from the Hattusha study primary investigators suggesting that thrombolysis should be preferred, and we agree with that because all centers cannot do all these complicated procedures. But what we need to show is that 1/3 of the patients on the Hattusha trial could not be included because they already had a stroke or a lysis failed, and that's what we said. And the filters only protect both this brain circulation, the carotid territory, but there are new epi-aortic filters coming in which could protect the whole circulation in this issue. So this is my conclusion. I hope this gives you an idea of what's happening in this area, which is new technology. And I think that today, last month, there is a JACC review on stuck valves, which has now made it a 2B indication to do this procedure. And it's part of the reference is our work, which we have done. So I'm happy to say that many centers in the US, Israel, Brazil, and India have started doing these procedures, which is an option. We're also running a randomized trial head-to-head, ultra-flow slow lysis versus a primary Petros. And we have recruited about 40 patients on this study in a single center. Let's see how it goes. Thank you very much. And if there are any questions, I'm happy to take.
Thank you, Dr. Ajit Manasri. First question is, how do you decide that whether it is a real thrombus or it is a pannus formation, particularly for the aortic valve?
That's very important. So the CT is mandatory. So you check the HSU units of the stuff which is sitting on the valve. Echo is no good for this. If the HSU units of the stuff behind the valve is less than 130, it is thrombus. If it's more than 240, it is pannus. If it's between that, it could be pannus or thrombus. Again, if it's a small pannus, there's no need to worry. We can still fix it. It will still open. But if it's a large pannus, it cannot be done, and they have to go for surgery.
Rajit, this is Dr. Tushar. I am a surgeon.
Yeah.
Any surgeon who has operated on stuck valves faces a dilemma whether to declot the valve or change the valve. And most of the times, surgeon doesn't want to take a chance and he changes the valve. How about the same argument being applied to your patients? One. And second, how many of these 30 patients were sent for surgery and why?
Oh, let me be very clear. This is a preliminary study, and the approval from the ethics committee was for no. These patients had either 2 surgeries or 3 surgeries and clear surgical rejects, or 2. They had lysis failed, or had a clot or the thrombus having a stroke, and they could not be lysed. So these are the only group of patients we recruited. We are not talking about patients who are clear-cut surgical or clear-cut lysis. Those are not the patients included in the study. Number 2, I understand your concerns that as a surgeon, when you see it, sometimes it's so full of stuff. You sometimes remove it and change the valve completely, and you're now dealing. But here's a bailout procedure. We are talking about a patient whom you bail them out, and then you have a chance to do something later. You could do surgery later. You could do medical treatment follow-up, and you can delay a surgery for the future. So that's the plan.
How many patients were subjected to surgery out of these 30?
So none of the patients in this 39, because they are clearly surgical rejects, so they cannot go for surgery. So there was no question of surgery. But we have now a 151 patient registry in the hospital, where we had 32 patients going for. But these are stable patients. That is a different subset of patients where the surgeon is comfortable doing them if they are not multiple surgery patients. And we have almost 100 plus patients who have been lysed, which is still our primary mode of treatment till we run the randomized trial and prove that either is effective or worse.
Have you tried in unileaflet valves, TTK
Yeah.
valve?
Yeah, the unileaflet valves have different. We have less patients on this study on unileaflet. We have only 3 out of 51. These, as you know, the Medtronic Hall was a common one which we used to see. They are really good valves, to be very honest. We see less thrombosis there in those patients, but you need only 1 balloon in the lateral orifice to open it up. And they do as well in the mitral position. Remember, in the aortic position, because it's a high flow situation, the procedure is not as successful as in the mitral. We got only a 70% success in the aortic position. Most of them are pannus because being high flow, when they present, it's usually hard pannus, which the surgeon has to get out of the whole thing.
Thank you.
Thank you.
Thank you, Dr. Ajit. A big round of applause for him. Thank you, sir, for presenting this talk. Thank you so much.
Yeah.
This is Jay Ajit sir. Thank you so
Hi,
much
Jay.
for spending your valuable time and giving us a very lucid talk on stuck valve and how can we treat it percutaneously. Thank you so much.
Thank you, Jay. Sorry for not being there, but I was busy with Sentient, so I couldn't be there. Thanks. Thank you.
Thank you. I would request Dr. Jay Shah to acknowledge our chairpersons and felicitate them, and Dr. Dhruv Jadeja to felicitate our experts. And after this ceremony, I would request Dr. Jay Shah to speak. Thanks.